we can hear you clearly and loud. It's very clear.
We can hear you also clearly, Sitanshu.
Yes.
I can hear Himanshu also very clearly.
That's nice.
Sridhar, good morning, Sridhar.
Good morning, sir. Good morning.
Good morning.
Good morning, Dr. Kadam.
Good morning. Good morning.
Dr. Atul Kotwal sir has joined.
Good morning. Good morning, everyone.
Good morning.
Good morning, sir.
Good morning, sir.
Good to see you all on a bright Sunday morning here.
Thank you for joining us, sir. It was a pleasure to have this panel in Iphacon 2021.
Thank you, Dr.
Both Dr. Atul and I thought that this would be very relevant, deliberation. So let's see.
So we are 6 minutes away from the session. Good morning, Mr. Dhillon. Thank you so much for joining us.
Good morning. I am so sorry for being so late and being difficult. Thank you.
No, you're.
Himanshu, do we need to send link to Anup once more?
I have sent the link again to Dr. Anup. I'm on the phone with him, sir.
Okay. Has Anup joined then?
Good morning, Dr. Anup. We can see you.
Good morning, Himanshu. Good morning, sir. I have joined already. Can you hear me, Himanshu?
Yes, Dr.
Doctor.
Anup. Yes,
Yeah.
yes, you were able to.
Oh, thank you very much.
Yeah.
I was slightly caught up with so many links, actually.
Not a problem, not a problem. Once you are in, that's fine.
Just give me a minute, please.
Sitanshu sir, are you there?
Yes, I'm there.
Sir, can we start?
Yes, it is 9 o'clock. Let's start. Let's get started.
Okay, sir. I'm giving a countdown. 5, 4, 3, 2, 1. We are live.
Good morning, everyone. I welcome you to the 65th, the day 4 of the 65th Annual National Conference of Indian Public Health Association, conducted in jointly by the IPHA State Branch Pondicherry and Department of Preventive Social Medicine and Jipmer International School of Public Health in Jipmer, Puducherry. So I welcome you to the 12th plenary of this conference. The title of this plenary is Human Resources for Health, Shaping the Agenda for Better Tomorrow. As you all know, the theme of this conference is public health more than ever now. And we have 3 sub-themes for this conference. One, the first day we discussed about the effect of COVID-19 pandemic on health system. And on the day 2, we discussed about the public health actions that should be taken to mitigate the effect. On day 3, now in this track, we are going to talk about the capacity building activities and how we should prepare ourselves to meet the future challenges of the pandemic. So in this regard, we are going to start the session with a very interesting plenary that we are having with us today on human resources for health. So it is my pleasure to invite the chairpersons for today's session. The first chairperson is Professor Sanjay Jodhpe, Vice President, Academics, Public Health Foundation of India, New Delhi. And the other chairperson we have today is Major General Professor Atul Kotwal, Executive Director, NHHRC in New Delhi. So to introduce Dr. Jodhpe, the details of Dr. Jodhpe in the field of public health needs no introduction. Thank you so much, sir, for joining us. Professor Jodhpe completed all his medical education like MBBS, MD and PhD from Government Medical College, Nagpur, India. He has also acquired postgraduate qualifications in sociology, public administration and economics from Nagpur University. Professor Sanjay Jodhpe presently works as Vice President Academics in Public Health Foundation of India, New Delhi, and also holds leadership position as Director at Indian Institute of Public Health, Delhi. He also holds joint appointment as honorary or adjunct professor in 5 international universities. His initial research work mainly focused on occupational health, infectious diseases, and vaccines. He is currently engaged in several research projects related to maternal and child health, vaccines, and human resources for health. Lot of awards and fellowships to Sir's contribution. And Sir has authored more than 400 scientific publications in international and in Indian peer-reviewed journals. Thank you so much, Sir, for joining us today. Now let's go to Dr. Major General Professor Atul Kotwal. It's our privilege to welcome Sir to this session as Chair. Sir is currently Executive Director of NHHRC, New Delhi, medical professional by occupation, public health researcher, administrator, educator with significant contribution in the field of public health, epidemiology, administration and research, teaching, mentoring in a career spanning over 36 years. It's a privilege to have you here, sir. He has received his MBBS followed by MD in Preventive and Social Medicine from Armed Forces Medical College, Pune. He also holds a postdoctoral fellowship in epidemiology, specializing in health systems, primary healthcare, epidemiology, implementation research, and interdisciplinary research. Dr. Kotwal has a vast experience ranging from serving in the armed forces across the levels of medical corps to being an advisor for public health in Botswana, Africa. In his tenure as OSD to Planning Commission, Dr. Kotwal was actively involved in planning and finalizing the 11th 5-year plan, review of NRHM, and conceptualizing urban health. Dr. Kotwal has received numerous awards for his contribution to the armed forces and towards his professional and research achievements, including Sena Medal and Vishisht Seva Medal, 8 Best Research Papers Award, and 2 Best Research Projects Award. He has also been awarded as the prestigious Dr. J.E. Park Oration by IPHA. Sir has got more than 120 publications in the Index Journal. It's really a matter of pride for all of us that we have got such illustrious illuminaries who are present over here to discuss about the issues of human resources. Thank you so much. I'm sure the 1,500 delegates who have registered for this conference, and as it is being live, coming live in YouTube, many more are joined us online, will be immensely benefited from this plenary session. Thank you so much, sir, and over to you.
Thank you, Dr. Sitanshu, and let me first welcome all the participants for this annual National Conference of Indian Public Health Association, which provides the platform for discourse and disquisition on very relevant and important public health issues for our country, in the region, and in also a global context. Thank you for inviting me and Professor Atul Kotwal to chair this session. This is a very interesting session, and what we would do is that we would be focusing on our discourse related to human resources for health, which we articulated as shaping the agenda for a better tomorrow. You would all appreciate and agree that human resources for health are a vital building block of the health systems. And therefore, strengthening HRH is a prerequisite to a very strong, robust, and resilient health system. A sufficient, equitably distributed, adequately supported, and well-performing health workforce can certainly help us and the country meet its health goals and targets. The global strategy on human resources for health, that is Workforce 2030, also noted that an enhanced investment in the health workforce can deliver a triple return of improved health outcomes, global health security, and economic growth. And we have some discussion related to this today. Investment in health workforce is a driver for progress towards several sustainable development goals. The UN Secretary General High Level Commission on Health, Employment and Economic Growth, that report which has been available, also highlighted several issues in this context where it has brought policy attention and increased investments in respective countries. The Indian health system has strategically advanced multiple initiatives to address the HRS challenges that we are confronting in our country in the states. The National Health Policy 2017 also very clearly articulated the intent and the thrust areas identified by the Government of India in the context of how do we advance the HRS agenda. Several initiatives have also been undertaken by the state under the aegis of initially NRHM and now the National Health Mission. And therefore, we thought that it would be relevant to deliberate on the human resources for health, focusing on variety of the aspects in the context of current discourse today. We have four speakers today who would be speaking on. We would begin with Dr. Ibadat, who would give us the global scenario for HRH. And then we will have Dr. Himanshu coming in to tell us the size, composition, and distribution of HRH in India. And this is the recent work that we had done along with the World Health Organization, which will be shared with you. Then Dr. Sridhar Kadam will bring a state experience in the context of HRH management and initiatives. And then the fourth one, Dr. Anup Karan, would highlight on investing in HRH and how much and where to invest, which remains very critical for us. And then we will, of course, take some interesting questions from all of you. Before I request the first speaker to come in and formally introduce, I would request Major General Professor Atul Kotwal to offer his opening remarks, and then we will move ahead with the session. Over to you, Dr. Atul.
Thank you, Dr. Sanjay. Good morning, everyone, once again. It's really a pleasure and honor to be here amongst you all. And I must compliment the Public Health Foundation of India and the organizers of the conference for organizing this session. And the importance given to this human resources by the organizers is clearly evident that a senior professor like Dr. Sudhanshu Kar is here with us, moderating the session. I request Dr. Kar, you be the third chairperson instead of the facilitator. We'll all learn from your experience in this preventive medicine. I think Dr. Sanjay Zodpe aptly covered the importance of the human resources and the why we need to focus on that. And there's no need to repeat, but just for the sake of all the participants who are listening into this session, when we look at the human resources, we know that yes, out of the 6 building blocks, this is the most important. The others can't function without this essential building block. And we also have to look at the quality and the safety and all other issues also when we look at human resources, because we can't have, it's not only the quantity of HR we're looking at, we're also looking at the quality of HR, which then leads to the further outcomes in terms of patient safety and quality of healthcare. So we need to look at that and clinical governance issues. And also, the dealing with the various the epidemiological transition all over the world, and of course in our country especially. So the Ministry of Health and same as under NHM initially, that was actually one of the game changers where we started looking at contracting in healthcare workers, and almost 4.5 lakh have been contracted in from 2005 onwards, which is a tremendous achievement. And this is not counting the 91,000 only during the last 1.5 years during COVID, out of which 42,000 were because of for non-COVID, and 50,000 were for COVID duties. And the capacity building for the states, which is going on, and the amount of funding which is given to states for this. But of course, this also has the other aspect of this, that probably the states are not looking at filling up the permanent vacancies. Then I just highlighted 2-3 important issues. We'll discuss it further as we proceed during the panel discussion. So back to you, Dr. Sanjay Zodpe. Thank you.
Thank you, Professor Kotwal, for the remarks. And let's move on to the session then. And we will have the first speaker, Dr. Ibadat Dhillon, and he will speak on global scenario of human resources for health. And let me introduce briefly Dr. Ibadat Dhillon. He currently is serving as the regional advisor on Human Resources for Health for the World Health Organization's Southeast Asia Regional Office. He recently moved from headquarters to the Sierra region. He has previously served in the Department of Health Workforce at the World Health Organization headquarters and as a health sector advisor for the Danish government, the Irish government, and the United States Center for Disease Control and Prevention. And he has worked with Aspen Institute Realizing Rights Program. Mr. Dhillon has graduate level training in international law and public health. Mr. Dhillon's work focuses on human resources for health and health systems at the national and global level. But in addition to this, which is a formal introduction, I would like to mention that we have been very closely interacting with Dr. Ibadat. And one thing which is clearly reflected is basically his passion for health system strengthening with focus on human resources for health. He's such a passionate person about advancing the agenda of human resources for health. It would be an excellent opportunity for all of us to listen to him in global context. What are the initiatives in relation to the HRH which are taken? So over to you, Ibadat.
Thank you, Dr. Zotpi. It's a privilege, and I say a personal honor to speak at the 65th Annual Congress of the India Public Health Association. So thank you. I will try to keep my presentation short. If the Secretariat could put it online.
We're just putting it.
Yes, thank you. And I will try to go through it quickly. Really, I think this has come at a very important time, especially given these ongoing and successive waves of the COVID-19 pandemic. It has really made us all think about how can we shape a better tomorrow together. And I will present a quick global and regional, honestly, just a snapshot that can help our discussions forward. Next slide, please. At WHO, we use something called a health labor market framework for universal health coverage. It really points out that as we think about achieving universal health coverage, we have to start thinking from the very beginning of the formation of health workers. So really from the production, the education of health workers into their employment and all the different policies that address it. One point that I want to make here, and I think that's really important, is that we must recognize that the goal is not just universal health coverage. The goal for health workforce education is also driven very strongly by economic, commercial interests, by trade interests, by interests even in foreign affairs, and by education interests. So this contributes to a significant complexity in the discussion on human resources for health. Next slide, please. For us in the public health community, for us at WHO and in CERO, and I think, and of course, the audience today, UHC clearly is our guiding pole. The right to health is our guiding principle. And I think this is really important to keep in mind as we discuss issues around human resources for health. The Southeast Asia region is home to almost 2 billion people. Over the last decade, and indeed last few decades, we have seen continued improvement in the coverage of essential services across the region. We saw reductions in extreme poverty. Yet at the same time, we must recognize that until this moment, the Southeast Asia region had on average the lowest public spending on health and the highest share of out-of-pocket expenditure across all WHO regions. So it's a real issue with over 300 million people estimated to experience catastrophic health spending annually. So there's even before COVID, there was a very, very big challenge in trying to getting access to people to essential health services. COVID has really hit the Southeast Asia region very hard. It has simultaneously increased financing requirements and introduced unprecedented economic financial pressure. The World Bank in early 2021, this is prior to the second wave of the COVID pandemic across the region, had estimated that of the 60% of the approximately 120 million people who were pushed into poverty in 2020 resided in South Asia. So really, I think the magnitude of the challenge in the region to address this issue is very substantial. At the same time, earlier this month, beginning of this month, the 11 ministers of health from the region came together. We had quite intensive discussions on COVID-19 and the opportunity to build back better. And indeed, they have signed a declaration, and I would recommend others to go to see this declaration, and where they have highlighted that what it stands in front of us is not just an opportunity and an imperative, but it's a once in a century opportunity. And they have committed to strengthen public investment in PHC-oriented health systems. And I will come back to this later. Next slide. COVID has also shown us very significant challenges across. We knew this even before, as we were moving from the MDGs to SDGs, challenges on deficits, inefficient investment, inequalities, mismatch between education and need, poor data, resistance, limited stewardship of the private sector, poor working conditions. So these have just become more prominent now under COVID. Next slide. Similarly, I think Major General Dr. Atul was speaking about these very significant forces, again, before COVID, that were putting huge pressure on health systems and on the health workforce, including aging, multiple morbidities, NCDs, climate change, migration, urbanization, and very importantly, the rising expectation of citizens and the rising costs of healthcare. Next slide. And in CRO, I will not spend too much time on these, but this is the latest data available at WHO across all countries. And we can see that Southeast Asia remains the region with very low density of medical doctors, of nursing and midwifery personnel, of dentists, of pharmacists, even though sometimes the region is seen as the global supplier of health workers for the world. Internally, it is still has low numbers of health professionals, and it's important to recognize in that last slide that while we're discussing doctors, dentists, pharmacists, there's a very important contribution in the region from medical assistants, from community health workers, from traditional medicine providers, and importantly, from informal providers who are unqualified. In some studies, we've seen that up to 1/3 to 1/2 of health workers at the PHC level are informal and unqualified. Very important issues on distribution across the region. I won't go into the details, it's there. Next slide, please. And very significant issues on quality, especially at PHC level. There have been numbers of studies on this. I will show two by Dr. Jishnu Das. And really, if you look at the middle column there, these are based on clinical vignettes on different disease aspects that were provided in different countries. And across countries, you can see very poor diagnosis of basic disease conditions and lots of unnecessary drugs given even in those conditions. So very serious issue of quality, especially as we go out into the PHC level. Next slide, please. Similarly, we talk about occupations and professions, but again, very big challenge across countries and including in India around the quality of the health workforce, again, through clinical vignettes used. And in some cases, we are seeing, for example, that Kenyan nurses are adhering to checklists to a level that is higher than medical doctors in other places. Similarly, in India, the study looked at the use of MBBS doctors versus non-MBBS doctors. And again, the adherence to checklists ranges quite widely. So again, the issue of quality. Next slide, please. I quickly wanted to touch on the issue of health practitioner regulation, because again, if we think about the construct of the health labor market, one of the key levers within government, but it's a difficult lever to use, is that of regulation. And health practitioner regulation is a core mechanism to mediate the health labor market and to try to ensure health workforce availability, accessibility, acceptability, and quality. Across countries, we can see that it is being used to look at the numbers and types of health workers produced, the quality assurance of education and practice, the location and costs of education institutions, distribution, scopes of practice, approach to unregulated occupations, etc. But often in very piecemeal ways. And health practitioner regulation and reforms have not always aligned with health system needs and service delivery priorities. And this is now we have come to the COVID-19 pandemic. Next slide, please. As public health professionals, as we look at health practitioner regulation, we also have to start asking what is the public's interest. In the early, almost 100 years ago, the idea was that elevating the profession was the same as elevating the public's interest. Over the last 100 years, there's been very significant thinking around this and recognizing that actually health practitioner regulation today must align much more closely with health system needs. So we have to look at the costs of regulation, the capacity of regulation, its efficiency, its ability to increase cost effectiveness, its ability to reduce unnecessary entry barriers to the profession, to promote competition, and to regulate proportionate to the risk. So these are really, so this is a very dynamic area that's changing, but it's a challenging area to work in. Next slide, please. We can see also that very significant reforms have been taking place across countries. I won't go into detail. I think colleagues in India would be very aware of the very significant reforms happening in India, and it would be important to follow these in the years ahead. But it is not just here, it is happening across countries and all linking more closely to the health system need. Next slide, please. And then we come to COVID. COVID is really important because under these, often under emergency acts and temporary authorizations, across countries, there were a lot of regulatory flexibilities and adaptations really to address what was this massive emergency. And so we saw flexibilities in the way education was formed, in the way we were looking at entry into health worker practice, into scopes of practice, international mobility I will come to, and then the use of telemedicine. And some regulatory systems that were more closely aligned to the health system, such as in Afra, where they were actually where they were overseeing all the health occupations, were very quickly able to use their regulatory mechanisms to support the surge workforce. At the same time, this period has shown us that data on the active health workforce was missing in many, many low and middle income countries. And things like what Australia did was simply not possible by other regulatory bodies. And at this moment, there's a real opportunity to also use vaccination data that is being collected on health workers to actually get a better sense of the active workforce across the region. Main point here really is that as we are moving out of this temporary situation, it will be critical to evaluate which of these flexibilities are able to advance health system goals without compromising patient safety. So this will be an important issue to, again, continue to look at. Next slide, please. And then we come to the issue of international mobility, which is so important. India, for example, it is something that has been rising over the last 2 decades. This is data from OECD countries. And India is indeed the #1 provider to the OECD of doctors and the second largest provider of nurses. So it's a very significant issue and it's growing in scale. Next slide. Oh, next, just quick clicks. Sorry for the, if you can click quickly through this. Yeah, this is simply showing that the demand for health workers is very prominent. It's increasing. Next, keep clicking, please. One more time. Yeah, and this again, it's the demand for health workers is rising, not just, and this is before COVID. It's not just rising in the rural areas, for example, in India or other Southeast Asia regional countries. It's expanding at magnitudes worldwide. And these are just some numbers that highlight this. The European Union, for example, has identified that they need an additional 1.8 million health workers by 2025. Germany, similarly, 500,000. These are all linked to demographic and epidemiologic transitions in wealthy countries, and is putting a huge pressure on the global health workforce. Next slide, please. And in COVID-19, we just saw a further exacerbation of this. Indeed, at the Assembly, World Health Assembly last year, there was a big discussion on what some called a global scramble for health workers when COVID hit, and some identifying it as a race to the bottom. So for example, during the same time that we had COVID, we had lots of countries working to ease the process of entry, setting up recruitment fronts, expediting visas and qualification recognitions, etc. While others were trying to limit the movement of health workers overseas. Next slide. For this audience, it will also be important to know that very major economies have come out with new approaches for the international recruitment of health workforce. This is important to especially the Commonwealth countries, is this revised UK Code of Practice on the international recruitment of health personnel. The UK recognized that it will need to massively expand its international recruitment, but has committed to do it in a more sustainable manner, where it will try not to exacerbate any existing domestic workforce shortages and actually try to support some of the benefits in countries. And this is again an area where we can discuss how to make this happen better. The European Union similarly has identified health, medical care, and agriculture as major areas of skills shortage in the European Union. So it's really health and agriculture workers that they're looking for. And again, trying to build some more at least they have articulated they want to build more sustainable talent partnerships. So this will be again important to follow. Next slide. And really, I think I would just conclude by coming back to the first slide on universal health coverage. We have a real moment to try to build back better. And as we build back better, we have more and more recognition that for both managing the COVID-19 pandemic and for delivering essential health services, we need to start thinking about really strengthening and reimagining primary healthcare after COVID-19. And central in all the visions and documents, we can very well see that a well-supported and distributed multidisciplinary primary healthcare team is central to this vision. It's not easy to do, but it is the direction is quite clear. And thank you, and sorry for rushing through these slides. And I leave it hand it back to Professor Sitanshu. Oh, sorry, Dr. Satbay.
Thank you, Ibadat, for this wonderful articulation of the global and regional challenges in the context of human resources for health. It's a very comprehensive presentation, and we very much appreciate all related issues being highlighted by you. What we would do is that we would take up the questions from participants at the end of all the 4 presentations. So may I now have the next speaker, Dr. Himanshu Nigandhi, who would be speaking on size, composition, and distribution of health workforce in India. And can we have Himanshu's slide for present introduction? Yeah. Dr. Himanshu Nigandhi currently works as additional professor at Indian Institute of Public Health, Delhi. This is one of the PHP institutes located in North India. He has close to 14 years of experience in public health practice and research. Dr. Himanshu is alumnus of PGI Chandigarh and subsequently trained in clinical epidemiology at the University of Sydney. He's a well-known expert in implementation research, monitoring and evaluation, impact evaluation particularly, and systematic reviews. He also participates quite significantly and contributes to the global evaluation and monitoring network, which is a network of 11 countries and contributing to the areas of monitoring and evaluation. He has several research projects from conceptualization to implementation and analysis. Currently, he is leading one of the very important initiative of how do we use district hospitals for rolling out postgraduate medical education, which has been recommended as part of national health policy. He is another person that in group today we have as a passion for human resources for health. So over to you, Dr. Himanshu. Himanshu, are you able to? We are not able to hear you.
Himanshu is there any connectivity issue?
So Dr. Himanshu is not here right now.
Maybe he's facing some connectivity issues, sir.
Yeah, so we can then move on to the next speaker, and meanwhile, then I will speak to Himanshu also to join. So we have next speaker, Dr. Sridhar Kadam, and he will speak to us on HR management initiatives, particularly exemplars. Or Himanshu, are you back? Okay, so I will request Dr. Atul Kotwal to introduce Dr. Sridhar Kadam and take the session forward.
Yeah. Hey, Dr. Notpe. So it's my privilege to introduce Dr. Sridhar Kadam, who is currently the additional professor and deputy director in the Institute of Public Health, Bhubaneswar, one of the institutions of Public Health Foundation of India. He's got more than 13 years of experience in public health, and he has various awards and contributions towards teaching, research, and advocacy in the health systems, human resource management, and health policy, and also developing and delivering various short and long-term capacity building programs, especially for workforce working in government systems, which, as you just heard, Mr. Ibadat, that the primary healthcare team that and quality issues. So this capacity building is one of the important contributions by Dr. Sridhar Kadam in this towards this. And he has several PFHI research projects specifically focusing on health systems, healthcare financing, human resources, and access to healthcare and inequity. So over to you, Dr. Kadam. Looking forward to hear from you.
Yes, good morning to all, and thank you, Professor Kotwal and Professor Zote. Thank you, Dr. Sutanshu and IPH for giving me this opportunity to share our experiences, especially from the Odisha state. So can I have my presentation, please? Or should I share?
Dr. Kadam, you can share from your side. You can share it if it is not very inconvenient.
No problem. Is it visible to all?
Yes, we can see the presentation. Please make it full screen, presentation mode.
Yeah, thank you so much. So I work in the state of Odisha, the beautiful state in the eastern part of India, with very beautiful people here. And I'm going to share, there are several innovations done in HRH in Odisha. I'm going to share one of them, that is about development of public health cadre in Odisha. And I would like to first acknowledge Dr. Mahapatra, Additional Director, Government of Odisha, who took forward the agenda of implementation of public health cadre in Odisha. So I would, because individual level care and population level care. So individual level care generally the doctors provide, but the population level planning, monitoring, implementation, and for which we require public health and management approach. So that is the need for developing public health cadre in any state, and how we did in Odisha. I'm going to share our experiences. So there are post-identified clinical specialists like gynec specialists, pediatric specialists, but not for the public health specialists. So public health posts largely managed by clinical specialists without any training on public health. That story goes on in any state, but it was going on in Orissa also. There were limited opportunities for monitoring public health education in the state of Odisha. There were only 3 medical colleges, and there were only MD community medicine courses in these 3 medical colleges. And there was no separate clinical and public health. There is not necessary separation, but there was no public health cadre kind of thing in that. The speciality of Odisha was that there was around 2009, 2010, there was a establishment of exclusive cell called State Human Resource Management Unit at Directorate of Health Services under the Department of Health and Family Welfare. Simultaneously, there was establishment of IIPH Bhubaneswar, Indian Institute of Public Health Bhubaneswar, one of the institute of PHFI, with an MOA with the state government for providing courses on public health and undertake public health and health system research. So there was a study conducted by IIPH Bhubaneswar on career progression of government doctors in Odisha, and it revealed that overall limited career opportunity for doctors with delayed first promotion. It was around 26 years of experience. The doctors used to be the first promotion. Clinical specialists, they were holding the public health management post, and they themselves, when we conducted in-depth interviews, they themselves told that they are neither interested nor competent for undertaking public health management work. So there were no clear career progression for public health specialists. And there was, everybody said that there is a need of developing public health cadre in the state. Even the clinical specialist said that there is a need of developing public health cadre. And there was established evidence. First 2 doctors went to All India Institute of Health and Hygiene and Public Health and NI Chennai for these public health courses, and they were better in dealing the public health issues uh, in public health system. So this was studied by NHSRC and IIPH Bhubaneswar, and there was clear-cut evidence that training in public health was useful to effectively manage the public health system. So the process started, and then discussion initiated with consultation workshops on public health functions. So first, all of us came together, IIPH, other public health institutions, and then government officials and other stakeholders, and started consultations on public health functions. We listed the public health functions at each level, and then asked the question, who will undertake these functions? And the need was established again. There were exposure visits to Tamil Nadu and Maharashtra, who are well in advance in developing public health cadre and implementing it. There are a series of expert consultations held national levels, like Professor Zotpe guided us, and Professor Dr. Salunke and other people stalwart in Tamil Nadu, they guided us. And draft document was prepared, that public health cadre in Odisha. Series of meetings were conducted with policymakers at highest level, like Development Commissioner, Chief Secretary, and Honorable Chief Minister, and the decision was taken to create public health cadre. So this was the restructure. So it doesn't go alone. It has a combination of things. So our study was emphasizing on weak career progression. So there were posts created. If you could see, additional director 1, additional director 2, from 29 to 374, these will go in pay band 4. So more posts were created, not only in public health, but clinical cadre also. So that they can have a better career opportunities. And then the posts were assigned to public health at each level, and around 578 posts were created for to be only for uh, people who are trained in public health. So like this was the career progression. So MBBS graduate. So this cadre first started with, because the public health or medical things are mainly dependent on doctors. So it started with doctors, but the post of allied health professionals was also aligned to public health and clinical health. So MBBS, so they work as class 1 junior branch at PSC New, and they get opportunity PG or diploma in clinical health and public health. So at CSC level or block level, then he or she becomes block public health officer, and the people who are trained in clinical services, they become the specialist, and then they become a DPHO, joint level, at district level, and they become specialists, and at district level, a district medical officer and district public health officer. And it was called chief district medical officer. It was renamed as chief district medical and public health officer. And then there is a common cadre of directors and special secretaries. So at state level, in Odisha, only that technical specialist can reach up to the additional secretary level in the Department of Health and Family Welfare. So there was a special secretary post. There was only one post. So under public health cadre, they were created special secretary medical services and special secretary public health, and then comes the directorate, and there are several directorates including director of public health. And there are other posts as usual in any other state. uh, Especially we have the MDO SMCL, particularly looking after the supply of medicines and instruments. At district level, so chief district medical and public health officer is a common post which take care of public health and medical services. So before going to this post, they are trained. The government of Odisha has innovated a 3-month certificate course on public health. So they are trained, because at this level, generally clinicians are reaching, because there is not critical mass of public health specialists trained in Odisha. Now there are around 160 people trained in public health, but we have to go a long way. So to meet that need of the head of the district having the public health knowledge and competencies, government of Odisha undertakes a 3-month certificate course for these people. And there are DPHO, district public health officer, and there are other departments section under him, and there is district medical officer. So district medical officer takes care of the clinical services at district hospital and the community health centers, and DPHO undertake all public health activities and supervises the work of block public health officer. So at block level or CSC level, we have block public health officer, and at the CSC level, we have a specialist. So there were again there was only one post at the CSC level. They call it as medical officer in charge, but now there are 2 posts. One is public health officer trained in public health, and specialist, they call it superintendent, who's take care of the 30 to 50 bedded hospital at the CHC. So this is kind of structure revised to manage the clinical and public health services in Odisha. It was appreciated by various meetings in the government India level. There are opportunities to improve it further. We need to reach the critical mass of public health specialists in Odisha. But this is the start around 2016-17. It has started implementing. So now the clinical specialists are posted only on clinical posts, and public health specialists are posted on public health positions. Thank you very much.
Thank you, Dr. Kadam, for sharing this excellent work. In fact, I'll just quickly I'll share with everyone who's listening in. We have finalized the public health management cadre, because the HLEG, as you all are aware, mentioned public health cadre, but NHP 2017 mentioned public health management cadre. So we have finalized that. It has been approved by the Secretary Health and Family Welfare. We have yet to make the presentation to Honorable Minister, which is going to be organized very shortly. And then we will be releasing it to states and support states in the creation of a public health cadre. So we have looked at 4 streams. One is the clinical specialist cadre, other is the health management cadre, and third one is the public health cadre, and the fourth one is, of course, the teaching cadre, which we have not touched in our report as such. And Odisha and Tamil Nadu were the main states where whose models we looked at while finalizing that. Dr. Kadam has been working closely with our team, with the PHA Public Health Administration and HRH team in this. Thank you. I think I can see Dr. Himanshu. So back to you, Dr. Sanjay, for carrying it forward.
Yeah, Dr. Himanshu, can you have your presentation? Yeah.
Sure, sir. I'll share my screen. Thank you very much, sir. So very good morning to everyone. It's my pleasure and indeed a privilege to be here in front of this august audience to present some of the work that we've been doing around size, composition, and distribution of human resources of health in India. So what I'm going to present to you is not work which is in isolation in India. In order to understand how our size is growing and how the distribution and the challenges that we are facing are very similar to those that are challenges faced by several other countries. And as part of a global response, the past 1 decade has seen several seminal reports issued at the global as well as at the country level, which have talked about a coherent and a systematic response to address HRH challenges. At a very fundamental level, the gap of health professionals is large and is expected to grow even larger. There are 2 primary factors which are driving this shortage. One is a growth in the population, and second is an increased demand for services. So this gap is expected to grow to nearly 53 million by 2030. Demand-based results suggest that this actual requirement of health workers at the global level will be as large as 80 million, and which is going to throw up several challenges in front of us as a global public health community. But let me put it across that beyond the size and the distribution, which is part of the domain of workforce shortage, there are other challenges which deal with skill mix, maldistribution, work environments, and also about the knowledge base about the health workforce as such. Some of the work that I'm going to talk about is primarily driven by work that we have done and which has been published in the BMJ Open, and then a revised work which has been published in the Human Resources for Health. So I'll be sharing some of the data about the size, composition, and distribution from our work which has been published. At a broad level, the size of the health workforce in India, as estimated by the National Sample Survey, is 3.87 million. When I say the National Sample Survey and I say they use the word workforce, it actually means the number of people who are actively working currently in provision of health and related services. So we might have a much larger stock within the country. So that is people who are trained. However, those who are actually working is always bound to be a smaller number, which the NSSO captures. And that number suggests that we are 3.87 million HRH in India. Now, how is this 3.87 million distributed across the various professional qualifications? So about 1/5 of them, 21%, are allopathic physicians. A little more than 1/3 are nursing and midwifery. Health associates and allied health professionals are about 19%. Ayush is about 13%, and dentists and pharmacists 5% and 6% respectively. But in addition to this 3.87 million, we also have a sizable support staff, which when estimated for 2016 was approximately 1.2 million. Works out to about 3.87 million plus 1.2 million if you count the support staff, to average about 5 million people who are directly working in provision of healthcare. But when we talk about these broad numbers, the 3.87 million, so that's part of column 3. However, when we talk about the adequate qualifications among this workforce, the number 3.87 actually comes further down to about 2.5 million. So when we cross-tabulate qualifications with what actual degree that the staff is reporting in the National Sample Survey, we see that adequate qualification brings down this 3.87 million to as low as 2.48 million. So it's a sizable decrease that we are seeing, but this is not unheard of. When we are talking about where these people are working in the public or in the private sector, we do recognize that the rural health statistics, which report data on specialists particularly, I've highlighted something in the red color, which is, as an example, surgeons, OBGYN practitioners, physicians, and pediatricians, then the in-position number is just about 1/4 of what is expected in the public sector. While we have had several positive steps that we have taken for recruitment of doctors, recruitment of specialists, and other professionals over the years as part of the Indian Public Health Standard requirements, however, we still are facing constraints, and these constraints are near universal, and most states are reporting shortages. When we talk about the 3.87 million in India, let us try to navigate into what happens when we talk just about doctors and when we compare the doctor population ratio across different countries. While 1 doctor per 1,000 is not a norm, we are just using it here for comparative purposes. If we adjust for qualifications and present what the number of doctors in India are, we are just at about 0.61 doctors per 1,000 people broadly at the country level. Now, you can see a clear difference in developing and developed countries in these numbers. And we are bound to face certain difficulties if our numbers are not in sync with what the demands or what the expectations of the population are in terms of service provision. If we take the nurse to the population ratio, the number is not too very dissimilar. We are about 1.06 nurses per 1,000 people. And if you're looking for adequate qualification adjustments, we are down to about 0.6 nurses per 1,000 population. And this is very different from a country like Brazil, which has a much larger number, Thailand, which has a much larger number of nurses as well. And of course, UK and Sweden are much, much greater numbers. But we are even worse off than our neighboring country of Sri Lanka. But in contrast to the doctor numbers where India and Bangladesh are fairly similar, India has far more nurses than Bangladesh. When we try to look at the skill mix of how many nurses to doctors are there at the global level, the OECD average is about 2.8 nurses for every physician. In India, without the education adjustment, we are about 1.7 nurses to 1 physician, and adjusting for education, this number is about 1.3 nurses to 1 physician. Now, these are questions that definitely come to our mind as to what the ideal number is of the nurse to the physician ratio in each country, given the uniqueness of the health systems and the kind of functions that are devolved to nurses and physicians within each country's governance system. But what happens to these shortages? Do they continue despite all the new announcements that have been made, the number of seats that have been increased? Our estimates suggest that although the gap in 2019, which we counted as a baseline here, would be as large as 0.82 in the skilled health workforce, which basically means doctors, nurses, and midwives, we are likely to see benefits by 2030, where the gap in millions is expected to decline to 0.75. It doesn't seem like a very big decline, but please keep in mind that we have an increasing population with greater demands for the health workers, which also come in at the same time. So our projected health workforce, which was about 2.6 million, will still be rising to 3.03 million, which is a substantial rise from 2019 to 2030. yet the gap in millions will continue to be substantial and large. When we break down this data about the numbers of health workforce state-wise within the country, we see a wide variation. The states are not comparable per se, because states which are the union territories or smaller states like Delhi, which are much more concentrated and urbanized, have higher densities as compared to states which are much more larger in size, with larger populations, as well as other historical deficiencies in the health workforce. So if we take the 44.5 as one of the thresholds for consideration by 2030, so this is part of the tracer indicators of the WHO to get to universal health coverage, we are likely to see, or we are seeing, a much smaller number in terms of health HRH density at the country level. Very few states make the cut. So it has to be an improvement all across the board that we need to see on the supply side, as well as the absorption into the health system. When we look at the physicians and surgeons from the NSSO, and we look at the all India density, which is much larger, however, this distribution across the states clearly outlines areas and states where there is a clear deficiency of the health workers. So the greens are the states with the better off numbers, and progressively as we move down to the reds, we are seeing greater and greater shortages. So the picture is quite clear as to where the shortages are in terms of physician and surgeon numbers, which is basically allopathic doctors. Nurses and midwives shows a slightly different picture, in which the traditionally poorer geographies, where we've had seen poorer health indicators, show a much larger deficiency. But what happens when we compare the rural and the urban population? When we look at the doctors, we see nearly 70% and above are in the urban areas, whereas just about 27% of the doctors are in the rural areas. This is much more negatively skewed in favor of the urban areas when we look at the number of dentists. Ayush are nearly equally distributed, but in terms of nurses also, we are seeing a difference where it is more urbanized. When we look at the private sector numbers, the private sector is about 70% part of service delivery in the outpatient sector, and about 58% of indoor admissions happen in the private sector. However, when we come to the health workforce, about 62% and above of the 3.87 million human resources are working in the private sector. About 51% of the nurses and midwives are also engaged in the private sector. Now, all of this sounds like a picture which is not too very rosy, but let us remember that we started from a much lower baseline, and all the efforts that have been done in the past decade have improved the overall numbers which are working within the public and the private sector in India. There have been substantial initiatives that have been taken as part of the NRHM and now the NHM to look at various bottlenecks, address them as well. The past 5 years have witnessed a phenomenal increase in the number of MBBS seats in the country. And down the line, 6 or 7 years down the line, when the first batches start to emerge out of this increase in the supply side, we are bound to see improvements. However, there is no room for complacency. Human resources take a lot of time to be adequately created. And there are several other bottlenecks over time that we have to address, particularly in the public system, to make sure that the availability and the distribution of human resources where they are needed the most is adequately and efficiently deployed for the greater population good. The WHO has identified 2021 as the year of health and care workers. So it's not just a question about the adequate HRH. We need to invest in these health workers, and there are substantial returns that we can expect in health, jobs, economic opportunities, as well as equity, which are down the line the moment we start investing our human resources for health. Thank you very much.
Dr. Kotwal?
I was waiting for Dr. Sanjay.
Yeah, not a problem. Please go ahead.
Okay, no, excellent. Thank you, Dr. Himanshu, for making this presentation. And when you started and you were discussing the numbers, I was just wondering, what was in my mind was the interstate and interstate variations, which also you have covered very well. And I think in addition to these seats and increase in seats of the UGs and PGs of medicine, we also are seeing an increase in the seats for the nursing colleges and institutions, and also all the other. So we are progressing towards that, but yes, a lot of work has to be done. And in a bid to increase the seats, the quality again has to be looked at. And the interstate variation, I'll just share with you that Telangana and a few southern states are now thinking of employing MBBS doctors as a CHO, community health officer, which is a nursing position. And in northern states, it's difficult to get even those in the nursing and the Ayush persons for CHO. Whereas Telangana and some southern states are asking her go ahead to employ MBBS doctors over there. So that kind of disparity also exists, which we need to address, and I think we can discuss it further. Thank you. Back to you, Dr. Sanjay. Or I think the next speaker, you would like to say something?
No, that's fine. This is Himanshu. I would say that you articulated our challenges in the context of numbers, but looking at distribution, very rightly mentioned by Dr. Kotwal, there is a lot of interstate variation also. And therefore, I think there'll not be one solution for the country, but each state will have to design their own interventions and solutions to the challenge issues, and see that in the next few years or so, we respond to these challenges appropriately, so that we would be able to advance the agenda of universal health coverage through strengthening our primary health care. So thank you. I think over to you, Dr. Kotwal, for the next speaker invitation. Thank you, Himanshu.
Thank you, Dr. Sanjay. Yeah, our next speaker is Dr. Anup Karan. He's additional professor in Indian Institute of Public Health, New Delhi. And a lot of papers shared by Dr. Himanshu, we could see his name there. He has more than 20 years of experience in teaching and research, and his core areas of research, inequality in health-related financial burden and its consequence on household living status in India. And specific areas of research are non-communicable diseases and injuries, tobacco control, health policy and planning, health economics, health financing, global health, research methods, statistical modeling, impact evaluation, health impact assessment, and health system. A wide, network of area of interest, and which is really tremendous. He has published research papers on issues such as inequality in payments of healthcare, poverty, and catastrophic impacts of out-of-pocket payments, economic impacts of NCDs, and also a lot of work on the human resources for health. So looking forward to listening to you, Dr. Anup Karan. Over to you.
Thank you, Major General Kotwal. I think my video is going to be played, I suppose, or what you prefer? Yeah.
Tech team, please play the video.
Yes, sir. Play.
Hello, everyone. Good morning. What I'm going to speak about is the investment case for health workforce in India. Exactly, I will be talking more about why such kind of investment is required, where exactly to invest, and how much investment is required. As a brief background, I will just start with two global literature. One is High-Level Commission on Health, Employment, and Economic Growth. And second one is a Global Strategy Report on Human Resources for Health. Both these literature were published in the year 2016 by the World Health Organization. And both these literature talked extensively about requirement of increased investment in health workforce, particularly in lower and middle income countries. In addition, there are also quite a substantial number of studies available in India, which highlighted acute shortage and skewed distribution of health workforce across Indian states, rural, urban, or public and private sectors. Taking cue from this literature, we identify areas and estimate required volume of investment in health workforce in India to achieve universal health coverage and Sustainable Development Goals by 2030. This is a conceptual framework we have used in the study. This maps the entire stream of health workforce, right from the point of production of health workforce from medical institutions to the point of they are active in the labor market. The three green boxes are the points where one can do the assessment of size of the health workforce. First of all, on the left-hand side, the green box tells about total production of health professionals. That is the cumulative total production of health production in a country. And then the second box, green box, talks about what is the actual stock available in the available for the health workforce. Because the actual stock may be even lower compared to the total production of health workforce because of different kind of attrition. Something like migration, retirement, or even many of the doctors or health professionals may not be alive. Then the third green box talks about the actual size of the health workforce who are actually active in the labor market. There may be still gap between the total stock and the total active health workforce because many medically qualified professionals may not be exactly working in the labor market. So only a proportion of these health professional might be exactly working in the labor market and particularly involved in human health services. Other may be unemployed or maybe simply out of labor market. The presentation mainly talks about different policy implications to reduce different kind of attrition at various levels. For instance, there is a need to reduce the migration. We can take a call also about the retirement age. We can also attract health professionals to work exactly in the human health and encourage retired health professionals to come into the labor market. These are the policy implications which are also mapped here in this conceptual framework. This conceptual framework has been taken from the Global Strategy Report, but has been customized for the Indian condition. Briefly talking about the methods, what we do is we have access data from two major sources, National Health Workforce Account and National Sample Survey Organization, NSSO 2018-19. So this is the latest data source available from the National Sample Survey Organization, which gives a quite robust account of the size of health workforce in the country who are actually active in the labor market, while the National Health Workforce Accounts mainly maps the total stock of health workforce, health professionals in the country. We estimated shortage of health, human resource for health as of today, currently, say in the year of 2019-20, and we also projected the shortage for 2030 with respect to recommended thresholds of health workers population ratio, which are generally 44.5 as recommended by WHO and 34.5 as recommended by ILO to achieve the basic tracer indicators of Sustainable Development Goals. Then we work out some strategies to meet these gaps. And finally, we estimate the required investment by estimating how much institutions are required to increase the production of health workforce. We apply unit cost to estimate the total required investment for opening new institutions and also expanding the seating capacity in those institutions. Finally, we very briefly present estimated benefits of such investment, particularly in terms of contribution to total employment and gross value added. The key findings of our findings are as follows. Actual health workforce active in labor market in India is far lower, density being just 11 health workforce per 10,000 population, compared to total stock of qualified health professional, which is estimated to be 26.5 health professionals per 10,000 population in 2020. So less than half is the size of the active health workforce. Secondly, there is a highly skewed distribution across different states. Also, there is inadequate skill mix. Doctor-nurse ratio is estimated to be only 1:1.2. There is a large attrition of human resource for health in the labor market. For instance, doctors, the attrition rate is around 30%, and for nurses, the attrition rate is around 60%. This simply means that around 30% of the doctors who are medically qualified are actually not working in the active labor force. Similarly, 60% of nurses who are qualified, but they are not working in the labor force. There may be various reasons. We will look into that. Then also 20% of currently working as doctors and 40% of currently working as nurses or midwives do not have adequate qualification. So let us see that these last 2 points as a twin problem. One is qualified but not working in the labor market. Another is not qualified but working in the labor market. This problem is not very unique for India. This has been there in many developing countries, but probably the size of such kind of leakages or gaps are quite high in India. Next finding I would like to present that active human resource for health in India is just 1/4 of the required density as recommended by WHO, and 44.5 density, and just 1/3 of recommended 34.5 density. Existing production capacity of nurses and midwives is highly unutilized in India. If you see the pass-out rates from the nursing institution, you will find that the pass-out rate per institution is just 19 or 20, as against the existing capacity of above 40. So even if 40 sitting capacity is available in different nursing institutions, the pass-out rate is just below 20. We estimated the shortage by 2030, and we find that nearly 0.6 to 1 million doctors and 2 to 3 million nurses to meet the threshold by 2030 in the active health workforce. One of the reasons of this shortage is currently India produces far lower medical professionals per 100,000 population compared to that in OECD countries. So to meet this gap, more than 3 lakh crore is required to bridge the gap at 34.5 threshold. Let us see some data. As I mentioned earlier, that a large number of health workforce is not active in the labor market. Take the case of doctors. Total stock of doctors in the country is available around 10.44, 10.5 lakhs, but only 6.6 would be working in the labor market. Similarly, nearly 22 lakhs nurses are available in the stock in India, but only around 8 lakhs nurses are working. Rest are either unemployed or not in the labor force, or also working in non-human health services, something like administrative services, something like different other services. They might be working, but not exactly in the human health. Let us see the production stream of health professionals in the country as compared to OECD country, United States, United Kingdom, or even Thailand. Total production per 100 lakhs population in India is just 9.2 nurses and 3.8 doctors. Even we extend we project it to 2030 after considering all the new medical institutions and nursing institutions which were announced today to be established. We will hardly reach to 9.3 doctors per lakh population, while 9.3 nurses per lakh population and 6.3 doctors per lakh population. So what would be the potential gaps by 2030? At 44.5 thresholds, 1 million doctors and 3 million nurses will be the real gap in 2030. At 34.5 threshold, the gap will be to the tune of 0.6 million doctors and 2 million nurses to meet this 34.5 thresholds. Some of the areas of investment we identified are as follows. First of all, increase the production, open new institutions. At the threshold of 34.5, the number of current institutions to be increased by from current 675 medical institutions to 1,450, and that to be opened by 2025. For nurses, the nursing institutes needs to be increased by little over 7,000 to around 10,400 by 2025. In addition to that, we also need seat expansion in the existing institutions. For doctors, the current, on an average, sitting capacity in one institution is 136, which needs to be increased to 175 by 2025. Similarly, for nurses, we can think of increasing the sitting capacity from current 41 to 60 by 2025. But there is also a need of improving the pass-out rates from the nursing institution, particularly from currently 19 to over 60. And this is really related with the quality of the nurses issue. One important strategy would be to reduce the labor market attrition by at least 50% by 2030. That is, encourage all the retired person or those who are not in the labor market to join the health labor force. So that will create a kind of additional health workforce by 2.5 lakh doctors and 8.5 lakh nurses and midwives. Even if we are able to encourage 50% of those who are currently out of labor market. Then, of course, one of the important issue is to improve the quality of health workforce. So these are the areas which requires enhanced investment to bridge the gap of human resource for health in the country. We mapped the range of investment which are required under different scenarios. So the lowest amount of investment required could be around 49,000 crore, and the highest could be 368 crores for at the 34.5 thresholds. And if you want to achieve the 44.5 thresholds, the range of investment could be between 308,000 crore to 718,000 crore. So what are the different scenarios under which the investment requirement varies? So the lowest scenario, the lowest range talks about, which I call is the lower bound, that has been arrived at by considering attracting 50% out of labor force qualified health professional, and also include Ayush practitioners and count them as the health workforce. Second is lower middle bound. That is only if we only consider the gaps in the total stock, not in the total active health workforce. The third range gives you the strategy about upper middle bound, and that considers attracting 50% of the labor force only, not counting the Ayush as the part of the health workforce. If we want to completely fill up the gap in the active labor market, without considering without attracting the out of labor force health workforce, and suppose that the same trend continues, same kind of attrition continues in the labor market, then the requirement will be quite high. At 34.5, the requirement will be 368,000 crores, and to bridge the gap at 44.5, the requirement would be 718,000 crores. Here, I present a potential benefit of such kind of investment. You can see that the potential benefit in terms of both employment generation as well as gross value added. So the potential employment generation because of the investment, I have taken the case of 368,000 crore at 34.5, one scenario, and 719,000 crore, that is the highest which is required. This will create an employment of 5.42 and 8.52 lakhs respectively. And the contribution to the gross value added would be something like 343,000 crore and 539,000 crore respectively. You can see that the potential benefit in 1 year is almost similar or slightly lower to the required investment. But this potential benefit will multiply over the years, while such kind of investment is required only for 1 year or can be spread over 3-4 years. So one-time investment will give kind of multiple benefits over the years in the time to come. Finally, a few discussion and conclusion points are listed here. The main focus of this discussion point is we need increased production, and there we need to expand the sitting capacity and the number of institutions to be increased. Also, we need to improve the skill mix. That is, we might focus more on the production of nurses and the recruitment of nurses in the health system. There is a significant gap in the stock and active health workforce data. For that, we need to triangulate the data and come up with a more robust data to give the idea about the health workforce. Quality issue is yet another important dimension which needs to be addressed in the medical institutions. That's all from my side. Thank you very much. Thanks.
Thank you for your sharing all this the details with us, and very aptly mentioned, you know, the amount of funds required. That's why even the public health management cadre, when we are looking at, you are looking in totality, we were looking at only at the public health sector. Even there, the amount of funding which will be required by states, which somehow, you know, the elephant in the room, which we are not, you know, right now discussing as such, and it needs to be discussed. We need to look at all that. So I think with that, I'll hand over back to Sanjay for some comments, and then we can have a discussion on all the speakers.
Sure. Thank you. I think Anup has very rightly estimated and is economist by training. So this perspective is important because without financial support, things will certainly not move. And therefore, assessment of the investment that would be required for strengthening human resources for health remains critical when you talk about strengthening our health system. So thank you, Anup, for that. And I think because we are left with 5-7 minutes only, so we have 2 questions. I think, Dr. Atul, if you can take up these questions with the speakers, and then I will come for the final comments. Or should I think you are muted, Dr. Atul.
Can you hear me now? Yeah, okay. Yeah, first was a very interesting question. Someone asked that one advisor, that may I know what is the role of pharmacists in public health. So I think Dr. Himanshu, if you could, you know, inform about this, what is their role?
Thank you very much, sir. It is indeed a very interesting question, and I will not just answer the question, I will try to take up a related point to it as well. Very often when we talk about human resources or a particular cadre as such, we conventionally tend to bucket them into a traditional job description. So there is a clear job description for pharmacists, which includes not just dispensing, but also plays a very important role in counseling and maintaining adherence. But beyond that, there have been several micro experiments within states and within districts where their job descriptions have been expanded, and there has been task shifting that has been introduced to bring them into the wider ambit of public health. My individual opinion is that while task shifting is a temporary solution, it is not a high quality solution for a lot of these services that are expected and demanded. At one point of time, when the thrust is going to be on quality, I would rather want somebody who is a dedicated person who plays a certain role within the public system, and we do not look upon task shifting as a permanent solution. At the other end of the spectrum is a gradual devolution of certain roles and responsibilities. So, for example, in the West, when they talk about nurse practitioners, the role of the nurse practitioner is much wider in ambit than what nurses currently do within India. So do we want to strategically head in that way, that there are certain functions that we visualize in the future will be taken up by pharmacists or somebody else in the public system versus what they're currently doing? So do we visualize it as a permanent shift or more as a temporary task shifting? So that's the broader issue that I would want to allude to. In my personal opinion, I would rather stick to the current roles which are there in the job description and look for long-term sustainable solutions by whichever workforce is going to actually provide them. Thank you, sir.
Thank you, Dr. Himanshu. I would just like to add here that you mentioned one very interesting concept, task shifting and task sharing. Like for COVID, as part of the EG3, we were looking at the roles and of all the healthcare workers in COVID, and also how to augment the healthcare workforce. And if you see the NHM example of LSAS and MOG, so till the time, and we all are aware when we'll be able to address the shortfall of all the specialists in our healthcare system. It will take, I think, another 17 to 18 years, maybe probably, if you're working in this space or even slightly increased space. So task shifting is a temporary solution, yes, but then quality. So looking at quality, our life-saving anesthesia skills and SEMOG and emergency obstetric and neonatal care task shifting, those courses are only available for public health MOs. We have increased the duration from 16 to 24 weeks and changed the curriculum also. And of course, as per our GB mandate, we'll be partnering with PHFI and one or two more organizations very shortly to look at how we can look at critical care, pediatrics, and also psychiatry. So this kind of also in task shifting, but of course, quality has to be maintained very this thing, and we are not. That's why advocating in the private health sector right now. We're only looking at the public health sector. Where as it has been shared by you and other speakers also, there's a acute shortage of the specialists at all levels. Any other speaker would like to address this question, or should I move to the next one? Okay, the next one is a comment by Dr. Sudhanshu, and very rightly mentioned that we need to look at the disaggregated and granular data for state specific when we talk of HR. So we can do a mapping and then look at what Dr. Sanjay also mentioned, look at specific solutions for those areas. So, the next question is the migration of qualified healthcare workers to other countries. When the country on the shortfall of a healthcare manpower, may I know what's your thoughts on this? So this is the same what Mr. Dillon has also mentioned. That they are now going to be, international partnerships to track such kind of movements. So I think Mr. Ibadat would be the right person to, comment on this. Mr. Ibadat, please.
I think it's a difficult question. The reality is that the interest of, I can say, governments is manifold. So we are looking at the health interest, but others are looking at the trade interest and the interest of labor employment and the expectation of the individuals themselves. And I think this goes back to the earlier question as well, in terms of mapping of the public training institutions and understanding where are people going. There was a big discussion in this in the Western Balkans, I believe in Croatia, where the Ministry of Health said, we're putting so many public resources into public education, but our people are leaving in magnitudes. And so they did some analysis where they said, if the same amount we put in public education, we put in employment, would this not be a better use of our money? That we put the same resources that we're putting in, because the private return on becoming a doctor and specialist is significant. So people are willing to put their own resources into these type of education things. So shouldn't this money shouldn't we put it? And they brought it to the cabinet. And they said, the minister, I think it was the vice minister of health I was discussing with, and he said it was immediately thrown away because the interest was so strong to make sure that people who are going into these major public institutions are able to migrate. But I think this is a difficult challenge, and even at this very moment, we are seeing that I know that the Australians are looking at free trade agreements with India. Japan has just made labor agreements with India, and others are coming. The UK is discussing with India, and usually it is not with Ministry of Health. Actually, it is almost never with Ministry of Health. And I think this is a really deep challenge, and especially in a time where we faced COVID and such severe challenges, then really where should the public finances go towards? But yeah, I will stop here. Sorry.
No, thank you. Thanks for this. Any other panelists would like to, add on to this before me and Dr. Sanjay add on to this, what Dr. Srival has already mentioned? Yes, Dr. Sridhar, please.
Migration of health workforce outside the country and within country is a major issue. I think Dr. Anup Karan may see that labor workforce, parental occupation. What is their parental occupation? If you see the A&M, ASHA, Anganwadi workers and A&Ms, what their parents do. Generally, they are the farming background, rural background. They remain in the rural background. It's not necessary that they should remain in the rural background. For example, in my batch of MBBS, we were sons of teachers. Among us, 35 were people whose parents were teachers. If you see the composition of existing MBBS batch, what their parents are doing. So it has an implication what their parents are doing, what is their origin, what was the primary education they had taken from, rural and urban. So this rural and urban divide in production of health workforce have tremendous impact on their place of or choice of working. So it's not only this sector, but it connects with the education sector. One of the slides Himanshu and Anup were mentioning, that it has a connection with the primary education and secondary level education. What is the quality of that? Where is it? Where it is happening? So unless we improve the education, primary and secondary level education in the rural areas, it will be difficult to any workforce to retain in rural areas, and public health will require people working in rural areas. So that was my point. Thank you.
Yeah, actually, it's a very, very complex issue. It's a multi-dimensional complex issue. Dr. Kadam has also added his views on that, which very rightly he said about the background also. There's a freedom of choice. Of course, there's a government funds being spent. There's a freedom of choice to the individual. On one hand, you're talking about global health and they're looking at the global scenario. On the other hand, if you want to have this kind of restrictive policies, but again, the governments have to look at what they are gaining from the funds. And Dr. A.R. Antony has mentioned in the chat box that you have to live with migration for career ambition. The lesson is to accept it and increase production proportionately. No farmer produces food only for his family's consumption. Some food to sell and earn a living as well as to meet other expenses. I won't comment on this. I have a conflict of interest. My son is an endocrinologist in USA right now. So I won't comment on this. And studied from the Maulana Medical College, government funded. So over to Dr. Sanjay for further comments and taking it further.
Thank you, Dr. Atul. I think all the speakers, because we are running out of time also, so let's conclude. But then all the speakers have done justice to the topics. Two areas that we could not cover today. One is health professional education, which is important in the larger context of human resources for health. And another is the role of the private sector, because when you talk about HRH, at times we generally focus on public sector, which obviously very important role to play in providing quality and dignified healthcare to our own people. But we also need to realize, like country in India, where the private sector is a quite predominant one and plays important role. And there are several health workforce issues and challenges in the context of private sector also, which we will have to deliberate on. But health professional education, by and large, I always felt supply side, the quality of education is critical and important for good, motivated, adroit, skilled, competent health workforce. And therefore, we are talking about 21st century, and we will have to see that how do we advance both institutional and instructional reforms within our health professional education architecture, so that we create transformative and change agents to work both in public and private sector. And so the deliberation in the context of health professional education would also be important, but paucity of the time we couldn't touch because HRH is a much more larger portfolio. But I thought that some light and some deliberation and discussions in the context of how do we improve the quality of health professional education, and how do we bring on the research front to the private sector are critical and important. With that remarks, Dr. Atul, you have any remarks before we close?
Thank you, Dr. Sanjay. I would just like to thank all the panelists for their excellent, expositions, and also the work which they have done. And just to share that the primary healthcare, we are looking very closely from the Government of India side with the Ayushman Bharat Health and Wellness Centers. So the primary healthcare, as mentioned by Mr. Ibadat also. So we are looking not only increasing the numbers, but also the quality with the capacity building and partnering with various institutions for capacity building. And we are also evaluating our trainings also. And we are also looking at now development partners to look at implementation of these capacity building exercises at the state levels, because we from NSSRC and the ministry cannot take on the entire load as such. So we are also looking at development partners in various states. And in fact, we are going to have a meeting with WHO day after tomorrow, and how they be getting involving them also in few of these states, in addition to, of course, BMGF and other development partners and Indian institutions. We have recently finalized a document on the public health education in India. So of course, as Dr. Sanjay has mentioned, we could not cover the education, but we are going to submit to DGHS very shortly. And we interviewed Dr. Sanjay also for that, for inputs for that. And hopefully we are looking at more availability of more public health specialists, MBBS background as well as non-MBBS background with the MPH, BDS, and Ayush, and even nurses with the MPH background. And that cadre we have already discussed earlier. So thank you very much for everyone, and thanks to the questions in the chat box. In fact, those questions made the discussion also interesting. Thank you, Dr. Sanjay. Over to you for final closing.
Thank you. Thank you, Dr. Atul Kotwal, and thank you all the four speakers, Ibadat, Himanshu, Sridhar, and Anup. And over to you, organizers, for providing us the opportunity to chair this session and advance the discourse and deliberations in the context of HRH. So over to you, Dr. Sitanshu.
Thank you so much, sir. So it's a wonderful session and a lot of learning, and I am sure that our delegates would have benefited from this deliberation. So with this, we close this session. Thank you so much. Again, the chairs, Dr. Sanjay Jodhpe, Professor Sanjay Jodhpe, and Dr. Atul Kotwal, sir. So with this, we move on to the oration. That the next oration session is on Dr. K.N. Rao oration. We'll move to the hybrid session. Thank you so much for joining. Thank you.
Thank you very much. Thank you, everybody. Thanks.
Thank you.
Good morning, everyone. Welcome to the fourth day of 65th Annual National Conference of Indian Public Association, Iphacon 2021. So our next session is Dr. K. Rao oration. I'm pleased to invite our chairpersons for the session. Both are prominent figures in the field of public health. Dr. Deepika Sood, scientist of National Institute of Cholera and Endemic Disease, Kolkata. She is Central Council member of IPHA. And Dr. K.C. Premrajan, Professor, Department of Preventive and Social Medicine, JIPMER, Puducherry. He is Chairman, Scientific Committee, IPHACon 2021. We welcome you, sir and ma'am. And I also invite our honorable guest, Dr. Sundararaman T. Sir. He is adjunct faculty, JIS Puducherry, and he is also former Dean, TISS Mumbai. Welcome you, sir. Now I invite Dr. Deepika Sood to open the session and talk us about Dr. K. Rao.
Thank you so much. Good morning, everybody, those who are physically present and those who are online. I'd like to read a few words for Dr. K. Rao. Dr. Kamaraju Narasimha Rao was born on 31st January 1907 at Bapatla of Muncher district, Andhra Pradesh. He passed his MBBS in 1930 and became a fellow of the Royal College of Physicians in UK. He joined the Indian Medical Service military wing in 1935 and was a prisoner of war in Singapore from 1942 to 45. In 1946, on release, he was transferred to civil IFVIS. He worked as professor of jurisprudence in Christian Medical College, Vellore, 48 to 49, and later in 1951 as professor of tuberculosis in Stanley Medical College, Madras. He was also the tuberculosis advisor to the government of Madras, 1951 to 54. He served as director of health services of Andhra Pradesh for 2 terms, 51 to 56 and 56 to 63. He was appointed additional general of health services, government of India in 1963 and became director general of health service in 1964 and served in that post till 1968. He was also president of the Tuberculosis Association. Dr. Rao was a great medical scientist and administrator and was associated with a large number of professionals and scientists in India and abroad. He was recipient of the awards like Dr. P.N. Raju's Oration Award of ICMH, Shodapti Oration Award of Association of Physicians of India, and Dr. B.C. Dasgupta Oration of Indian Public Health Association, of which he was also president during the year 1966. Dr. Rao functioned as chair of the expert committee of WHO on tuberculosis and also the chairman of executive board of WHO in 67-68 and served as the first president of World Federation of Public Health Association and consultant for medical education of WHO and PAHO for Latin America. He was confirmed the honorary LLD by the Sri Venkateshwara University, Tirupati. He was the executive director of the National Academy of Medical Science in 1975 to 79, and brought into existence the International Medical Science Academy in 1981, and had been its founder and fellow since then its present. As an authority in family planning and population control, he contributed valuable papers for guidance of the people and medical profession. He was also deeply interested in medical education and toured all over the world to gather the experience of all countries in this respect. Thank you.
Thank you, ma'am. Thank you for the wonderful introduction. Now I invite Dr. K.C. Premrajan to introduce our orator, Dr. Sundararaman.
Very good morning to all. It's my privilege and honor to introduce my own teacher, Professor Sundararaman, who is going to give today's K.N. Rao oration. Professor Sundararaman is well known in the field of public health, especially those who work on health system and health policy development. So, sir has been first stated as doing MD Internal Medicine from Madras University. He spent his first 22 years of his professional life as faculty member and professor of Department of Internal Medicine at JIPMER, Puducherry. And then he moved over, changed his track, moved to working with public health system. And for the first 5 years of his public health career, he was head of State Health Resource Center at Chhattisgarh from 2002 to 2007, where we all know that he pioneered the maintaining programs and state health sector reforms. Then he moved over to New Delhi as Executive Director of National Health System Resource Center for 2 terms from 2007 to 2014. And during that time, he initiated, developed, and led an institution providing technical support to many initiatives undertaken under the National Rural Health Mission and then National Urban Health Mission. In his position, he played a key role in research, innovation, and capacity building that was required for the health system strengthening. And he was also a member secretary of the Sector Innovation Council in Health, and he was a member of steering committee for the 11th and 12th 5-year plans, and he played a very crucial role in preparing the national policy document of 2017. After completing 2 terms in the NHSRC, he moved back to academics in 2014-15, initially as visiting faculty in the Department of Social Medicine and Community Health at JNU, New Delhi, and then he worked as professor and dean of School of Health System Studies at Tata Institute of Social Sciences, Mumbai. And after retirement, currently he is an adjunct faculty in the Department of Humanities, IIT Chennai, and at JIPMER International School of Public Health. Dr. Professor Sundararaman is known for his work with community health workers and with development of health policy and strategies for primary health care. He is a member of a number of expert committees related to health policy and planning, and he authored a number of publications in journals and number of books. For young faculty and postgraduates in community medicine, public health, who was interested in health policy system development, it's a must to read his publication. He has been actively associated with People's Health Movement and has been known for his advocacy and bold initiatives in support to achieve the right to health and healthcare. He is also a founder member of India's Jan Swasthya Abhayam, and is currently the global coordinator of People's Health Movement, which is a global network of a civil society organization dedicated towards people health. Thank you.
Thank you, sir. Thank you, sir, for the wonderful introduction. Now, we request Dr. Deepika Sood to felicitate Dr. Sundararaman T. Now I hand over the stage to Dr. Sundararaman T. to deliver his oration.
Before I start my formal oration, let me just take a minute to thank all of you for this recognition. These recognitions are rare for health systems professionals because by definition, what we achieve successfully must be owned by governments and the larger organizations as their decisions. Otherwise, it's not much of a policy if owned by earlier. And recognitions from peers like the Public Health Association is particularly welcome. And to receive it in my alma mater from people whom I have taught and people whom I have worked with is even more welcome. So it's a very nice day and I find it a very happy occasion. I hope my formal presentation will encourage a generation of young people to engage in health policy and systems work. And that is the way I have really structured that presentation. I think that policy is always made by politicians in negotiations with multiple stakeholders. But public health community is just not another stakeholder. It is not just a matter of their opinion like other stakeholders. We bring evidence to the table, and evidence with it has its own power. And therefore, it's very important to really look at this whole rising discipline of policy and systems research, which is what I have been focusing on. We must note that otherwise this space gets occupied by international agencies and consultants, and it is high time associations and the public health community in India reclaim this space. Thank you, and I'll now start my formal presentation.
So happy to be on this stage. It is an honor to be invited to deliver the Dr. K.N. Rao Memorial Oration. I am so happy to be on this stage and in honor of a person who could be very well said to be one of the first pioneers in this field which I am going to be talking about, health systems research. He has all the qualities that define this field. He was a professor of jurisprudence, then a professor in tuberculosis, was a medical person plus also an administrator. He served as administrator heading a state department and then subsequently the national department. And in fact, that is precisely the sort of multidisciplinary leadership grounded in health systems work that we require today. So, thank you for inviting me on this occasion to give this talk. I am going to be focusing on two things in parallel: the central aspects of what is happening in health sector reform, the whole dialogue that is happening around that, the changing discourse, and also how it relates to the emerging science and field of practice which is known as health systems research. Now, a few definitions to make sure we are on the same page. Health policy and systems research is an emerging field that seeks to draw a comprehensive picture of how health systems respond and adapt to health policies, and how health policies can shape and be shaped by health systems and the broader determinants of health. There is now a major WHO organization, the Alliance for Health Policy and Systems Research, that systematically stewards this development. There is therefore a corresponding definition of health systems, the main point being that they are understood as social systems, and therefore, it is a point where we are talking both of medical systems, but we are also talking of social systems, a bridge between social science research and the biomedical research on that. Now, this discipline is not characterized so much by its methods, but by the questions it forces. Some of the questions relate to areas of understanding, but many of them relate to health sector reform, and indeed in many ways this discipline as a discipline emerges in the whole crucible of dialogues around health sector reform. So, they are discussions around how health sector performance improves, and there are discussions around how to make health systems accountable to people, so that they deliver the attainable higher levels of health that are required by a health system. And the accountability here is, we are not talking of just the peripheral provider, we are talking also of the accountability of the policy maker. A new policy is announced, say the Pradhan Mantri Jan Arogya Yojana. Did it deliver the health outcomes that people expect out of it, or even the outcomes for which Parliament approves it? So, these are the sort of questions that at some larger level this discipline handles. In India, this science has been around always, but has seen a major growth in the last 2 decades, from about 92 publications in a systematic review that were picked up for the year 2006 to about 314 in 2012, and much more now. Much of it is on service delivery and on information, but increasingly there is a lot on governance also. The problem with health systems research in India is both the subjects of research are concentrated in very few states. About 4 states provide most of the people who study it, and about 5 states the bulk of the studies are on. So, in some sense there are many areas that are very seriously under researched, and many areas in the country where schools of public health have not yet engaged with health systems research. So, there is a huge gap there. Now, why do I call it the crossroads? Because at some point there is a big choice that has to be made between what we would call research on perceptions, on ideologies that are based upon healthcare markets versus the treatment of the whole area as a public health good. The former emerges from neoclassical economics, and the latter depends a lot upon political economy for framing the questions and the understanding ideology of it. So, in the first set of perceptions which we associate with the term health care reform, we see public services are portrayed as inherently inefficient, poor quality, because they are outside the market, whereas private sector is efficient and good quality, but unaffordable. Ideally, neoclassical economics would leave the whole of healthcare like any other commodity, like say management of hotels or management of say transport, to the private sector. But then, because people, there is a goal of also everyone getting healthcare, they reposition the government role as a purchaser, where it purchases healthcare on behalf of patients through insurance based systems or partnerships or other forms of contracts. And the government role as the provider of health services is very much limited. So, there is a whole trend in reform that tends to push systems to behave in this way. But there is another trend which says that it is necessary that public services should be dominant, because markets do not work for healthcare, and private sector, if it is there, should be limited and strictly regulated. There are problems of public service delivery, but they need to be researched and handled in a different set, which is not really trying to make them more like the private care. And government has a duty to assure quality health care to all, irrespective of ability to pay, and therefore, it is not a commodity, because you could not like buying, some person can afford less, he gets a cheaper mobile, some person can get more, he gets an iPhone, but it is not like that. If you are going in for a surgery, then there is no question of compromise on the quality of surgery that you get. So, in some sense there is a thing, and you say yes, whereas healthcare markets may increase your GDP growth by so many percentage points, treating healthcare as a basic substrate of social capital also leads to huge health benefits. But these are entirely 2 different streams of thought which come to contend on this. Now, why does the COVID crisis create a new opportunity and a new situation. One reason is purely because number of world leaders for the first time were to call out that we must see vaccines and indeed all of healthcare as public goods. For a long time, in fact, last week the WHO has come out with a journal publication on a special issue on common goods. So, world leaders from the UN Secretary General, the WHO Director General, the French President, the Japanese President reiterated the importance of health as a public good. And civil society also and much of the academic community joined in calling for health care to be treated as a global public good. There was also the rather spectacular failure of private markets, at least in LMICs, that we could see, despite the fact that a lot of it is now covered and empaneled under insurance contracts. But surprisingly, not only in healthcare delivery, even in the production and manufacture of commodities like vaccines and protective equipment, you had to depend upon government intervention in a major way. Public financing for research, public financing for manufacture and production. And there are calls now by like the India-South Africa's appeal before the World Trade Organization for a complete pushback on all patent restrictions, at least on COVID technologies. But it is still the crossroads, because there is a pushback. Rich nations contend that market regimes work for technologies and therefore insist for new innovation they need to keep to this particular patent regime, and they blame, for example, poor private sector performance on better terms required. And therefore, at one point the debate is not over, it is just set on new terms, and therefore, this whole thing looks at health systems research and how it contributes to this whole crossroads at this point. Next. Now, let us take a couple of steps back. If we look at where this began, in the immediate post-war period, there is a large world consensus that health and healthcare is a right. You see this expressed in the UN Declaration of Human Rights, you see it expressed in the International Covenant for Social, Economic and Cultural Rights, you see this expressed in the Declaration of Alma-Ata. The first two are binding treaties that the Indian government has signed to. You also see beyond international agreements that socialist nations deploy free and universal health care as the basis of their systems. But even important, the whole industrialized world, the capitalist economies are also going in for complete state provision or at least state guaranteeing of health care provision to all its citizens. The only nation that is an exception in this is USA. They may choose between what is called the Beveragian systems like the National Health Services of UK or social insurance systems like you have in Germany. But eventually what you have is a universal healthcare system where the state guarantees and total expenditure on health more than 80 to 90% could be government expenditure on that. There is a sharp influence of Keynesian welfare economics that decides this, and you find that developing countries which are decolonizing are choosing between this. They are all largely committed to going towards a universal health care paid for by the state, but because of resource constraints and also because of local elite pressures, they also allow private systems to grow. But as a result, this whole consensus rests upon a Keynesian economics understanding, what is best expressed in one landmark paper. They call this paper the birthing place of the whole of the discipline of health economics. This paper, Uncertainty and Welfare Economics of Medical Care, goes to say that it is not only public health as preventive services, things like pollution control. It is even individualized curative health care is an area where market failure is inevitable. Unlike other commodities, one does not know one's requirement unless it is too late, and at the point when you know the requirement, you are not really in a position to bargain. You do not know how many people are going, whether we are going to fall sick next year or not. And when you go and purchase it, you don't know the outcome of care. No doctor can guarantee you a cure. And if you book a hotel room, you will get a hotel room. If you book it of a particular quality, you will get that quality. But you can never ever say that for healthcare, and yet you have to depend a lot of trust on that. But this trust has to take place in a huge situation of information asymmetry, where, for example, when I go buy a hotel room or book a transport, I know what I am trying to buy and I know whether I get it. But when I go and tell a doctor whether he decides to do a cesarean section or a normal delivery is a decision that very often he should take independent of exactly there is a feel on that. But at some point there is a decision we have to leave on trust. We can't ask him whether the decision is taken in our interests. But unlike in all other commodities, where the interests of consumers and their preferences is also the interest of the seller, here the true interest of a patient need not be what is most profitable for the provider. So, and then there is the whole issue of professional power and how it is. You know, what this phenomena, are you the doctor or am I the doctor? At some point, choice is ruled out a priori. Given all these situations, it was the global consensus that you can't leave healthcare to the markets. It has to be provided by the government in a manner in which market forces are kept out of it. So, it is provided, we would call it as a gift, which is tax funded. All of this has therefore been the architecture that designed what healthcare was. Unfortunately, however, this approach seldom worked. You have, for example, a problem that poor investment was a major related problem, and in India particularly you see that we spend less than 1% of the GDP and 30% of total health expenditure is government expenditure. Our proportion of total health expenditure, which is government health expenditure, is about the lowest in the world, bottom 10% of countries. And our total health expenditure itself is among the lower countries in the world which we have. And we have therefore a huge gap in infrastructure and human resources that is consequent upon our poor deployment of financial resources. But there is also another part which money alone does not solve. It is the problem of getting skilled workers in rural and remote areas, it is the problem of accountability, the problems of corruption, the problems of quality of care, responsiveness to immediate needs. You are providing some services in the primary health services, but people have different needs, many of which you can't respond to. Your access to commodities, there are problems that logistics has to be supplied, it is not like the market knows to supply it, and the health information systems have their problems in that. So, there is a whole host of problems why public services delivery has been weak, and increasingly there was a need to reform these. And when we are talking of reform, one of the major examples of reform, I am skipping a particular period in history, was the National Rural Health Mission. 2005 to 2012, something that I have been closely associated with, because we founded and headed the National Health Systems Resource Center, which had a role in knowledge management, capacity building, embedded research, streaming knowledge resources to decision makers, sharing learning, all of it built on an earlier experience of State Health Resource Center, but all of it today we would know as policy and systems research. Remember, at that time this was an emerging concept as a discipline. So, these were one of the things that were happening, and the NRHM addressed these problems, what were called the non-investment problems. For investment, it promised to raise the resources, but for the non-investment problems, it said they did not want to use the word health sector reform, because that word had been captured by market based reform. So, to distinguish themselves from market based reform, it was called architectural corrections, which was somewhat on a rights based approach, because it talked of guarantees of health care. And it talked of 5 major measures: communitization, which the heart of it was district planning, but also committees, participatory committees at district level and at field level, village committees. the huge community health worker program. Then you had flexibility in financing with untied funds given to institutions and funding going according to plans. The central government had a role in setting standards. It's not as if it abandons everything to decentralization, and monitoring against these standards. They were called the Indian Public Health Standards, and the gap had to be funded by the government. And there was professionalizing management capacity, including in fact the whole schools of masters in public health, and the huge expansion starting with the Public Health Foundation of India in courses. And now today there are 50 to 60, maybe even 100 courses in masters in public health or related different disciplines of health, which all started around this period, professionalizing this, and innovations in human resource management, which were a number of things, including increases but also innovations. So, there were measures that were tried out at the National Health Mission, should be seen as one major approach to health sector reform viewed in a more generic context. But the point I am also trying to emphasize was that this depended upon a lot upon a number of systems research inputs. It is not common sense. It is not just a committee of experts decides what to do. It is not just a political call. Eventually, it is a political call and it is a power play, but that power is largely influenced by the evidence that is provided by research. And much of this evidence came from a few research institutions, of which the NHSRC was one, the Public Health Foundation was another, and certain schools of public health like All India Institute, PGI Chandigarh also generated a number of reviews related to this. So, here are some which I give as examples of the type of research influence. These are all papers that I have published as part of NHSRC. The first one was in Lancet, the community health workers. This was on the Chhattisgarh program. Second, which was very interesting, was Indian approaches to retaining skilled health workers in rural areas. Then there were two joint publications, multi-author publications in Lancet on basic background issues. And one which I am really interested in is why some doctors stay in rural Chhattisgarh. So, instead of asking the boring question why doctors do not go to rural areas, we flipped the question and said at least 1/3 of PHCs have regular doctors who are serious and sincere. Let us figure out what makes them different from the others. It was an extremely useful study, because you could influence policy and say, look, it is not just enforcement. Do not force somebody who does not want to go there to go there. There are people who for different reasons would want to go there, and try to find more people like that or build more people like that. So, systems research can lead to extremely innovative ways in which one can improve systems, and working within a rights based framework on that. This is another set. I would not go into this in detail, but this goes beyond human resources into management of knowledge resources, into issues of research itself, into issues of technology assessment, and issues of health information systems. How do you improve basically health management information systems, which are notorious for poor reliability of data? And one of the very dumb answers is, if you put poor data in, you will get poor data out. No doubt that is true, but I call that dumb because most of the times the problem is not the data entry. The problem is at different levels in between, and with the assumptions that we make. The common sense driven approach, we would not treat a patient who needs clinical care on common sense. We would insist that there is some studies that evidence the decisions that we make. But in systems, unfortunately, we still have to move away from common sense, which, while very valuable, and if something is not contrary to common sense, you would look twice, is insufficient to actually make the complex decisions that systems make. Of course, the National Health Mission had a huge number of problems. There were the investment did not match the promises. There were old problems which were pre-NRHM that continued. You had corruption, you had center-state relation issues, governance issues. The urban mission started off very late because of this whole Tucker, this whole conflict between the market-based reform and the public health goods or political economy based reforms, and the whole controversy about decentralizations. So, it started off only in 2013, and even then now is weakly willed. And then many features of health sector reforms of the earlier period, selective packages of services, user fees, vertical programs, they were not going very well, and very much they were not very useful. And one major particular problem was that the entire increase in human resources, the bulk of it was contractual, not regular employment, and relied a whole lot of theories like pay for performance, they call it P for P, results based financing, and then a whole issue of trying to look at public private partnerships. So, there was a lot of confusions in this, and even today this notion of reduction of government employment and outsourcing has real problems, and the higher you go into the service, the more the problems are there. I mean, you may outsource your security services reasonably well, but you will have a much greater problem if you have to outsource your clinical services. And part of the reason was a very, very poor theorization of health system strengthening as global public goods. So, here I am saying there was a failure of the public health community, of the research community. It is not only a governance failure, it is also a problem of research. In contrast, health sector reform is got a huge degree of support from academic literature, studies, theorization, because the dominant universities of the world are proponents of it. And at some point, it is in their interest as part of the global public health. At one time was a support to colonization, today it is a support to the new economic relationships. So, this called the philosophy of health sector reform of a market based research. Earlier I was dealing with non-market based solutions, and now market based solutions would say that except for things like vector control, where you can't price it, because even the person who does not pay for the vector control will benefit from it, and you can't exclude people. So, for example, in JIPMER campus, if we control the mosquito menace, then you can't make people pay for it, because even those who do not pay will benefit from it. So, you call that a public good in a very narrow sense, non-rivalrous, or goods with high externality. So, government does get into COVID or into TB, because if it does not, then the healthy people, the elite, people who can pay will also suffer from it. Therefore, you are worried about the sick, not because you feel the sick have a right. You are worried about the poor, not because you think the poor has a right, but you are worried about them because if you do not take care of them, it is going to come back and strike the rest of the population. And you hear this said about COVID most often, that at some point if you do not take care of all people, it is going to affect even the richest people on that. And that is one set of reasons why you identify that. And the third was, you said, yes, okay, you do some poverty alleviation, but you limit it to a very select set of services, and the rest of it you leave to markets. So, there is a whole school of research that leads and supports this sort of thing, and this school is the dominant school because it is based upon neoclassical economics, which is the dominant economics. And the process and impacts in India was actually government medical colleges slow down in this period 1993 to 2005. This was the period when till then it was 90% government medical education, technical education, nursing education. It shifts, no new recruitments, even doctors, nurses, even for replacing people who had died or gone on vacation, or who had retired, were not there in the primary care sector. Very selective package of services. So, primary care was limited to RCH and a couple of disease control programs, and the introduction of user fees. All of this was part of the process of reform. So, if you see that a PHC is very ineffective today, they do not provide for epilepsy, and you shut down services in JIPMER saying, no, it is the job of the PHC. You forget that by policy, such services for things like epilepsy or hypertension or diabetes were removed from the ambit of primary care by a reform process that was set in motion in the 90s. So, this whole selective care package comes in then, And then you have huge increases in the cost of care, because 85% of care now has to migrate to the private sector, and modest or no improvements in population health. So, you have a huge outpatient in the big hospitals, because the outpatient in the primary level have been withdrawn from providing care for a number of diseases. So, this marked the first reform, and this was marked by a set of philosophies, but I am also saying that it was marked by a large body of academic research and discourse. This whole thing of dollar spent per Dali saved, disability adjusted life years, and a whole school called New Public Management. Wow, how you make the public sector responsive to prices. So, you say, yes, we agree with Keynes that prices do not work, it is market failure, but the role of the government is to set the prices right. And this sort of feeling would get into even our way of thinking. So, people would say, people would not respect what they do not pay for. Whether or not you work, you will get a salary. So, why will public servant work? Remember, an institution was JIPMA was built on a understanding that you provide for the health staff over here their residence, you provide a school, local school, you have their shopping center, take care of their basic needs in a reasonable way, so that without disturbance they can dedicate themselves to public service. That same thing you can't say today. Today you would say, oh, look at it, he's got in the private sector he would be earning so many lakhs. Now, in the public sector he is wasting. So, the whole notion, people, this whole notion of how you talked about public service and public thing, there at that time you would say, I am part of nation building. So, those value structures were to change within this, and they also have a role to play in the changing of these health. The way we think about health systems started changing. Now, in between, of course, and largely driven by political reasons, the National Rural Health Mission happened. But after that, by about 2012, it had reverted to what we would call the second wave of health sector reforms. This is a term that I am using in the current of, we are talking of waves of COVID, it is easy to use this particular thing. This really started off at the academic discourse starts off at 2005 or even earlier, you can trace it, but it becomes dominant by 2010 and largely associated with the dialogue around universal health coverage. Universal health coverage by itself does not necessitate this, but then there are collaterals in this, like shifting the government role from provider to purchaser. Okay. Therefore, what it means is that the government pays for insurance rather than pays for a hospital care. Insist on provider payer split, say that the government department that is managing hospitals should not be the same ministry that is managing insurance. And you say that you fail to see, distinguish, say you put them all into a single network and you make them respond, even the public provider respond to how much profits he makes, according to that they will pay their salaries. And there is a whole approach, I can't go into the details, what is called the managed care approach. So, for primary care, their solution is to create large networks which will be in charge of, say, a block and hand it over to a corporate care, say one corporate house to run services for this, say, Tindivanam block or in Kadalur in Vilpuram district, and they will be paid so much and they will provide the entire primary care. So, this sort of managed care option started coming up. So, these sort of things come, and driving this is the Niti Aayog. In many ways they are moving on this. See, India is a mixed economy, we retain a commitment to public services, but the drive, the thrust of change very often is, for example, integration and centralization with the Pradhan Mantri Jan Arogya Yojana, search for new public private partnerships. So, the Arogya Yojana, Niti Aayog sets itself the agenda of designing contracting packages by which district hospitals and medical colleges in different states can be contracted out to private partners, so that instead the government expenditure on it is lower and they can use cross subsidy mechanisms within that, etc. And now recently as March 31st, 2021, where you have the second wave ongoing, encouraging foreign direct investment to come in India and to invest heavily in the private markets etc., and a huge centralization in medical education that allows privatization to continue, and you see this in different sectors also. Now, there is a huge body of research, I said, that supports such changes, but there is a lesser body of research, but still an important body of health system research that questions these changes. So, the effectiveness of government strategies, we have actually shown that at PMJAY, while it provided as a number of people using it is heavy, in actual reduction of catastrophic health expenditure, it did not do much, and in access to care also it was extremely limited. You can also look at how markets and prices change in different areas, and a lot of commentaries upon this. So, this whole meaning of universal health care coverage, the interpretation, should you interpret it towards a regime that treats all of healthcare as a public good, or should you emerge it as part of emerging markets? There is a whole area of work there, and now in fact, it is an interesting one. The first paper has two authors, Narayan Devdasan and Sunil Nandraj, and myself as another author on that. But the remainder of the papers, we wrote one, and the other two authors have continued to write contesting papers. So, there's a, if you follow this, there's a debate that's on. All of it is based on a very solid database. The National Sample Survey Organization and the NSSO data of the 71st and the 75th round is a very rigorous nationwide sample, which can comment on a whole lot of things about health systems and how they work. So, this is the sort of stuff on which most of us work, and this database, there is a whole set of papers on that. Now, when it comes to the COVID-19 pandemic, it is too much current. I do not want to give any conclusions on that. But the pandemic is a stress test for health systems, not only in India, but across the world. It is curious, there is a global health preparedness index, which the World Bank and WHO had conducted, and USA and UK were ranked as the first and second most prepared for the epidemic. And Vietnam was about the 50th position, and you had many other countries, Germany much lower, 35th position, Thailand at somewhere at the 60th position. But many of those countries which were ranked rather low in the preparedness did far better than the countries that were ranked at the top. And within each category, you see that particular problem there. So, in some sense, all our theories were put to a stress test to see how far they actually could perform. And there are therefore a number of open questions in this area that must attract research and must attract people who are in practice. How was performance of different sectors? What forms of engagement with private partnerships worked? How do different areas like information technologies? Most of us know that Arogya Setu never really took off, though you keep signing that you have got Arogya Setu downloaded. But CoWIN has done relatively much better. COVID trackers have had a mixed response. So, what works, what does not work, organization of primary care services, of reference, of ambulance services, which were the places which were yesterday I presented a paper where in some detail we looked at how many best practices had managed to prevent a disruption of healthcare services very successfully, but many had not also, and what made it work, and lessons from governance, federalism and the right to health care. What are the lessons for healthcare financing? And there is a whole set of last year's publications on this area. Every one of them, these papers, these are my papers, recent papers, reflect on this issue of which are the systems that work and how do you make for systems that are much more responsive while retaining the framework of a global public health network. Where we view how do you make for systems research which views health systems as public goods and not as opportunities for market based profiteering. So, what are the challenges ahead? One major challenge is to the whole of health systems design. We need to conceive of health policy and systems research, documenting what is happening with this policy work, did that work. A lot of the studies that we come in India are really evaluatory studies or documentation of what happened. But we need to go much beyond that to offer creative and innovative design solutions. What do I mean by design solutions? As different from enforcement, ANMs are not going to the subcenter. What is the solution is you offer ANMs should go to the subcenter. You don't need research for that. What you need research for is to say where are you able to make it happen, what are the situations that actually change, how do we address the determinants of that particular set of behaviors or contexts. So, these sort of solutions require an entirely different approach to health systems research. They must be designed as learning systems, constantly able to learn from experience, theorize and adapt, and policy and systems research needs to get embedded into implementation. I mean, this is not a new thing. If you have a professor of surgery, he does much of the surgery. It is embedded research that happens in most of clinical domains. But in public health domains, especially in systems research, you need to be able to bring in a number of people who are engaged in implementation into the process of research and study also, which is important. And it needs its set of institution, processes, skills and methods that need to be developed. So, at some sense, this is a huge area of work that is opening out. And the final take home thing is that much of the frameworks that we use in this area, because of the nature of its development, are largely developed in Western countries, in universities over there. Much of it is research on developing countries, but they are using frameworks that are drawn from a certain economics framework and from a certain experience of health systems development of their countries. We need to be able to develop the confidence to develop our own frameworks. Unlike the biomedical sciences, where discoveries tend to be universal, in the social sciences they are far more context specific and they are far more dependent upon the frameworks of analysis you use. And therefore, it is important for this public health community to engage beyond the documentation, beyond giving them data, beyond being partners who collect case studies for Harvard, to actually becoming centers where you develop theories, much more grounded theoretical frameworks with a developing country perspective, which views healthcare as public goods, respects the principles of equity, solidarity and health rights. And much of it will depend upon methods that we have to develop for this, like case studies have to be developed on ways forward and used in much more creative ways. Thank you.
Thank you, sir. It was such a nice session. It was very informative and enlightening for all, especially for us, the young budding public health professionals. Thank you for the session, sir. And now I request Dr. K.C. Premrajan to present the momentum to the Dr. Sundaraman T, sir. Thank you, sir. Now I request Dr. K.C. Premrajan, sir, to close the session.
with this, we came to the end of this oration. I would again like to thank all the organizers and Professor Sundaraman for having given a very thoughtful and I should say a radically new approach. And I'm sure today's oration would have really made all of us think about the future, the futuristic health system development for the country. Thank you, sir. Your thoughts always be a real driving force for the future public health. Okay, thank you.
Thank you, sir. Thank you, ma'am. Thank you, everyone. And we will move on to the next plenary session, plenary 30, health promotion, which will be held in the main hall, and plenary 40, front of level packaging, held in the to be held in the hall A. Thank you. IPH quiz, hall B. And also, IPH quiz will be held in hall B.
Good morning, Dr. Thankapan.
Good morning after a long time.
How are you doing? Good to see you.
Good to see you again, yes.
Good morning, Dr. Narayan, Dr. Thakur.
Yeah, good morning.
Good morning, Dr. Thakur. We met Dr. Thakur yesterday, of course.
Yeah, I saw both of you, on the award ceremony yesterday.
Yeah. We were there.
Good to see you. Great.
Good morning, sir. Now we'll move on to the next plenary session in the 65th Iphacon 2021, titled Health Promotion Setting-Based Approach. It is my honor and pleasure to welcome all the chairpersons and the dignitaries. So Dr. J.S. Thakur and Dr. J.P. Narayan will be the chairpersons for the day. Dr. J.S. Thakur is a professor in the Department of Community Medicine and School of Public Health at PGIMER, Chandigarh, and he is the president of the World NCD Federation. He is an expert member of the Mission Steering Group of the National Health Mission, chair of the first World NCD Congress held in Chandigarh, and he provides consultancy at international level to many developing countries, including Maldives, Sri Lanka, and Timor-Leste, and the Indian states. He is a member of the Indian expert group on COVID-19 for the ministry and was a team leader for the central team to Punjab and Jammu Kashmir and Maharashtra, Chandigarh. He is the chairman of the COVID-19 prevention and the IEC committee at PGIMER. Thank you very much, sir. Next, Dr. J.P. Narayan. He is a technical advisor for the South Asia Field Epidemiology and Technology Network. He is a senior visiting fellow at the University of New South Wales at Sydney. He has served in the World Health Organization in various capacities at Regional Office for Southeast Asia, Pan American Health Organization, and WHO headquarters in Geneva. Post-retirement from the WHO, he has served as a senior advisor to the Government of India and helped launch the India Epidemic Intelligence Service, or the EIS, in collaboration with the US CDC. He received MBBS and MD degrees from AIIMS, New Delhi, and MPH and MS from Harvard School of Public Health at Boston. It's an honor again to invite you, sir. Now, I request the chairpersons to conduct the proceedings. Thank you.
So I request Dr. J.P. Narayan to start, and then I can.
Okay, thank you. Thank you very much, and good morning. Let me, on behalf of my co-chair, Dr. Thakur, welcome all the delegates attending the conference, both online and offline, to this very important topic of health promotion, the settings approach. Why is this important? Because I think health promotion is very closely linked and also, in fact, designed for disease prevention. So health promotion, disease prevention, they go very much hand in hand. So health promotion is critically important, which is now, I think we recognized recently with COVID, and earlier in HIV also, health promotion was the bedrock of HIV/AIDS prevention. First of all, let me just, very briefly define my understanding of what the settings mean. So broadly, settings can be defined as places where different sets of people engage in their daily activities, be it in school, in workplace, healthcare setting, or even the community, and where a variety of factors come into play that affect our health and well-being, and obviously which needs to be addressed as a part of disease control program. Therefore, settings approach provide an opportunity to design and target health promotion and interventions to reduce these risk factors and thereby prevent disease or ill health from occurring or from getting worse. So the setting approach to health promotion is applicable to a variety of not only communicable disease, but also particularly non-communicable diseases, because it's very much linked with behavior, and also other situations like immunization, even in environmental health, especially climate change. I think health promotion has a critical role to play. So with this very, very short introduction, let me introduce let me welcome as a mentor, because Dr. Thakur is going to be the first speaker, and he has already been introduced. And Dr. Thakur will be speaking on global health and wellness initiative, play, laugh, and grow, progress and challenges. In Hindi, often he talks about khelo khilao, hanso hasao, or bado badhao dusron ko. Yeah? And so with that, a very short introduction, let me invite Dr. Thakur. Over to you, Dr. Thakur, please.
So thank you very much, Dr. Narayan. And at the outset, I am really thankful to the organizers for keeping, health promotion as a plenary session, because, based on our work for the last 25, 30 years, what we have observed is that, health promotion is a neglected area in our country. And we have done some of the studies in the state of Punjab and Haryana, and you will find that, in fact, I have written a paper in our Indian Journal of Community Medicine that is the focus on prevention missing in Indian health programs. And the answer was yes. So Dr. Narayan has already mentioned about school setting, workplace setting, community settings, which are very, very important. And we have the privilege of working in all these settings. For school setting, we have 12 weeks lifestyle intervention models for school children, 20 weeks lifestyle intervention models. And we have also developed a accreditation system for health promoting schools, where schools are categorized based on the standards into platinum, gold, silver, and bronze categories. And I'm happy to share with you that all schools in Chandigarh, they are done the ranking in terms of this accreditation, that is all 206 schools. And Dr. Subhaji Good is there. So we were also invited by the WHO CRO to work on the, the global standards, which has been introduced now for health promoting schools. So we did the assessment in all the Southeast Asian countries. She will be speaking more on that aspect. We also worked for a workplace model for the National NCD program, which is already there under the program. And we also got the opportunity to work for health promoting district model in Punjab and Haryana. This is also called Hoshiarpur Ambala model. And this is already, published. But what I would like to emphasize here, that we really need to invest and do enough funding for health promotion programs in our country, because this preventive component is weak and need to be strengthened. And again, compliment the organizers for keeping it as a plenary session. So I'll stop here, and now coming to my presentation. This is already shared, and may I request the organizers to run the presentation.
Tech team, can you please have the first video?
Ma'am, we have the video of Dr. KRT.
Can you please have Dr. J.S. Thakur's video?
No, we don't have the Dr. J.S. Thakur's video.
It was confirmed yesterday. It was there. I especially checked with the team.
Can you double check, please?
Yeah, and same is true for Dr. Subhaji Good's video. Kindly check also.
Give me 1 minute. Give me 1 minute, sir.
I'm sharing from my end.
All right. Yes, Dr. Thakur, over to you.
I think, are you running my video, which is already recorded, or shall I present? I can take the question at the end because.
So I've started screen sharing from my side.
Okay, please.
Okay, then. Please go ahead.
Oh, I need to speak. So I'll.
So greeting to the delegates of Iphacon held at Pondicherry. I'm Dr. J.S. Thakur from PGI Chandigarh. I shall be speaking on Global Health and Wellness Initiative, Play, Laugh and Grow, and what are the progress and challenges. So in this presentation, I would like to take you to background. What is this initiative all about? What are the strategies and what is the progress which we have achieved over a period of time? If we take non-communicable diseases, 70 to 80% of non-communicable diseases are preventable, but there is a little focus on prevention. World NCD Federation, which was established in 2015, is working on public health approaches for global NCD agenda. And our focus is mainly on prevention, surveillance, and disease management. That is, those who are healthy should remain healthy, those who are at risk should be identified early, and those who are suffering from the disease should get access to the treatment. Now, coming to the objectives of this Global Health and Wellness Initiative, it was initiated for building a global platform to engage public towards health promotion and achievement of SDGs. And at the national level, it also complement and supplement the Health and Wellness Centers initiative under the Ayushman Bharat and the integration of his national health program. Now, why we need this initiative? We need to understand this illness and wellness. Most of the time we are dealing in illness, and in the national NCD program also, the focus is mainly on illness. But what is really required is the wellness, and wellness will come from working with the population, that is the health promotion, and in health promotion, especially focusing on different setting-based approach, that is school setting, workplace setting, community setting, and as well having this yoga as in the mainstream. We worked in Punjab and Haryana state on a health promoting district model, and we took one district in Punjab and Haryana to study that how different national health program are working, what is the extent of focus on health promotion, and this is published in the International Journal of Non-Communicable Diseases. So under this project, we did the analysis of the budget for prevention and wellness in these two states. And you will find that there was a very minimal budget of the total budget, that is 0.6% in Punjab and 1.2% in Haryana out of the total national health mission budget. We also did further analysis and found that 75% of this budget goes for printing and 25% for advertisement. And hardly there is nothing which is available for prevention. And we also worked out that how much is required. It is almost 5% budget if it is allocated under the National Health Mission. We can adequately cover this health promotion component, but it appears to be a distant dream. Now, coming to this initiative, Global Health and Wellness Initiative, Play, Laugh and Grow, and the Indian version is Khelo, Haso, Hasao, Bado or Badhao, India. So the partner in this campaign is World NCD Federation, the Ministry of Health and Family Welfare, the PGI Chandigarh, Indian Association of Preventive and Social Medicine, IPHA, and the key component of this global health and wellness initiative are health promotion through different settings, multi-sectoral participation, and monitoring and evaluation at different levels. Now, this initiative was launched on 2nd March by Mrs. Vandana Gurnani, Additional Secretary and Mission Director, National Health Mission. And the key feature of this initiative are integration, convergence, multi-sectoral participation through, working on health promoting district model, which we developed in Hoshiarpur and Ambala district of Punjab and Haryana, which is also called Hoshiarpur Ambala model, and health promoting schools, that is the accreditation system for health promoting schools. We have also an institutional mechanism, and the Center for Sustainable Development, Health and Wellness is providing that, and some resource material has also been developed. This initiative also have linkage with the SDGs, and it also caters to SDG 1, 2, 3, 4, 6, 7, 11, and 17. And we all are working towards realizing for SDGs, so this initiative will be contributing in that direction. Now, in this initiative, there are three main components, and how this initiative will integrate and contribute to health and wellness in India. This play or the Khelo will integrate Khelo India, Fit India, Eat Right India, Poshan Abhiyan. The Laugh or Haso or Hasao component will integrate National Mental Health Program, Jan Andolan, Positive Attitude, National Ayush Mission, and the Grow, that is Bado or Badao, will focus on whole of the society and whole of the government approach, and will also contribute to the National Multi-Sectoral Action Plan, Swachh Bharat, Skill India. And the fourth component, which was added later on, and understand, Samjo or Samjao, that is, will integrate National Health Mission, National Nutrition Mission, Jan Andolan, and behavior change communication at different levels. Coming to the strategies and activities, this is basically a global, regional, and national advocacy and the partnership which is being promoted. We have engagement with the service provider. We have called for ideas to propagate the initiative, induction workshops, capacity building workshops, engagement of the general public, engagement of the media, and implementation of standards for health promoting workplaces and the districts under this initiative. Now, coming to the operational aspect, a global advocacy is being undertaken through the regional advocacy meeting by the regional offices of the World Density Federation. In India, it will be operationalized through the Health and Wellness Center under the Ayushman Bharat. The focus is on multi-sectoral empowerment model and a decentralized integrated approach. And the key stakeholders are center and state government, the public health organization, the community medicine department of medical colleges, setting-based approaches that is focused on school, workplaces, and community, as well as civil society. So now, what is the progress which has been achieved so far? The campaign is already launched, as I mentioned. There was a public forum in Tri-City of Chandigarh, Mohali, and Panchkula on 6 March. We have a promotional video which was released by the Director General Health Services, Government of India. IPHA and IAPSM both are our partner for this initiative, and a national strategic planning workshop was held on 15th of May, and there is also an International Advisory Committee which has met on 7th of June. This just a brief about this Center for Sustainable Development, Health and Wellness. This center has been established in Buda village in Punjab, which is around 6 kilometers from PGI Chandigarh, where we have adopted one village to develop as a demonstration model, and center will be functioning there, and it will provide the institutional support to this initiative. This is the brochure of this campaign. In this village, we will be involving Panchayati Raj institution, the agriculture department, the health department, and other later department, so that there is a multi-sectoral participation to develop it as a smart, sustainable village. We have already, as I mentioned, some advocacy material, so short video on global health and wellness initiative. Mr. Milkha Singh was our brand ambassador. Unfortunately, he is no more, but his message is still with us. We have 2 publications now. There is the editorial in International Journal of Non-Communicable Diseases, and also in this is a bulletin of Epidemiological Foundation of India. lot of coverage to this initiative in the national and the local media. Just to summarize, I would like to emphasize that it is high time to shift the focus on health promotion with strategic focus on multi-sectoral collaboration to reduce the burden of disease at the national and the global level. There is a huge institutional and individual capacity gap in health promotion which need to be built. Center for Sustainable Development, Health and Wellness is an effort in that direction to utilize health and wellness with multi-sectoral approach and realizing the SDGs. This global initiative will also complement and supplement the various national health programs under the National Health Mission and Health and Wellness Centers under the Ayushman Bharat. And it is very important that we should have adequate resource, that is the separate budget should be earmarked for strengthening health promotion component under Health Mission in India. And we are just asking for 5% of the budget should be earmarked for this purpose. This is about World NCD Federation, which is spearheading this campaign at the national and the global level. And I'm also happy to share with you, beside, we have also come up with the two other centers, that is Center of Excellence in Evidence-Based Research, where we are undertaking systematic review and meta-analysis, and there is a Center for Implementation Sciences and Research, which is focusing on implementation sciencing, and we have a separate award session during this Iphacon. We have publications which are available, and it is my pleasure to invite all of you to be engaged as a volunteer in this campaign, and you can contribute in any way, and kindly visit our site, worldncdfederation.org for further details. So thank you very much for your patient hearing. Namaskar.
Thank you. Thank you very much, Dr. Thakur. I think one very important lesson that we learned from COVID pandemic is the need to invest more on public health and more on health promotion now and in the future, with a focus on integration or mainstreaming into different programs, and also on multi-sectoral approach. Indeed, the concept of health and wellness initiative is applicable. In fact, it goes beyond NCDs. I think it's generally on health and well-being. And also you mentioned about link with SDG. And so, and thank you very much. Now, I just like to inform that we will have question answers at the end of all the four presentations. With that, now I would invite Professor K.R. Thankampan, who's Dean, School of Medicine and Public Health. Obviously, I think the longer introduction is on the screen. So he is Dean, School of Medicine and Public Health, Professor, Department of Public Health and Community Medicine, Central University of Kerala at Kasaragod. He is a public health physician trained in India at Harvard School of Public Health with interest in non-communicable diseases and their risk factors. He's head of Ajuta Menon Center of Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum, for about 20 years. He has more than 250 publications, including those in leading international medical journals. Dr. Thankampan will be speaking on Health and Wellness Center as a strategic choice for health promotion in India. I think this is also a very critically important area. Over to you, Dr. Thankampan.
Hope my presentation is already there in the recorder. Yeah, I think so.
Start the recording, please.
Good afternoon.
Yeah.
I will be presenting the topic on health and wellness centers as a strategic choice for health promotion in India. Health and wellness centers in India. There are 150 peripheral health institutions. Sub-centers and primary health centers will be developed as health and wellness centers in India. A sub-center in India is catering to a population of 5,000 in plain areas and 3,000 in geographically difficult to reach areas, whereas a primary health center caters to a population of 30,000 and 20,000 respectively. These health and wellness centers are expected to provide a comprehensive primary health care. How do we promote health promotion through health and wellness centers? I think the following activities should be promoted through these health and wellness centers. One is healthy diet, physical activity, tobacco prevention and control, alcohol prevention and control, reducing indoor air pollution, all belonging to non-communicable disease prevention and control. And in addition, I think we should also promote hygienic practices like water supply and sanitation and hygienic practices. So let us take all these issues one by one. Healthy diet, first of all. I think we need to promote context-specific healthy dietary practices. Childhood undernutrition is a major challenge we are facing in India. So I think that should be a priority in health promotion in all these health and wellness centers to address the undernutrition, particularly among children and women. Encourage locally available fruits and vegetables in order to address NCD risk factors. Encourage vegetable cultivation and consumption of green leafy vegetables and fresh vegetables so that people can eat pesticide-free and fresh green leafy vegetables. Low salt and sugar, sugary products should be encouraged. Less amount of oil, avoid trans fats. These are all activities that can be promoted through these centers. And we should also coordinate with the schools in that area so that we can promote healthy eating practices and policies at all the schools. Regarding tobacco prevention and control, I think all of you know tobacco is one of the major killers, and we should focus on prevention and control of tobacco. Ensure that no tobacco users under the area of the health and wellness centers so that nobody starts tobacco. Work closely with the schools and make sure that the Cigarettes and Other Tobacco Products Act are implemented in all the schools under the area of these wellness centers. Ban tobacco sales to minors as per the CODPA Act. All advertisements on tobacco should be banned as per the CODPA. Opportunity screening of all patients attending health and wellness centers so that we can identify tobacco users and address them with brief intervention so that they will stop tobacco. And implement tobacco-free homes so that there's nobody under this area, nobody smokes in the homes. Physical activity promotion, work closely with the schools and make sure that all the schools follow the guidelines for physical education classes. And teachers also participate in physical education class as per the recommendation. Usually in most of the schools, education boards, they also recommend participation of not only students, also teachers. Yoga can be promoted in all institutions so that people in all age groups can participate in some form of physical activity. This can also be an entry point for physical activity for other age groups. At least 30 minutes of moderate physical activity for adults and 1 hour for children need to be ensured in all the health and wellness centers areas. If playgrounds are not available in schools, coordinate with the local governments to provide these facilities. Alcohol prevention and control. This is another major NCD risk factor. Education about the harmful effects of alcohol. Ensure that the government policies, both the central and state government policies on alcohol, are implemented in the areas covered by the health and wellness centers. coordinate with the schools in the area and make sure that alcohol products are not allowed in the school campuses. Identify those who are addicted to alcohol and guide them or their family members for de-addiction services available within the area of health and wellness centers or in the nearest area. Domestic violence may be associated with alcohol addiction, and this may be kept in mind when such cases are reported to the staff of the health and wellness centers. Other indirect effects of alcoholism, such as road traffic accidents, suicides, homicides, etc., may also be communicated to the population so that alcohol consumption is restricted or avoided. Reducing indoor air pollution. Educate the community about the ill effects of indoor air pollution, particularly for women and children. Encourage changing to cleaner fuels and inform the facilities provided by the national and state governments for cleaner fuels. Coordinate with the local self-governments for changing to the cleaner fuels. Water supply and sanitation and hygienic practices. Importance of clean water, sanitation, and hygienic practices are important health promotion measures. Linkage between communicable diseases and non-communicable diseases, which was clear in the current pandemic of COVID-19. It's very clearly indicate that we have to work jointly for non-communicable and communicable diseases prevention, because there's a strong linkage between communicable and non-communicable diseases, as was evident in this current pandemic, because the COVID-19 was affecting and the mortality was much higher among those with the NCDs, like diabetes, hypertension, cardiovascular disease, cancer, and those people who are receiving dialysis, etc. So it's very important to address these water supply and sanitation practices, particularly, these social distancing, mask wearing, all these things. So health and wellness centers can be strategic choice for all the health promotion activities in the community. So what are the opportunities and challenges for these centers? India has a strong primary health care system in place. For example, as per the latest data, we have more than 160,000 sub-centers, including 3,302 urban sub-centers. More than 30,000 primary health centers, including 5,190 urban primary health centers. So totally we have more than 190,000, much more than the 150,000 health and wellness centers planned. In addition, there is one Anganwadi worker and one accredited social health activist, ASHAs, for every 1,000 population. So in the year 2019, there was one sub-center available for a population of 5,616 against the norm of 5,000. And one PSC for an average population of 35,567 against the norm of 30,000. So which means we have a gap in this primary health centers and sub-centers, and these gaps need to be filled. And another point, important point or the challenge is that the pay structure for the Anganwadi workers and ASHAs need to be revised as per now. So many studies, they have recommended this enhancement. So in order to address these challenges, I think the health allocation, the budgetary allocation for health needs to be increased. As of now, I think we are spending only about 1% of GDP. And we had a plan, I think, as per the latest national health policy, we were planning to increase this health allocation to 2.5% of GDP. I think we should try for that. Then only I think these gaps can be filled and the primary healthcare system and the health and wellness centers can be encouraged and supported throughout India. Thank you very much for your attention.
Thank you very much, Professor Thankampan. I'm sorry I'm not able to start the video. So anyway, I think I've been, there is, The co-host has asked you to start your video. Okay, now it's working. Yeah. All right. Okay, thank you so much for raising many issues, very important issues. And indeed, I believe this health and wellness centers provide a unique opportunity for us to strengthen primary health care, maybe achieve health for all in due course of time, and focus on primary and secondary prevention. So I think there are many things that you mentioned about, the ASHAs, their role they're playing. And in many places, I think the salary or remuneration they're getting is abysmal. So I think government need to focus on many of these areas. And with that, I'd like to hand over to Dr. Thakur as my co-chair, please.
Thank you, Dr. Narayan. So can I have the CV of the next Dr. Sitanshu Kar? So it is indeed a great pleasure for me to introduce Dr. Sitanshu Kar, who is a professor and head preventive and social medicine JIPMER. He is also the organizing secretary of this Iphacon. So he is a busy man, but it is his commitment to health promotion that he decided to join. He is also the associate dean research JIPMER. He has done his MD from PGI, and I have the privilege of guiding him during his MD. So this is indeed a privilege for me. And also later he worked as a colleague with me in the WHO as well. He is a FAMER fellow, Fulbright fellow, and also John Hopkins Scholar Program offered by the Institute for Global Tobacco Control. He has many awards, best research paper in the first World Density Congress organized at PGI in 2017, which we organized. No bias at all, because I was not involved in any selection process. Best paper in non-communicable diseases session at the 60th National Annual Conference of IPHA at Dehradun, and also a core member of the NTTC since 2020. He has 150 research publication, 1 book and 12 chapters with 10 technical reports, and his area of interest is chronic disease, epidemiology, tobacco control, health technology assessment, health system, medical education, and it is indeed a great pleasure to introducing him, and he will be speaking on the topic on the setting-based approaches, which is the key theme of this, that is school, workplaces, and community. So over to Dr. Sitanshu.
Thank you so much, sir. It is indeed a pleasure to be introduced by your own guide, and whatever the principles of NCD epidemiology I have learned, it is all because of you. I still remember the day when I came up with an idea about doing something in HIV epidemiology, and you told, no, we should focus more on NCDs. That's how it all started. I have a video to present over here, sir. Thank you so much for all the learning opportunities that you have provided me and my institution over a period of time. Thank you so much, sir. Greetings to all the participants. I am Sitanshu Shekharkar, currently working as professor in the Department of Preventive and Social Medicine, JIPMER Pondicherry. So today we are going to talk about settings-based approaches, schools, workplace, and community. So the plan of the session is as follows. First, we'll be talking about why we should focus on healthy settings, experience of implementing settings-based approaches in different settings like healthy workplace, health promoting schools, and healthy community. And finally, the lessons that we have learned by implementing these strategies in various settings. Now, as per the Ottawa Charter 1986, what is the health promotion is the process of enabling people to increase control over and to improve their health. So this definition leads to 3 approaches to health promotion, that is issue-based, population-based, and settings-based. Issue-based approaches address specific issues and promotes healthy policy, healthy practices like unhealthy diet, tobacco, harmful use of alcohol. Similarly, population-based approach will focus on specific age groups like children. Okay, population-based strategies target specific age groups for prevention of disease and promotion of health among children and elderly. Settings-based approach is an approach which promotes health in an establishment. The establishments are basically healthy workplaces, schools, villages, districts, cities, markets, and hospitals. The next question that should come to our mind is, what is a setting? The setting as per WHO is defined as a place or social context in which people engage in daily activities, in which environmental, organizational, and personal factors interact to affect health and well-being. Now, as per WHO, there are various types of settings that we come across, but today we are going to talk about healthy workplaces, health promoting schools, and about healthy communities. How to develop a healthy workplace? So the first thing that should come to our mind is, it is important to have a joint planning mechanism. The joint planning should be done by the industry sector and health department. By doing a joint planning, we try to create something called Healthy Workplace Committee with involvement of all stakeholders. This Healthy Workplace Committee will do certain functions. That first thing to start with is evaluation of current status. That has got two components. One, to do a workplace level situational analysis, and the second is to focus on employee level health behavior survey. In the employees level health behavior survey, we'll try to look at NCD risk factor profiling, looking at using various tools available for it. It can be an NCD light performer or something called IDRS. So the second component of doing the behavior survey will have occupational hazard assessment. The third one is assessment of mental health status. So similarly, when we look at workplace level assessment, what are the facilities available in the workplace, whether it is a disabled friendly workplace, whether it is baby friendly workplace or not, that is assessed through this evaluation of current status. Based on the findings of these two surveys, a joint plan of action is formulated by the industry and health department. So following that particular development of plan, there are multiple rounds of discussions are conducted to identify policies that will promote health in this particular setting. Now I'll take you to an example where the healthy workplace model was implemented in the Union Territory of Chandigarh, where it was conducted among 3 industries with a population of 947. As I told you, the first component of this Healthy Workplace Committee is to do a situational analysis. Here, this table represents the demographic and the distribution of self-reported behavioral risk factors, self-reported disease profile, and also physical measurement. So having done this measurement and trying to identify what is the problem that this particular employees are facing in this industry, the Healthy Workplace Environment Committee, they try to identify interventions under these 3 following headings. Nice part. So based on the findings of the baseline survey, what the Healthy Workplace Committee proposed is to have interventions under the 3 following headings, like promoting healthy practices, physical work environment, psychosocial work environment. So, and the interventions were divided into 3 broad headings like core, expanded, and optional categories, as depicted by different colors in this particular diagram. The similar experience was also done in Pondicherry. We implemented something called Nallam initiative in a IT sector with a workforce of around 2,500. And we also followed the similar strategies. First, to look at their baseline health status assessment. and then developed an intervention which will help them to promote health in their respective settings. Coming to the second setting, where we will be talking about health promoting schools. The first thing is why we should focus on health promoting school is over 90% of all children are in the primary school and 80% of children are in lower secondary schools. UNESCO and WHO has urged countries to make every school a health promoting school. Now, how do we start making a school as a health promoting school? The principles of making a health promoting school is similar to how we make a healthy workplace. So here also we start with a joint planning mechanism by Department of Education and Health Department, which leads to formation of a committee called School Health Committee. We do current situation, evaluate the current status among the health students and also at the school level. Then we develop a plan of action. The plan of actions can be classified under all the following headings, but to make it more concrete, let me read some of the policies. Like we focus on the school health policies, look at the physical environment to provide safe playgrounds, looking at the social environment to have anti-bullying environment, links with the parents and communities, and also promote their personal health skills and access to school health services. Now, the same experience was also conducted in Chandigarh, where the schools were categorized into different categories like bronze, silver, gold, and platinum, using a predefined criteria in a 2 to 3 years intervention study, and it was tracked over a period of 3 years to look at what proportion of schools move from one category to the other. That means what proportion changed the status from bronze to silver, from silver to gold, and gold to platinum. And ultimately, it was concluded that the school accreditation was feasible and leads to significant improvement in the accreditation level and health behavior of the children in the school. Now, currently, WHO has also proposed global standards and standard statements of development of indicators for school health promoting schools, which starts from having a government policies and resources to school governance, looking at school governance and leadership, looking at the school curriculum, how to promote or support physical, social, emotional, and psychological aspects, school physical environment, and finally linking school health services with the health system and trying to look at their development in a more holistic manner. Coming to the third component, where we look at the characteristics of a healthy community. The characteristics of a healthy community also has got certain components, like physical environment should be clean and safe, environment that promotes social harmony and actively involves everyone. So the community need is also assessed and trying to look at how to address their need in a better way, in a more comprehensive and collaborative way. The final thing is the important component of sustainability is also kept in mind, how we can use a sustainable use of available resources for all this community. So with this background in mind, so the final lessons that we have learned by looking at this, all the three experiences that we have, is the first point that we need to understand is there should be a willingness and commitment from both the sectors, from all the relevant stakeholders to have a committee to plan accordingly and also implement those planning over a period of time. We should also work as a team. All the stakeholders should come together and try to work for the betterment of the community. It is not a single time activity, because development of committee and also identifying the policies for implementation is a continuous process. Every time the need evolves, and people should be doing this over a period of time, one time activity, and we should not stop it. So that is what it means by continuous process. The implementation or the intervention what we are trying to do should be need-based, should be culturally appropriate, should be context-specific, and it should be evidence-driven. So without that, then it will not work. Finally, involving community and empowering community is the key strategy that we should all remember. So with this, I'll stop my session, and I'll be very happy to have your question and answers subsequently. Thank you so much for a patient listening.
So thank you very much, Dr. Sitanshu, for very nicely covering the setting-based approach in health promotion, covering the school setting, the workplace setting, and the community setting, and the issues which are involved. And you have also given the good examples of workplace experience from Chandigarh, for school setting experience from WHO Chandigarh, as well as healthier communities. And also very rightly concluded by saying that there are lessons which need to be learned for building a credible health promotion program with the commitment, with the team effort, and quality assurance is a continuous process, and it should be need-based, context-specific, and also we should keep the model of this empowerment model in mind, so that communities can take control of their health. And so once again, thank you very much. And if there are any questions, you can, the participants are requested to put in the chat box, or we can also ask directly. So thank you, Dr. Sitanshu. So moving to the next presentation. Can I have the CV of the next presenter? So the next presenter is Dr. Subhaji Good, and she's a regional advisor for health promotion and social determinant of health, the WHO Regional Office for Southeast Asia region. I'm very happy that I have the privilege of working with her as a counterpart in the WHO country office. She has initiated a number of works in the WHO to address the determinants of health that lie outside the health sector, and working with the non-governmental agencies in various areas. She played an active role in development of regional framework for health in all policies, framework for intersectoral action, guidance on health equity, and impact assessment. She has 25 years of international experience and 10 years in the UN health system, which include working in Africa region as well as in Southeast Asia region. So she will be speaking on a very important topic of global standards for health promoting schools, and what are the experiences from Southeast Asia, and what are the implementation challenges. So over to Dr. Subhaji, and before her video starts, would you like to speak something before your video starts?
Thank you very much, Dr. Thakur. I hope you can hear me clearly.
Yes.
Greeting everyone, and greeting Dr. Janurai. It's been a long time, and all the audience in this meeting and the host for this important conference. I'm glad to be here, and I'm glad to hear what you're talking about, the health and well-being, which is very much also aligned with our 10th Global Conference for Health Promotion this year. It will be happening in December, from 13 to 15 of December, virtually, because we're still having many countries locked down. It was originally planned for United Arab Emirates to host this conference. But I want to echo what you have mentioned earlier. And this health promotion in the new generations is go beyond health sectors. And that's why we talk about well-being. We have the big 5P to address on health and well-being. One is on the people. And of course, we want to talk about people in every age group, every types, every characters. And also we talk about the planet. So we follow the 5P to promote health and well-being. People cannot live in the planet that's still not healthy, not promoting the inducive environments for live, laugh, and play, as you say. And also, we've emphasized the issues on peace. Now the world is really need that kind of peace to tackle both health and ecological emergency. We talk about the prosperity, and also the important part is the partnership, which is the action that we used to call the multi-sectoral actions, intersectoral action. But more than ever, we need the partnership. So the 10th Global Conference, we follow that 5 principles of people, planet, peace, prosperity, and partnership. And we will have a deep dive on different characteristic settings that you're talking about, and also make sure that we will be able to create the world where all people can enjoy healthy life and well-being and living in a healthy, safety, supportive environment, and also inclusive society. So there's a big agenda coming up for the Global Conference for Health Promotion this year. And what we are doing currently, that I'm here, what you're talking about the settings, besides schools, we also have city and community. We also have new effective healthy cities initiative and new guidance and new indicators as well. Regional office also built the regional laboratory. This is a social laboratory to create urban governance for health and well-being, which is also resonate with the 10th Global Conference. And I'm glad for this meeting. I would like to emphasize on, as you asked, on the health promoting schools, the global standard. I think it's better to see the reality. And also I've produced videos to share with you what health promoting schools would look like in practice and how it's going to benefit others. And it's also explained different standards in that video. I will be standing by after the video to listen to your questions and answer. Over to you, Dr. Thakur.
Thank you, Subhaji, and may I request the organizers to play the video, please.
Imagine a world filled with the joy and exuberance of young children. Imagine a world where schools are a safe and secure place, where children can be at their best, where they can discover and express themselves, a place where they can give wings to their dreams. Imagine schools where teachers, staffs, and parents happily engage in making schools a beautiful, healthy place, where all can learn, and schools, homes, and communities can stay connected. Imagine a world where all children everywhere, having acquired the knowledge and skills, the attitudes, behaviors, and experiences, become well-rounded, healthy, happy, educated, caring, and active members of the society. This is the vision and dream of a health-promoting school. Wow, that's wonderful! I would very much like to be a part of this world. So what is a health-promoting school?
A health-promoting school, or HPS for short, is a whole school approach where the school provides the foundation and a setting for healthy living, learning, and working. At its core, it fosters the physical, social, emotional, and psychological conditions for health as well as for positive educational outcomes. Did you know that HPS approach was first articulated by WHO, UNESCO, and UNICEF in 1995 and adopted in over 90 countries and territories? It has evolved over the years and become even more comprehensive and inclusive.
Interesting. What does this approach entail?
The HPS approach goes beyond the mere delivery of health education, health services, and integration of health in the school curriculum. It encompasses the whole school policy, governance, educational system, the school's physical and social environment, and conscious efforts to create an enabling milieu that promotes physical and mental health of everyone in the school. It also extends to parents and communities, ensuring social well-being of children and adolescents.
The WHO Regional Director for Southeast Asia endorses the HPS approach, which recognizes that health and education are fundamental and intrinsic to human development. It is a transformative and collaborative approach that brings together students, parents, families, local communities, and governance systems to enhance lifelong learning and increase the health and well-being of students, staff, and the community. Truly, the link between education and health has never been more apparent. This is especially true in today's times, where we are seeing a disruption in the education and well-being of children.
Absolutely. In June 2021, UNESCO and the World Health Organization further stepped on this movement by launching the Global Standards for Health Promoting Schools, a resource package for schools to improve the health and well-being of 1.9 billion school-aged children and adolescents. The importance of the HPS approach has become even more evident in view of the closure of many schools around the world during the COVID-19 pandemic.
What are some of the benefits of health promoting school?
There are huge benefits. Let me share a few voices from the ground.
The health promoting schools approach improves health, well-being of students, staff, and the wider community. The healthier teachers are also role model for the healthier lifestyle that children can adopt.
HPS establish foundational knowledge, attitude, and behavior to enhance health and well-being and make healthier choices when we grow up.
It improves working environment, quality of learning and teaching, and leads to better educational outcomes. With comprehensive health promoting school policy, we can provide better coordinated services and create an enabling environment for children in every school.
A key benefit of health promoting schools is multi-sectoral collaborations that support education, health, and well-being. It benefits everyone involved.
Effective implementation of health promoting schools can reduce the burden of non-communicable diseases among children and adolescents, thereby leading to healthier life.
This approach leads to more equitable health and educational outcomes, including increased gender equality.
That's awesome! The benefits clearly highlight how important the HPS approach is for each one of us and the society as a whole.
Absolutely. An effective school health program can be one of the most cost-effective investment a nation can make to simultaneously improve education and health.
Tell me more about the recently launched global standards. I understand that this will ensure that there is greater consistency and adherence to quality.
The global standards and indicators are the backbone of the health promoting schools. They also provide a vision and a roadmap to make every school a health promoting school.
This is excellent. Please elaborate on these global standards.
There are 8 global standards for health promoting school systems. Let's look at Standard 5, 6, 7, and 8 to understand how a health promoting school looks like. Standard 5 highlights that the school curriculum promotes physical, social, emotional, and psychological aspects of student health and well-being. Standard 6 is about the school having a safe and supportive social emotional environment to promote the well-being, confidence, and mutual respect of all its members and local communities. Standard 7 urges that the school has a healthy, safe, secure, accessible, and inclusive physical environment. Standard 8 emphasizes that all students must have access to comprehensive school-based or school-linked health services that address their physical, emotional, psychosocial, and educational healthcare needs.
Wow, that sounds like a dream school. How can this dream be realized?
To answer that, we must look at Standard 1 to 4. These are the systems and governance backbone of this approach. Standard 1 is vital. It is aimed at the whole of government commitment and investment in making every school a health-promoting school. Standard 2 is about the school's commitment and investment in a whole school approach to being a health-promoting school, which is effectively reflected in school policies and plans. The focus of Standard 3 is on the whole school model of school governance and leadership that empowers the stakeholders and supports a health-promoting school. Finally, Standard 4 signifies that the entire school community actively engages and collaborates with the local stakeholders as partners for health-promoting schools.
Wow, these standards are designed to create schools that nurture education and health. They also equip students with the knowledge and skills for their future well-being, employability, and life prospects.
True. Importantly, it is these standards and how well they are implemented in letter and spirit that differentiate a health-promoting school from others. The standards are also supported by a detailed implementation guidance around scoping, designing, implementing, monitoring, and evaluation.
I never realized how comprehensive this approach is. So, what is stopping us from making health-promoting schools a reality?
Every country and system has its own limitations. However, instead of limitations and challenges, let's look at what would make the health-promoting school's vision a reality. Perhaps a kind of a checklist to guide our efforts. Do we have a national policy to advocate and implement health-promoting schools? Is there a strong leadership at all levels? Are we allocating dedicated and sustained resources? Are there strong intersectoral coordination mechanisms for effective implementation to support every type of school? Is the community participating fully and effectively? Are the school programs and curriculum evidence-based and comprehensive to include physical, social, emotional, and psychological aspects of student health and well-being? Are the school health services comprehensive to cover children, adolescents, teachers, and staff in the school? Are the schools prepared to respond to pandemics like COVID-19 and future public health emergencies? Looking at the global standards and checklist, it is evident that the Health Promoting School Initiative is an investment in the current and future health of young people and communities.
The initiative contributes to WHO's triple billion targets to improve the health of billions by 2023 and the Global Education 2030 agenda coordinated by UNESCO. To bring this vision to reality, each of us need to play an active role in implementing the HPS approach, take concrete actions, and commit ourselves to this goal. WHO calls upon member states in the WHO Southeast Asia region countries to affirm their commitment to make every school a health-promoting school. It is time to ensure that no child, teacher, and school is left behind in the quest for health for all and lifelong learning.
Thank you very much,
Dr.
Dr.
Yes, and I just want to add to the videos that next month in October, we're going to have the interministerial meeting on health promoting schools, where we invite Ministry of Health and Ministry of Education. There will be call for actions from the ministries. And also we have regional directors of UN agencies, WHO, UNICEF, UNFPA, World Food Programs, UNESCO. They're going to join together to deliver also the declarations from the regional director to support investments for health promoting school. So these are very high time for health promoting schools, and I appreciate your programs that include this subject in the public health agenda. Thank you so much.
So thank you, Dr. Subhaji, for very nicely covering the topic of HPS and global standards for health promoting schools. And I'm sure that they are going to be game changers in the times to come. And also covering the other settings like healthy cities and the social laboratory concept, and also updating us on the forthcoming events of Global Health Promotion Conference as well as interministerial meeting. I have been reminded by the organizers that there is a time constraint. So before we close, can we have one or two quick questions if they are there? Anybody want to ask a question?
Sir, we don't have any questions in the chat box, sir.
Okay.
Okay.
And
So
maybe
there
in the interest of time, if you could wind it up. Thank you so much, sir. So sorry to do that, but yeah.
No, it's all right. So I think I must congratulate all the four speakers for, amply highlighting the topic of health promotion, since this conference is India specific. And the government has come up with this health and wellness centers program under the Ayushman Bharat mission. But there are 2-3 things which I would like to highlight, that it is more of, to me, it more appears to be a care model than a wellness model. So wellness will come if we work with the communities, we work with the schools, workplaces. So there is no mention of that. We have tried to do some advocacy at the level of the ministry and with the state government that health and wellness should be a true reflection. And secondly, in my opinion, we are just doing a lip service in this country as far as prevention or health promotion is concerned. So we really need to have adequate resources available for health promotion if we want to see the results. And if we take the example, 70 to 80% of the NCDs are preventable. So with this brief remark, I hand over to Dr. JP Narayan for formally closing the session. And with his concluding.
Okay, thank you. Thank you very much, Dr. Thakur. And thank you, Subhaji. Good to see you. I just like to take 1 minute, maybe highlight few points as perhaps guiding principles for a health promotion program or strategy. Number one, the health promotion should be evidence-based. Number two, health promotion should be comprehensive. It was already mentioned. With that, I think as far as communication is concerned, it can be both media approach as well as interpersonal approach, especially when behavior change is. Third is obviously the partnership or multi-sectoral engagement, particularly community for which the health promotion program is being planned and implemented. And fourth, I think we have seen in HIV program particularly, the creation of enabling environment. Without the enabling environment, behavior change, that is the main design, behavior change cannot take place. Because like, for example, in HIV, you cannot promote condom if condoms are not available. Or there is, the society has stigma and things like that. And finally, I think from the program implementation point of view at various settings, I think what is important is to have a policy, and second is to have a plan of action. I think these two, in every settings, I think it's important. This is what was done in the context of HIV and also in the context of TB. And obviously, I think within the context of NCDs as well, I think it's critically important. With that, let me thank all the speakers for their excellent, comprehensive presentations. I learned a lot today because I've been out of touch for quite some time. And all the delegates who tuned in. And so with that, I think we close the session. Unfortunately, it usually happens. We have, I think time is always a constraint. So with that, I like to thank all and thank you very much. Dr. Thakur, I think maybe a good idea to have one Hasso Asao.
Yes. Let us
have a laughing session. Okay, over to you. Thank you very much.
Okay, so thank you so much, sir. That session was a very interesting session. So we close the session by thanking the chairs, Professor J.S. Thakur and Dr. J.P. Narayan, sir. Thank you so much, and all the speakers. So we move on to the next session. Over to you, Dr. Stuti.
Thank you so much, sir. So with this, we move on to the next session for today. So up next, we have a session on the race towards endgame tobacco. And joining us here as chairs, we have Dr. Kavita Vasudevan and Dr. Sudhanshu Shekharkar. So Dr. Kavita is the professor and head of the Department of Community Medicine at the Indira Gandhi Medical College and Research Institute of Puducherry. Ma'am has completed her MBBS and her master's from JIPMER and has over 17 years of teaching experience. She is a FAMER Fellow from the PSG FAMER Regional Institute and a Nodal Officer for Model Rural Health Research Institute, MRHRU, Puducherry. She is also the MEU Coordinator for IGMCRI, the NTEP Zonal Task Force or Vice Chair Member of the State AEFI Committee. She is also the DST State Expert of the Appraisal Committee, and ma'am has over 42 publications to her credit. I would also take this opportunity to thank Dr. Swasti Charan, who could not join us as chair today due to some unforeseen commitments. So filling in for him today, we have our second chairperson, Dr. Sudhanshu Shekharkar, professor and head of the Department of Preventive and Social Medicine, JIPMER, and the organizing chairperson of the Iphacon 2021. Over to you, sir and ma'am.
A very good morning to all the participants. I welcome you all to the 65th Iphacon 2021 plenary 15. In today's plenary titled The Race Towards Endgame Tobacco, we have 4 eminent speakers who have contributed widely to the tobacco control activities. Tobacco endgame concept envisages a tobacco-free future. It reorients the discussion towards plans for ending the tobacco epidemic through various policy approaches. So in today's session, we have 4 speakers, as I said, and I welcome the first speaker, Dr. Sonu Goyal. Dr. Sonu Goyal is the professor in the Department of Community Medicine at PGI Chandigarh. He has done his MBBS and MD from IGMC Shimla and PhD in Human Resource Management. He's also an adjunct associate clinical professor in the School of Medicine, Faculty of Education and Health Sciences, University of Limerick, Ireland, and honorary professor in the Faculty of Human and Health Sciences at Swansea University, United Kingdom. He has 20 years of experience in the field of public health. He's a Deputy Medical Superintendent and Purchase Officer for PGI Chandigarh. He has more than 120 papers, authored 38 chapters, produced 12 films on national health programs. He's a recipient of various awards, including Young Researcher Award by IAPSM Ford Foundation, Harcharan Singh Oration Award, Vasudeva Oration Award, and many more to his credit. So now I invite Dr. Sonu Goyal for his session on reflections. What is the tobacco endgame? Over to you, sir.
I am Dr. Sonu Goyal, working as Professor of Health Management at Postgraduate Institute of Medical Education and Research. And I welcome you all to this Indian Public Health Conference being organized, association conference being hosted by JIPMER Puducherry. It gives me immense pleasure to introduce you all to a very interesting session on tobacco endgame. Many of you might not be knowing about this concept, so I will briefly introduce this concept to you in this session, and the speakers of subsequent session will dwell more on its model and progress made so far across the globe as well as in India. Firstly, we will discuss about the global burden of tobacco use. Tobacco use kills almost half of its users. The lower and middle income countries house over 80% of world's 1.3 billion tobacco users, and around 12.2% of all LMIC deaths are tobacco related. Further, tobacco kills almost 8 million people per year. That is 80 lakh people per year. Of this, around 70 lakh people are due to tobacco use directly, whereas 1.2 million, that is 12 lakh people, die due to exposure to secondhand smoke. So besides, smokeless tobacco use leads to around 2.5 million disability adjusted life years, while 148 million disability adjusted life years are lost due to tobacco smoking. So given this backdrop of high mortality and morbidity due to tobacco use, I am briefly introducing you to the concept of tobacco endgame. So the tobacco endgame concept suggests that moving beyond tobacco control, the idea which we are perlocating for many years, so we want to move beyond tobacco control and emphasizes on the idea of seeking the end of tobacco epidemic rather than just controlling of it. So it assumes a continued presence of tobacco since it is common, widely available, ordinary consumer product, but this concept focuses towards a tobacco-free future wherein all commercial tobacco products would be gradually phased out from the globe or from the country whosoever practice it, or their use and availability be significantly restricted to a limited number of people who are tobacco addicts or who need tobacco for their survival. In continuation to the previous slide, the initiative designed to change or eliminate permanently the structural, political, and social dynamics that sustain the tobacco epidemics in order to achieve within a specific time an end point of tobacco epidemic. So this means that we want to eliminate permanently all those dynamics which are playing role in the society, whether they are structural, political, and social dynamics, and all work together to eliminate the tobacco from the society. Secondly, the tobacco control and endgame is a social change process, wherein the changes in tobacco use, intentions, knowledge and attitude on one hand, and public policy and legislation on other hand, continuously interact and influence each other to the health of people. This means that we not only want to have policies and legislation in place, but also to enhance the knowledge and attitude of people so as to move towards the tobacco endgame. Further, the endgame is a strategic plan to reduce prevalence within a set period of time. For example, people have kept the target of reducing less than 5% globally by year 2040. This is just a set period. and denormalizing tobacco use. That means that it should not be considered a normal thing in the society. Then moving towards a tobacco-free generation. Again, this is a sub-concept in the tobacco endgame. That is, we want to have a tobacco-free generation. That is, no tobacco product should be there for those people who are our future. That is, no sale to those people or children or infants who are born after year 2000 or 2010, whatever date we want to set. And fourth is focusing on the supply measures. That is, nicotine regulation or elimination, taxation, increased tax to such an extent that nobody can afford tobacco, and we need to have a proper pricing controls so that tobacco is not being sold in the society. Moving ahead, it's essential to mention here that it is vital to address tobacco as a systemic issue, and it's crucial to make tobacco industry liable. That is, these people who are actually working, or the organization who was actually working for promotion of tobacco through any means, we need to eliminate that. And tobacco should not only be considered as a health issue, but should be a systemic issue or a issue which is actually degrading the system, or a societal issue because it causes all type of harm to the society. Then further entrusting tobacco marketing and or supply to a non-profit agency mandated to drive sales down and imposing a sinking lid on supply of tobacco available for commercial sale. So this is another thing which is a model which has been suggested, a sinking lid model, which means that we want to decrease the sales and decrease the, we want to have a lid which keeps on sinking every time, every year that sale on a particular shop, there should be a limited amount of tobacco product, and every time it keeps on decreasing, and over a period of time that tobacco product cannot be sold by any of the tobacco vendors. Now we learn some elements of end game strategies. We have told about some of the strategies before that. So some of that include having an explicit government intention and plan to achieve close to zero prevalence of tobacco. That is, nobody should be using tobacco except those who are addicts or those who need tobacco for medicinal purposes. A clearly stated government end target date. Government should have a date in which there should not be any selling of tobacco product within a maximum of 2 decades, along with mechanism to ensure the continued and augmented availability of non-tobacco nicotine. This is basically just for the pharmaceutical purposes, not for in substitution of tobacco, but for pharmaceutical, for those people who are taking tobacco to a greater extent and now they are addicted and they need nicotine for their survival. I am sharing few examples of model used by various countries across the globe in initiation of endgame concept, although we'll be having a separate session in this wherein you will be learning more about these countries. For example, New Zealand. New Zealand has been pursuing to make New Zealand a smoke-free nation by 2025. And they have been using some of the strategies which I mentioned just before. Then Bhutan has placed a ban on the sale of tobacco products. That is another thing which has happened. Then if Australia has adopted a plain packaging concept. Now in India, you have seen that 85% of the tobacco pack is being covered by warnings. But we have 15% of the pack which is still there. So plain packaging means nothing on that pack, so that they will not promote tobacco. So Tasmania is moving towards a tobacco-free generation. I already talked about this tobacco-free generation. That is no sale to those born after a year X. And Singapore again is moving towards a tobacco-free millennium generation. So these are some of the, just an example. We will be having an elaborate session on that. So dear delegates, so far we have briefly discussed about this concept and few examples from the nations and their initiatives. Now the essential components for endgame from the perspective of policy lens include the following. I think you are all our community advocates, and you should see from this policy lens as well. That is, we need to strengthen the WHO Framework Convention on Tobacco Control for internationally cohesive national policies. Only when we strengthen that WHO FCTC, this is a policy by WHO, so we need to strengthen that. Adapt and strengthen WHO Empower strategy. Again, I wish that you all study this WHO FCTC and Empower, because in the limited time we are not able to enlarge upon them, but they are really important. We need to strengthen them if we want to achieve the tobacco endgame. Then integrating tobacco control in health and development agenda. So tobacco control is not only a health subject, it's a developmental agenda, because it is everywhere. So wherever you are going to for some program, I think even in non-communicable disease program or in TB control program, so everywhere we should advocate tobacco, because tobacco and TB is a very dangerous combination. Similarly, non-communicable diseases, it's a common risk factor. Maternal child health program, again, dental health. So we should always integrate tobacco control in these developmental agenda. Then we should always try to form targets by the government when it should go with the end game. We can make it at the state level also. We need not go to the country level. Then enhancing policymaker interest in the issue. So this is really very important, because we need to find that advocacy ground where policymakers come and take this agenda forward. So this is very important, and we need to have a very strong law and its effective implementation to facilitate litigation against the tobacco industry. So that is really important. We need to counter them. So these are the things which we need to do from the policy lens. Now, we need to see from the perspective of community lens, which includes we need to build public support for government targets. So government, how the government acts. So we can advocate the government through evidence, but from the community perspective, we need to build that public support for this tobacco endgame. If some villages pledges that there should not be any shops in the village, so many people have already done it. Many villages have already done that. So that gives that support to the government. Then enhancing mass media campaigns. Mass media is really important, and we need to support this tobacco control through mass media or tobacco endgame through mass media. Better delivery of cessation support. So cessation is really important now, because even if we have a tobacco endgame, there might be few people left who require nicotine for their survival. And we need to have lawsuits, RTIs and PILs by the community against the tobacco company. So in conclusion, just want to say that tobacco endgame is really a very important concept, and there is no meeting of tobacco control which we normally do where people have not asked why not government stop selling tobacco. So that's why tobacco endgame is a really important concept. But considering tobacco is being taken care by almost 13 governments, 13 departments. So it's really a very challenging issue. Second is that public health advocates have to think through the ethical minefields rather than just having that mindset of having more money from the tobacco taxation. So do not forget, there are political and legal battles. There will be that. However hard they are, worth the cost, given the economic benefits of public health, which we are going to achieve after the tobacco endgame. I think it's worth taking this as your goal, or as your topic of thesis, or as your ideology, which you need to practice towards the tobacco-free society. So in the current century and with the additional challenge of the pandemic, it's high time that we need to think out of the box. We need not concise ourselves to a tunnel vision where we just think about the normal strategies of tobacco control. We need to go out and think out of the box and advocate towards this tobacco end game. So I thank you all for this interesting session, and I want to congratulate the Department of Community Medicine, School of Public Health at Chippar, Puducherry for organizing this wonderful webinar. And I would like to end here this presentation. Thank you.
Thank you, Dr. Sonugoy. We'll take the questions at the end of the session. I request all delegates to please type their questions in the chat box. Moving on to the next session, we have Miss Anne Jones, who's joining us from Australia. Thank you, ma'am, for taking time to join us. Miss Anne Jones is working as the Technical Advisor, Tobacco Control in the Union for the last 14 years. She's been instrumental in negotiating tobacco grants in Asia Pacific region, developing training programs on implementation of the Framework Convention on Tobacco Control, the CEO and advocate and policy advisor on preventing deaths and diseases caused by tobacco. She's also a political advisor at the Parliament of New South Wales. She's the founding co-director of the Manly Environment Centre. So I invite Ms. Jones to please start her session.
Greetings to friends and colleagues in India. I'm very pleased to be joining this session to speak about the global progress in tobacco endgame. My name is Anne Jones and I've been a technical advisor on tobacco control to the Union since 2007, and I'm very pleased to be joining you today. The presentation will cover, first of all, a declaration, and of course I have no conflict of interest. I want to very briefly recap endgame and why now, and then follow that with some examples of progress, as well as 5 lessons that I think we can take away from this presentation on the way forward. And lastly, just a slide on resources for you to follow up for more information on endgame. So endgame, what does it mean and how do we do it? Now, in the past, I used to get endgame a bit confused with tobacco-free generations. It now has a very specific meaning, which I'm going to describe below, taken from Ruth Malone, who's the editor of Tobacco Control. But from my perspective, endgame is really a paradigm shift. It's shifting the focus away from just controlling to actually ending. So it's a really important concept for us in tobacco control. So the way it's defined by experts in endgame is these are initiatives that are designed to change permanently the structural, political and social dynamics that sustain the tobacco epidemic in order to end it within a specific time. And that is the key. It's actually within a specific time. And of course, these are structural changes. But more of that when we talk about some progress in recent times. So how do we do it? Is it really that complicated? Well, it doesn't have to be complicated because it can be integrated into strategies for tobacco control, like national or subnational tobacco control strategies, as well as human rights, social, sustainable development goal strategies, and of course the key being end dates. And most countries that are progressing end games are nominating 2030 or 2035. It depends really on the country context. So why now, during this terrible COVID time, should we be progressing endgame in such difficult circumstances for everybody? Well, the Tobacco Control Journal sets out the reasons why, and there are 38 million reasons. The 38 million reasons are the 38 million children and young people who are already using tobacco. So it is a very serious situation we have with so many new users who are becoming smokers or users in a very short time. The endgame discourse is also growing rapidly. And if you look at Tobacco Control Journal, you'll see there's nearly 200 research articles in recent times on the endgame. And so it is growing. And of course, the third most compelling reason is that the tobacco industry has a mission. We all know that it's about them. It's not about health. And they are exploiting COVID as well as corporate social responsibility and the harm reduction model to further their progress and expansion into low and middle income countries. So what is the sort of progress that has been made in recent times? And I've just chosen some examples here for you that are global as well as national and local. And so the really big global efforts that are supporting Endgame include the solutions that already exist, and that is the treaties such as the Framework Convention on Tobacco Control, as well as human rights, SDGs. These are already hard-won treaties and conventions that exist that we can use. And of course, governments have the power to raise tobacco taxes to reach the goals that have been set and agreed to by parties. A second example is the Sunset Project, which is a US-based project, but its purpose is to end the commercial sale of tobacco products, and that is based on their focus on human rights, and human rights is a priority for tobacco control. So more of that later. The third example is the campaign, the Stop campaign that has been supported by Bloomberg to actually stop tobacco industry interference. And that's contributing enormously through its coordination of efforts around the world. The fourth global example, which I think stands out, is the divestment campaign for making tobacco, the divestment of tobacco becoming the norm. And that is, I think, contributing enormously to endgame progress. So if we think globally and act locally on endgame, what are governments doing? There are several endgame strategies that are underway in several countries. Australia most recently in 2020 established a Centre of Excellence for Endgame Research with a global consortium, and I think that's a good sort of lesson for perhaps other countries to be thinking about as well. At the city level, there are supply side bans that have started, particularly in the US, and they're aimed at ending the tobacco sales. And of course, there are partnerships now that we're seeing for healthy cities that are supporting more and more tobacco control. And it's only a matter of time before we start to see, I think, more endgame strategies in place in these cities as they progress their implementation of tobacco control measures. So endgames have been going for quite a while, and prior to 2018, this is just a summary of some of the jurisdictions that have agreed to reduce tobacco use, mostly to under 5% or less, based on several measures that they are mostly FCTC measures, but it also includes, and this is the endgame component, the phasing out of commercial sales of tobacco, some countries by 2030 or 2035. And examples of these countries include Singapore or jurisdictions as is in Tasmania, New Zealand, Scotland, the Netherlands, Finland, Ireland and California. And although all the models are slightly different, there are some very defining characteristics about these endgames, usually a law, an action plan and dedicated funding. If we look at Finland as a case study, and of course Finland is a small country, it's a wealthy country, but it is a great example of how the community there and government got together to pass a law for tobacco-free Finland. They did this in 2010, so nearly a decade or over a decade ago. So they developed the law and that was followed by an action plan. And their goal was for less than 5% daily use by 2030. And in 2016, with the increase in nicotine products, ends and vaping and so on, they expanded on their law to include all nicotine products. And I think one of the great positives from Finland was a very strong consensus that this is what they wanted to achieve. And that was despite some minor opposition, usually from the tobacco industry, but also from other small groups that were much more interested in seeing harm reduction factored in there. And as a result of all of this work since 2010, smoking rates or tobacco use rates have decreased quite significantly. But in a recent research article published in Tobacco Control Journal, it was identified that the main barriers are insufficient government funding and insufficient priority, as well as tobacco industry opposition. And I think the key lesson, as recommended by these researchers from Finland, is that governments really need to designate funds for structural change. You can have a law, you can have an action plan, but without the funding, it's going to be very difficult to achieve or accelerate progress towards those goals. Some further highlights since 2018. For those of us who were able to attend the World Conference on Tobacco or Health in Cape Town, there was a declaration on human rights that was approved and endorsed by the delegates, as well as 161 organisations worldwide. And this is a very important united step that was taken by so many people working in tobacco control and so many organisations who said we must really bring an end to the tobacco epidemic and protect the human rights of all people, not just some. Another landmark report that came since 2018 was by WHO, UNICEF and the Lancet Commission. They had a very large consortium that looked at the future for the world's children. It's a very comprehensive report, and they called on all parties to put children at the centre of the Sustainable Development Goals. And they have an index that measures the improvement in children's health. And I think this is a very important time in the history of tobacco control for us to put the health of children first and decide that we must start to raise tobacco-free generations with more endgame strategies. And I mentioned earlier STOP. It is a major highlight because it's globally reporting and countering tobacco industry interference. The index is showing though some big gaps in the adoption of Article 5.3 of the FCTC for parties to actually do more to protect health policies. They may be doing it well for the Ministry of Health, but not right across government. So we need to do a lot more work in that area. And the tobacco-free portfolios, US 11.4 trillion has been divested. And this is a major highlight because what it's saying is that it's not normal to have governments and investors investing in a product that kills 8 million people a year. I mentioned the Australian government earlier because I think this is a great example for India to think about having a centre of excellence for endgame research or a resource hub with global and local experts that can make sure that all of the latest research is there, the latest case studies, and to help show the way forward, not only for India, but for other countries as well. California, of course, has its own resource hub and plan for an end that involves endgame measures. They have an endgame centre. They provide trainings, they provide resources that are still relevant for people outside of California. And they have been successful. 2 local government authorities have already banned the commercial tobacco sales so far, and there will be more to follow. So California is leading the way on endgames. So what are the 5 lessons on the way forward, not only for India, but for any country that's trying to accelerate towards goals in reducing tobacco? Well, sorry, I just need to go back. Sorry about that. The consensus amongst the NGOs and the civil society and government is quite important, but the consensus can just be on the key elements for embedding a goal, either in the National Tobacco Control Strategy or subnational strategies. It's very important to have the goal with an explicit plan and a timeline for the endpoint, depending on the country or the state context. Without a plan, there's just more of the same, but with a plan, an explicit plan and a goal, it's possible to work towards that endpoint. Secondly, the end game measures can include all nicotine products. It doesn't just have to be combustibles or the worst ones that we have, and it can include the phasing out of the commercial sales. And that doesn't mean that it's not necessarily a complete ban, but it stops the sales at the retail level, which is the front line for the tobacco industry. And thirdly, researchers have pointed out that there's no one end game, but an end game is really possible if effective action plans are devised and funded. And of course, the tobacco industry is counted. Fourthly, the strong evidence base is really can be very effective in identifying and closing gaps, as Australia and California have done with their resource centres. The missing voices of children, low tobacco taxes and underinvestment in health are just three examples that have been identified by researchers as problem areas that we really do have to address. And of course, lastly, in terms of lessons, tobacco industry interference, mentioned it a few times, and I know we have a speaker that will be focusing on it as well. This remains possibly the major threat for endpoint unless parties can agree on what their endpoint is and include in that action plan countering the tactics of the industry and adopting Article 5.3 measures that are really effective across government, not just for the Ministry of Health. And lastly, these are the resources I urge you to have a look at. The Sunset Project with its Human Rights Hub, tobacco-free portfolios is a great example of divestment. STOP, which is already working hard, I think, in India to coordinate efforts. The Future for the World's Children is an inspiring report. Endgame centres, there's a couple that we already have, and there may be even more that I haven't been able to identify for you. And lastly, the Union Hub, which is all about implementation and enforcement. So I'd like to wish you all very well in your conference, and I hope you are able to progress the end game. Thank you very much.
Thank you, Ms. Jones, for your excellent presentation on the overview of the global progress made towards tobacco endgame. I thank you for joining us at this time across time zones. Now we move on to the next session. We will take the questions at the end of the sessions. I request the delegates to please type in the questions in the chat box. Moving on to the next session, I hand over the session to the next chairperson, Dr. Sitanshu.
Thank you, Dr. Kavita. So the next person needs no introduction in the world of tobacco control. It's Dr. Upendra Bhojani, a very dear friend. He is the director of Institute of Public Health, Bengaluru. And in the interest of time, we'll not go through his CV. He has requested personally. Thank you, Upen. Thank you so much for joining us. So let's go to his presentation directly, please.
Hello, and my greetings to all of you at IPHA conference. I thank organizers for this opportunity given to me to engage with you all. We have heard from earlier speakers about what we mean by tobacco endgame, what are the various strategies to achieve tobacco endgame, and how various jurisdictions across the world are mapping their own journeys towards achieving tobacco endgame or tobacco-free future. In this talk, I'll reflect a bit on what are the challenges to tobacco endgame, and particularly focusing on tobacco industry-related challenges. So there are indeed many challenges to tobacco endgame, and if I adopt from what Thomas and Gostin wrote in Tobacco Control Journal, adopting it to Indian context, one can say that there are some of the ethical issues or questions that we may need to consider while thinking about tobacco endgame. For example, let's think of putting very high taxes on tobacco products, and then in a shorter run, people who are poorer, particularly, they also use more tobacco. And tobacco is so addictive that they may not be able to quit tobacco in a short run. And this means that they may have to cut expenses on some other essential items in the households. So there may be some regressive impact on some of the already vulnerable groups of some of these strategies. There will be some degree of stigmatization of tobacco users, which also happened these days, and also of the people who are associated with the tobacco industry. One may have a question that will there be an adequate alternative livelihoods to tobacco workers, or in terms of providing adequate tobacco cessation services, because there will be many people who would like to quit. Some may also have a concern that is this not a paternalism, right? Going with aggressive regulations in area where one may say that it's an individual choice to decide whether to use tobacco or not. And finally, some may say that will we ever address the broader determinants of tobacco addiction, the broader situations which create stress, which pushes people into addictions. Otherwise, tobacco addiction may get replaced by some other addiction, may also be harmful. So these are some of the ethical concerns that come to mind. There are, of course, some of the legal concerns in achieving tobacco endgame. Tobacco industry has been known to claim its right to trade, right to intellectual property, right to free speech, in order to resist some of the tobacco control measures. They have challenged the legal interpretations by governments and sometimes the regulatory capacity of the governments in bringing certain tobacco control measures. So these are the various concerns that one may can think of. However, let me focus on tobacco industry here, because tobacco industry has particularly used some of these grounds and others to mount a very formidable challenge to tobacco control, and so to tobacco endgame. So what is tobacco industry? Well, tobacco industry in some sense is very unique and very different from many other industries in a sense that it produces products which are lethal, which are known to create huge health harms. It has a huge negative impact on environment. And in fact, as WHO rightly claims, that there is a fundamental and kind of irreconcilable conflict between industry interest, which is to trade in tobacco products and earn profits out of these lethal products, and the interest of public health policies, which is to reduce tobacco use consumption and the associated burden. Now, when it comes to tobacco endgame, I tend to see two broad categories of challenges which are associated with tobacco industry. One is a deliberate resistance from the industry. And we have seen that the tobacco industry uses several tactics, a variety of strategies to interfere with or to influence tobacco control policies and its implementation. We often call these tobacco industry interference, and I will come to the detail of some of these challenges and strategies in a minute. The second kind of a challenge, which is more natural, is that when we talk about tobacco endgame, we then need to talk about providing safer and viable alternative livelihoods to those who are into tobacco sector, and particularly tobacco workers. Now, there are some steps which have already been taken in this direction by governments in India, by others, in terms of providing alternative livelihoods. But one can still argue that there is need to do more. We need to scale it up. And there is also some criticism that in many of such initiatives, we have not heard enough the voices of more marginalized workers from tobacco sector. So in general, we can do more in that area. Now, coming to tobacco industry interference, as I said, the industry uses various tactics. One of the tactics that the industry uses is that it exaggerates the economic and livelihood significance of itself. While tobacco sector does provide some employment, tobacco sector does contribute to some extent to the economy. But what we see is that the tobacco industry makes rather tall claims about its economic and livelihood significance in various reports it produces, in various press meets. If there is any tobacco control regulation brought out by government, you will typically see, huge paid advertisements in national dailies claiming huge job losses, etc., etc. Of course, the reality is different. While there is complexity in arriving at a very precise estimates of how many are the tobacco-dependent livelihoods, there are quite good studies now which show that while tobacco industry representative body claims that tobacco-dependent livelihoods are something like over 45 million workers in India, the similar estimate which are arrived at from rather reliable sources from the government surveys and the other evidence puts this figure at something like 7 million. So a huge exaggeration. Similarly, tobacco industry is known to make very tall claims about its economic contributions. But while doing that, the industry does not mention the economic cost of tobacco-related diseases. If you look at a report by the Government of India, it clarifies that in a given year, the total excise revenue from all kind of tobacco products in India in that year constituted only 17%, 17% of the total cost of the diseases attributable to tobacco use. The second strategy is the litigation. We have seen that the tobacco industry has used litigations aggressively and more systematically to challenge tobacco control regulations. There is hardly any tobacco control regulation which has gone unchallenged in courts by tobacco industry. Such litigations not only cause delays and dilutions in these regulations and their implementation, but it also leads to intimidation, right, of regulatory authorities. I mean, they will hesitate to take more stringent actions, and also to the tobacco control advocates and activists. The other major thing, which I think we all have observed and is increasing in recent times, is the use of corporate social responsibility. I would say so-called CSR, where industry gives away sponsorships, enters into partnerships with governments under the banner of CSR. The thing is that WHO says that there cannot be anything that can be called socially responsible by tobacco corporations, by tobacco companies, because their core business, which is to produce lethal products, is not in alignment with the social goals. And so more of these is rather a public relations strategy, so to say. So through CSR, tobacco industry has been building a very favorable image among public, among policymakers. More importantly, such CSR engagements enables industry's access to policymakers. For example, India's largest cigarette manufacturing company is known to enter into CSR-based agreements with many municipal bodies in India in order to support solid waste management efforts. But these are the same municipal bodies which are often the nodal agencies to do tobacco control in those jurisdictions. So you can see the conflict there. In a similar line, tobacco industry is known to fund political outfits. Some years in past, we have good documentation around the kind of donations that the tobacco industry used to give to political parties. And once these political parties are in power, it would be conflicted, or it would be at least there would be hesitation in taking a very strong tobacco control position by those governments. Industry has also been giving some money to organizations in social and development sectors, including NGOs, which basically builds their credibility. Industry is also known to fund science, known to fund research and publications. For example, one of the very big e-cigarette company has supported in recent past a whole special issue by a health and medical journal from India around harm reduction, basically making a case for e-cigarettes, the products that the company actually produces. So we need to be really wary about these strategies. Lobbying is another common way in which whether industry representatives or the more organized bodies representing tobacco industry influence the lawmakers in order to have the regulations which are favorable to industry. We have seen a lot of mobilizations from industry side, be it rallies, making high-level appeals, protests by tobacco vendors, etc. Finally, I would highlight the use of front groups by the tobacco industry. Basically, front groups are understood as organizations that purports to represent one agenda, but in reality, it serves some other party or interest whose sponsorship is often hidden or not mentioned, right? And there are many such examples of tobacco industry using front groups in India and in globally. I would mention particularly this organization called Foundation for Smoke-Free World. It's quite a deceiving name, but this is the foundation which is funded by the Philip Morris International, which is one of the big tobacco companies in the world. And the foundation, gives out money, including research grants in India and other countries in name of doing research on harm reduction, doing programs on harm reduction, and making a case for e-cigarettes. But also, in fact, I have made an argument that even smokeless tobacco, which is one of the biggest problem in India, and they frame smokeless tobacco products as kind of a harm reduction alternative to cigarettes. So in essence, let me come to some of the concluding remarks that as we saw, tobacco industry interference through the use of various such strategies that we just discussed is really a major challenge to tobacco control and to tobacco endgame. While there are some policies in place to prevent such tobacco industry interference in India, there are a number of Indian states, state governments who have put in place some of the measures like code of conduct for public officials in not taking favors from tobacco industry, not interacting with tobacco industry unless for the regulatory reasons and things like that. In fact, more recently, the Ministry of Health and Family Welfare at Government of India level has also put in place such a code to prevent tobacco industry interference. But certainly there is need to do much more. We are yet to have a nationwide policy in our country to prevent comprehensively the tobacco industry interference in public policy. And as mentioned earlier, I think there is also a need to do more in order to promote safer and viable alternatives to tobacco work, and particularly for marginalized workers in many of the manual operations of tobacco industry. So thanks again for listening to me, and I'll be happy to engage with you. You can write to me at upendra@iphindia.org. Wishing you a fruitful conference.
Thank you, Upen. That was such a interesting summary and nice compilation of the facts, how tobacco industry, the place hide and seek. The title that you have given for your talk was very apt, Playing Hide and Seek, Tobacco Industry Challenges to Tobacco Endgame. Thank you so much for joining us. Now we move to the next speaker. Dr. Rana Jay Singh, Deputy Regional Director at the Union Southeast Asia Office, New Delhi. Rana sir is a person in tobacco control everybody knows in India and in Southeast Asia region, and is also a global figure. So he has got 30 years of experience in tuberculosis, lung health, tobacco, and NCD control. More than 30 publications on TB, tobacco and NCD control in peer-reviewed journals, contributed to textbooks on respiratory medicine and tobacco control for public health professionals. So without further delay, may I request Dr. Rana Singh sir to please start his presentation.
Thank you, Dr. Stashu. Please allow me to share my screen.
Yes, sir. We'll do that.
So we've enabled screen sharing. Could you please try now?
So can you see it?
Yes, sir, it's visible.
Sir, can you make it full screen, sir?
Yes, yes, I am doing it.
Hanji, sir. Hanji.
Sir, are you facing any?
So there is an icon. Yes. Dr. Rana?
Yes, yes, yes. No, it's fine.
Hanji, sir. ऐसे करिए, sir. Hanji. We can start, sir.
Yes. Please, please. Oh.
Sir, there is an icon at your right and down, icon like a TV. Click that, it will be full screen.
So suddenly, let me see.
Sir, we can run this also. This is visible.
You can run from that side?
No, no, no. This can be like you can.
Yes, yes.
This is visible. Anji, sir.
No, I have just lost the icon. Please stop share live.
Sir, you can see at down notes, comments, then a book, then a 4 science, then a book, then a live
Can
TV.
you?
Just
see the slides
down and right near Zoom.
Okay, thank you.
Yes,
so can you see it?
Yes, sir. We can see it, sir. We can.
And the slide is moving?
Yes, sir. Yes.
Okay, thank you very much. So thank you, Chair, Dr. Kavita, Dr. Stanshukar. Thanks to Professor Goyal and Dr. Kaur for including a tobacco control plenary for our colleagues from Indian Public Health Association. It's really very crucial and their involvement is of paramount importance if we want to have an effective tobacco control and tobacco endgame in the country. Now, as far as my session is concerned, most of the things have already been shared by my previous speaker, but still I feel that I have some points I would like to make to see that our public health professionals they can have some understanding of the issue and how they can contribute for effective tobacco control in the country. So thank you once again. We all know it is World Health Assembly in May 2013, which adopted a target of 30% relative reduction in tobacco use prevalence by 2025. So this is something which we need to remember. So this was our target. Tobacco control is also becoming an integral to the agenda of SDGs, Sustainable Development Goals, adding urgency for attaining World Health Assembly targets and swiftly moving beyond them to eliminate tobacco use in all forms by 2050 everywhere in the world. In India, we had an international conference on public health priorities in 21st century in the year 2013, where experts from almost 54 countries, they deliberated on the issue. So what should be done? So you see, what was the point? In 2013, it is almost 8 years. So I just want to share with you that it is not something which we are talking now. It is almost many years when people started talking about tobacco control. It is almost at the same time people started, why we are talking about tobacco control? Why not tobacco endgame? So it was in 2013, and before that, my colleagues has already shared how this concept of tobacco endgame, and Professor Goyal has shared that has come when often in our day-to-day work, people ask us why you are talking tobacco control, why not tobacco endgame? So this global conference, they deliberated to identify strategies for ending tobacco-related harm to health and development in 21st century. So what should be these strategies? First of all, they discussed that. They also discussed setting up of global and country-wise targets to protect the present and future generation from harms of tobacco. So this was the overall objective of this conference. This was something which was discussed for global endgame. So what should we do as far as India is concerned? Now you see, I have been given presentation, Daring to Dream. So first of all, let's dream for tobacco end game. So this is something which we are continuously highlighting. So let's dream for tobacco end game. In every program, we are asked this question, why tobacco control? So we will have to know it's time. We need to dream for that. And what kind of dream that should be? Tobacco-free India by this year, 2030 or 2040. What should be our timeline? I would like to share with you that our neighboring country of Bangladesh, they have already set a target of tobacco-free Bangladesh by 2040. And who has made this declaration? Declaration was made by none other than Prime Minister of Bangladesh in a World No Tobacco Day meeting in 2016 that Bangladesh will be tobacco-free by 2040. And now they are also preparing. I have been visiting that country. So there are some plans, there are some discussions, there are some strategies also that how we can make that country tobacco-free. So what is for India? So how long we need to go? Already Professor Goyal has explained us what is mean by end game when we will talk. So perhaps it is something which will bring total change. It is not something as a tobacco control that it will continue for years together. We will continue to do workshops. We will continue to sensitize people, and it will go on for years together. You see, United States of America, they started comprehensively, they started thinking about tobacco control when its first Surgeon General report was released way back in 1964. Then they thought of starting. So you see, for US, at that time, their tobacco use prevalence was very high, perhaps more than 50%. Now it is around 20%. But you see how many years they have taken. It is almost 60 years since when they are working on various issues related to tobacco-free. Today's discussion on smoke-free, there is pack warning, there are advertisement bans, one by one, the things are doing. Are we in India going to take same much time as other countries have taken for tobacco, for bringing their prevalence down? Still in US, it's not near to tobacco end game. So what should we do for India? So definitely we need to reduce that prevalence to such a level when no longer it remains a public health challenge. And then we can really push tobacco that now we do not need you. So that requires, as Professor Goyal already mentioned, some structural, political and social dynamics which are sustaining this epidemic. So this is something which we would all like to place before you and just invoke and thinking among you that how we can achieve that. So already mentioned. So first of all, we need a plan. Short-term, mid-term, long-term strategic plan is something which is required. We need to adopt a national action plan. Already, all the three previous colleagues have mentioned that this is something which we are required. And what should that plan should have? First of all, set a target. Whether it is zero prevalence or close to zero prevalence, which often people say at least 5% of prevalence, when tobacco use no longer remains a public health challenge. Second, we need to develop, implement or strengthen current and new policy approaches. So this is something which is very crucial. We need to complete or close ending of commercial sales of tobacco products, which has already been highlighted. And I will be discussing it on perspective of our country and tobacco use being fully denormalized. So this is something which we need to do, and that how we can denormalize tobacco use in the society with virtually no exposure of children and youth to tobacco products. So this is something. Now, what are the things which is driving this epidemic? Just take example of our own country. We have now various surveys. Global Adult Tobacco Survey, we have Global Youth Tobacco Survey, early initiation of tobacco use among children and youth. Very crucial, important point. Prevalence of tobacco use among youth. You see, if we see GATS, so almost, please see, last line, more than 55% of tobacco users have already initiated before they are 20 years of age. And more than 67% have already initiated before they are 25 years of age. So that is all that age, children, adolescent, and youth. So this is a huge burden, which is really a big challenge for a country like us. Even Global Youth Tobacco Survey, there is a high prevalence of tobacco use among children of 13 to 15 years of age. And then what is further? Tobacco use situation in India is very complex. As in foreign countries or in developed countries, we only have cigarettes. Cigarette is a major form of tobacco use. But in here, we have a variety of smoking products and a large number of smokeless tobacco products, innumerable products. And there are people who are using both forms of tobacco. So the tobacco use situation in our country is really very, very complex. So now let's take the first point, set a target and timeline. What should be our target? So how these things will happen? We need to deliberate. We need to sit together. Who is going to start this discussion? Perhaps it is you, a public health professional, who need to bring these things on forefronts. Currently, 29% of adults above 15 years of age, they use tobacco. 268 million tobacco users. That is roughly about 27 crore. Huge burden. It is very difficult to help people to quit tobacco. How tobacco control happens? We need to stop new people from starting to use tobacco and help those who are already using. So when 27 crore tobacco users are using, and Professor Goyal has already mentioned that tobacco is such a product in our society which kills 50% of its users. Do we have any other product? Whether it is for eating, for drinking, do we have any other such product which kills 50% of our users? No, it is tobacco. So what will happen if we have 267 million tobacco users? You can imagine the burden. As a public health professional, if you ask me, and if I ask you, which is the biggest public health challenge in the world, globally and in our country, it is tobacco use. It is this tobacco burden which is killing large number of people. And if you compare it to the death and disease caused by tobacco use, if we see about communicable diseases, all of you are already aware how the burden has shifted from communicable to non-communicable diseases. So what should be our target? What should be our timeline? 2030, 2040? How much time we should take? Currently, we have, just to update you, that in India, we have National Tobacco Control Program, under which we need to increase awareness, implement our law, cessation, tobacco cessation, reduce production and supply, and facilitate FCTC implementation. These are the current strategies in our country. And how we can really strengthen their implementation is very important, first of all. And if I would like to, when we are thinking of end game, when we are thinking of our targets, when we are thinking of our timeline, so I would like to inform you the progress we have made in last few years. From 2009 to 2015, there is a decline in prevalence by 6 percentage points with a relative reduction of 18%. Currently, we have 29%. So in 6 years, we have been able to reduce roughly 1 percentage point per year. Currently, we are 29%. How many years it will take us to reduce our prevalence to 0 or to 5? It is 20 minimum. So we need to see that how we can accelerate prevalence of tobacco use rate every year. Then second, we need to develop implement, strengthen current as well as new policies. As I mentioned, we already have WHO FCTC, we have WHO Empower, we have a national program, we have COTPA. So their effective implementation, monitoring is very crucial. That will continue, that should continue. But in addition to that, other policy approaches are also required. And on that, already I think my colleague Anne has mentioned about there are product related, how we can reduce nicotine content over next few years among in tobacco products, how we can make tobacco unpalatable so that people don't use it. Thirdly, the new novel products, that is availability of ends, etc., electronic nicotine delivery system. I think they should not be available at all if we want to denormalize tobacco. What is happening? E-cigarette, it is again normalizing tobacco use. But that is why there should not be any availability of ends. Then there are user-related. We are already working on various licensing issue. Professor Goyal also mentioned about prescription to purchase. Then policy related. So this is something which already many colleagues in the country, they are working on tobacco-free generation. What is tobacco-free generation concept? That no sale of tobacco products to anyone born after certain years. And what is that certain years? Even if that can be 2006, even if someone becomes or attains an age of 18 or 21, even then that person will not get tobacco. That is a tobacco-free generation concept. And already many colleagues in the country, they have initiated that kind of thinking or thought process among tobacco control stakeholders. Then this is something. Please see first bullet point. India already has 85% pack warnings on both sides on principal display areas of packs, but now it is time to go beyond that. So plain packaging is very important for the country. And when countries, if we're already having 85%, it should not be very difficult task for the country. Then tobacco taxes, very important issue. As I mentioned, different types of products are there. Not only cigarette, but additional BD and smokeless tobacco are major challenges. And tobacco taxes on these products are very low. They are not meeting the standards of WHO recommendations or World Bank recommendations. Then stop tobacco industry interference. Already Dr. Opendra Bhojani has very clearly explained us how that is also very crucial if we want to achieve tobacco end game. Tobacco vendor licensing, again, important area to reduce availability and accessibility, which is also now gaining grounds in countries of also in Southeast Asia region. Globally, there is a few countries which are now working that tobacco should not be sold by everyone. So we need to ensure right now what is the situation in our country. As soon as we come out of our home, tobacco is being sold by almost everyone. Whether it is a tea shop, grocery shop, departmental store, anyone, he or she is selling tobacco. Other things which we should need to do as far as complete ending of commercial sale of tobacco products. We first of all in India, you know, India is a tobacco growing state country, also third largest country in the world. So we need to reduce tobacco cultivation. We need to reduce land under tobacco cultivation. Some work is already going on to substitute tobacco crop with other nutrient-rich crops, but that is very, very small work right now. It requires big efforts. Trade and investment and divestment out of tobacco, other important issue that whenever we discuss tobacco control, we need to see that whenever we are discussing multilateral and bilateral trade and investment, it should not impact tobacco control efforts. And just yesterday, I heard Dr. Upendra Bojani talking about commercial determinants of tobacco control. So this is very important that all commercial determinants for tobacco control that should be taken into consideration. We should not do any such agreements or trade agreements or investments which impact tobacco use, tobacco control. Then sinking lid, a concept Professor Goyal has already mentioned that we need to reduce slowly a quota on tobacco manufacture and imports. And as far as India is concerned, I would like to explain. It's almost 20 years now. Already we are working in tobacco control. So it's high time for thinking tobacco end game. Then how to denormalize tobacco use in the society so that there is no exposure of children and youth. At least we need to see India is relatively a young country, and we need to see that there is no exposure of children and youth. We upholding child rights to curb exposure to tobacco smoke at all places, including homes and private transport, public places. There is huge second-hand smoke exposure of children and non-smokers. So we need to see that. Effective implementation of child and youth protection policies, including TOFI guidelines, tobacco-free educational and institution guidelines. Then effective IC and mass media campaigns to ensure behavior change, not only simply information that is, yes, tobacco is harmful. We need to have such IC and media campaigns which can really change the behavior and not simple information related to tobacco harms. Now, in the conclusion, to above suggested strategies for tobacco end game, we need first understand the epidemic. Perhaps we do not have complete understanding. We must analyze and explore association among socio-demographic factors and tobacco use in children and youth in the country. We need to advance research. Still, as far as tobacco related research in countries like India is very on very lower side. So not many people are involved in that. So advancing the research to support stronger, innovative and evidence-based tobacco control measures beyond FCTC is something which is very important. And please see the last bullet point. To do so many things, it is not possible while we are doing it with other things. You all know HIV, AIDS epidemic within. So because it was really big challenge for the country at that time, government created a separate body, NACO, National AIDS Control Organization, with dedicated budgets, with dedicated teams. So this is something which we need. We requirement of a dedicated agency or authority for multi-sectoral integration, interagency coordination, and wide-ranging partnership which remain central to fighting the tobacco epidemic and countries and tobacco industry interference. So thank you very much. Thanks to the chair. Thanks to Professor Kar and Dr. Kavita. Thanks to all for listening. Thank you very much.
Thank you, sir, for your detailed presentation on developing an integrated tobacco and grain strategy for India. There were so many points to take home regarding tobacco control activities, especially in India. So moving on, at present, there are no questions in the chat box. Before we conclude the session, I would like the speakers to make any concluding remarks, if any, from your side.
Okay, so Dr. Kavita.
Yes, sir.
I think Nani is pitching, so I'll just pitch over because this is a session where we tried to introduce a different concept altogether, that is tobacco-free endgame. And Dr. Rana has rightly told that the endgame has started way back in 2013, but still many people doesn't know about it. what tobacco endgame is and how to achieve that endgame. And that is why we always keep talking about tobacco control. Even us who are working for tobacco control for so many years, we also try to talk in terms of tobacco control, not tobacco endgame. So it is right time for all academicians who are sitting over here from public health fraternity. I think I was in another session which is going on in NCTOH. So that is an oral presentation session. So in that also we have Dr. Surekha Kapoor was chairing that session. So I was telling that why not AIMS forms a consortium of tobacco control, and why not we make an effort, because if AIMS, JIPMER, or Institute of Eminence across country make that effort, all the medical colleges and all people will follow. And that is a very good thing which can be started, and that can be take away from this session as well. So that is the purpose I discussed with Dr. Stanshu, that why not to introduce this thing among our public health fraternity, who many of them are not aware about this. So this is my humble submission.
Sure. Thank you, Dr. Sono. That was a very pertinent suggestion. And as we have been working together, so let's take this cause forward. And we must work for the cause of tobacco control in this country. And thank you. And so she has joined us from from Australia, and it's so lovely to see Rana sir. And Upendra, can you just switch on your video if you are there? Yeah, so we can just click a photo, then we can. I'll do the print screen, and we'll then end the session. We'll move to the next session.
We can invite Ain for 1 minute if she want to speak something on it.
Sure.
Because it was a recorded session. So Ain, yeah.
Thank you, everybody. That was a really great session, and I was quite encouraged by Dr. Rana's presentation. Analysis of the tobacco rate or the smoking rate in India, which, even though it's very high, like extremely high, at 28%, but with an average 1% decline per year. Imagine if India just was able to double that to 2% per year. That would have a huge impact on reaching a goal by 2030 that could be under 5%. So 5% or less. I mean, I'm not an epidemiologist, but if you had some people who would look very closely at those figures and factor in, population growth and the impact of ends and so on, it may be actually achievable. And that means it's very exciting news. And I do hope that you're able to take this forward and get some dedicated resources to make it happen.
Right. Thank you. Yeah.
Thank you so much, Dr. Sono, and thank you, everyone. We conclude the session now. We move on to the next plenary. Thank you so much for joining us. On behalf of the organizing team, we really...
Thank you, Anne. Thank you.
Thank you.
Thank you, Dr. Stanshu, for keeping this session, and thank you all speakers and chairs for being present. And thank you, Anne, especially from Australia. You are joining at an odd time sometimes.
Thank you.
Okay, bye-bye.
Bye.
You can come. Now we'll start the next plenary. I invite Dr. Mahalakshmi to please join us. We have also Dr. Arun Agarwal has joined from PGI Chandigarh. Thank you so much, sir. I hand over the session to both of you.
Good afternoon. Good afternoon, everybody. Apology for joining a little bit late. So we'll go on to the next session, plenary session 70, which is a look forward session, especially in public health advocacy and important public health tool. This session will be chaired by Dr. Arun Kumar Agarwal and myself. So I'm Dr. Mahalakshmi. I'm working as additional professor in the Department of Preventive and Social Medicine at JIPMA. The Dr. Arun Kumar Agarwal sir doesn't need any introduction, but it's my privilege to introduce sir. Sir is a professor of Department of Community Medicine and School of Public Health in PGI. His area of interest are reproductive health, child health, quality of care, micronutrient deficiency, and operation research. I think many of the public health management skills have been learned by not only his own students at PGI, but also throughout India from him. So Sir has been a member of IAPSM, IPHA, and Indian Association of Maternal and Child Health. Sir has multiple funded projects and numerous publications in national and foreign journals. Over to you, sir. We can go to the speakers.
Thank you so much. And it is always a very good feeling to be associated with JIPMAR. And I think JIPMAR is the department of three Lakshmis. So this is great. This is always great. And I think this session is also, you rightly mentioned, is very important for public health practitioners. And you have lined up very eminent speakers for deliberations in this very important conference. So can you project the, yeah. So I will be introducing the first two speakers as told to me, and the I think first one is Professor Chirian for this. Yeah. So I think Dr. Chirian Varghese also is a very prominent professional, and I think in when we organized our workshop in 90s, since that time, then we were very junior and we were asked by our HOD to contact him and invite him. So he is currently the cross-cutting lead of NCD and Special Initiative WHO Geneva, and WHO is member since 2001 at country, regional, and global levels. And so many awards, fellowships, but significantly mentioned PhD in cancer epidemiology and key role in clinical oncology and epidemiology in India, cancer research in UK, and done 70 articles in the field of NCDs. This is just a very brief glimpse of the experience he has, Professor Chirian Varghese. So maybe we can start his session first, and then we introduce the second speaker when he will speak. Over to Dr. Chirian, please.
Good afternoon. Thank you. Greetings from World Health Organization. Honorable chairpersons, participants of the 65th Indian Public Health Association Conference. Stuti, can you please close this?
Yes, so we will have a live presentation.
Yeah.
Thank you.
Okay, thank you. Good afternoon, Dr. Agarwal and Dr. Mahalakshmi. Thank you to IPHA for giving me this opportunity. I think this comes just after the tobacco session, and it is quite important, as Dr. Agarwal and Dr. Mahalakshmi said, that the public health advocacy has to now be very strong. We have just had this during this pandemic about the various advocacy challenges and towards policy changes, because that is what ultimately will make the difference. As all of you are public health professionals, you know that advocacy means to change what is into what should be. And that is the sort of simple way of looking at what advocacy should achieve. But then how do we do this? I think we need to do our homework, as you heard from Dr. Rana, clearly sort of bringing out the data on tobacco just in the previous session. What is the real issue that we want to address? We have to be very concrete on that. You can't have multiple issues, because your advocacy becomes more powerful when you really know what is the issue. Is this relevant and timely? Because there is a particular opportunity that is available. So when there is Nipah, you can actually talk about One Health, and so that kind of opportunity you have to use. You have to have facts at your fingertips. If you talk about HPV vaccination or tobacco, you need to know exactly the issues there with real numeric data out there. Be thorough with the proposed change. Don't just be very generic. And then you have to titrate the advocacy accordingly, and then finally be brief and direct. So in my view, the advocacy spiral, as I call this, is the way that you need to sort of crystallize and synthesize your information in a way so that at the end of it, you are ready to advocate. Education alone is not enough to change. We just had the tobacco example again. Many years back, 30, 40 years back, doctors used to advertise for tobacco. Are doctors not aware of tobacco harms? Nurses not aware of tobacco harms? Even now, a lot of doctors and nurses smoke. So which clearly says that a change in behavior or change in policy is not just the result of knowledge. Knowledge is critical, but that knowledge is not enough to make the change that we want. So what do the change that we want? So let's stick with the end game of tobacco. Let's take an example. Okay, we want an increase in taxation by 30% over 2 years. So first itself, you should, I'm just giving an example, but it can be 70% also over 2 years. What are the information needed? What is the tobacco prevalence in youth, in girls, in women? Impact on health? What are the economic losses? Who needs to act? It is not just saying general advocacy. You have to be very focused on finance ministry or the group which is doing taxation and the health ministry. What are the scenarios? WHO has got a tobacco tax in which will give you different scenarios. What are the successful examples? The Philippines has actually increased tobacco taxes, got a lot of revenue, and covered millions of people who are poor with universal health coverage. And that is the kind of powerful advocacy that you bring in by saying that it is not just theory, but it is feasible. What are the counter issues? You should really be aware of the counter issues. Small farmers, small livelihood issues, all those will come up and you should be ready to answer them. You should have the solutions, like as you heard, the alternate cropping or new sales of other products, etc. And finally, it is not just one person, and advocacy becomes actionable when it comes from multiple corners. And that is why politicians, farmers, students, everybody should be singing the same song as it is. Again, be specific. For example, if you want to increase financial allocation for primary healthcare by 10%, that is the policy change that you need. What needs to change? What is the finance needed? How that 10% is going to be used? What are the challenges? Because I go to a lot of meetings, people just generically say, oh, PHC is important, UHC is important, this can be done, that can be done. That is not going to make the difference. We have to be realistic. Let's say childhood obesity is increasing. In fact, during pandemic, now countries are reporting that during this last year, childhood obesity has increased for obvious reasons. Now, what are the things that we can change? We can change food availability, but that will depend on economic situation. Agricultural policy can be immediately changed. Maybe, may not be. Food marketing in a country like India, where there is non-formal sector is very high, streets food is very high. It may not be as easy as in the UK to control food marketing. Education, as I said, education can improve knowledge, but need not change to behavior. But then what can change first? Maybe there is a midday meal program in all states in India. So maybe the midday meal program, are they just giving sugary biscuits there? Can we just change that to a fruit which is grown locally? So be very realistic as to what can be achieved. And that is because it is the success that will lead to success. So I think in public health policy change, what the public health advocacy has to be very appropriate to that time, be realistic and be sort of palpable for the person who is able to change that so that they can take action accordingly. Just to be put at appropriate level. If you want to have something happening in the Department of Public Health in JIPMER, then you talk to and advocate to Siddhanshu. But if it is something about the whole of JIPMER, they go to the director. If it is something to the entire Puducherry, then you talk to the Lieutenant Governor or the cabinet there. Or you take it to the Ministry of Health, or you take it to the Global Climate Summit if you want to change climate, and people even talk about planetary health. So be very sure as to where you want to pitch it. You can't just sort of pitch a change that is needed at the national level to the local department. We have to make the real relevance of the people. We should have the people who are really impacted and be part of the solution. The problem and the solution has to come in the same table so that people can actually know what is the change that is needed. Finally, and I would say most importantly, believe in what you want to achieve. Look at these 4 great leaders of the world: Martin Luther King, Mahatma Gandhi, Mother Teresa, and Nelson Mandela. They all believed in the change that they want, and they achieved that change. I think public health advocacy comes with a certain amount of passion, a certain amount of conviction that needs to change. And finally, be patient because good things take time. And there are no shortcuts to any place worth going. So thank you very much. And I'm sure the rest of the speakers are going to elaborate in great detail. And thank you.
Thank you, sir, for a wonderful session. So you have spoke not only of the advocacy and also about something which youngsters would learn is how to make a presentation, for advocacy. So we loved your session, sir. So over to you, sir.
Yeah, so you are right. I mean, this is how, in advocacy, learning by doing that, in a very small presentation, very effective message has been given that, knowledge is not enough. You have to change and you have to have right people and you have to believe in what you want to change and you have to be realistic and, very effective message for all those who want to do advocacy. So now maybe invite our next speaker. Please, can you put up the profile? So, yeah, I'm not sure whether I'm pronouncing it correctly. Dr. Selina Skoken. So it may be wrong.
Shoken, it is Shoken.
Shoken. Okay. She is the principal of Advanced Global Health LLC, a consulting firm focused on health technology and innovation in developing countries. She previously served as Director of Policy and Advocacy at Merck for Mothers, where she led the Saving Mothers, Giving Life public-private partnership. This is great. Public-private partnership is most difficult part, and people want to leave the private sector because it is very difficult to touch. So prior to Merck, Selina was Director of International Organizations at Population Services International, in which she worked with Global Fund to fight AIDS, tuberculosis, and malaria and other multilateral organizations. She has also served as Chief Advisor in the Rwandan Ministry of Health at the World Bank and at the Global Fund to fight AIDS, TB, malaria. And in 2005, she was a fellow at the Council on Foreign Relations. I think lots and lots of national and international organizations in diverse fields. It will be really a feast to listen to her about this important session on advocacy. Over to you.
Hello, my name is Selina Shoken, and I'm the principal at Advanced Global Health, LLC. I've been working on cervical cancer prevention and advocacy for several years, and it's a pleasure to be with you today to talk about how to build partnerships for cervical cancer elimination. As you probably know, cervical cancer is and continues to be a big problem around the world. And last year, 311,000 women died of this disease. It's also a disease of poverty. And you can see from this map that the darker shaded countries are where there's higher mortality from cervical cancer. I think that this map also shows a certain level of opportunity, though, because you can see that in Australia, Canada, the United States, Europe, and other countries, these maps are shaded much lighter color. And what that means is that this is a preventable disease. If we have the right tools and we focus on this disease, we can prevent women from dying of cervical cancer. In light of that, the World Health Organization has adopted the cervical cancer elimination strategy, and it was adopted by member countries around the world. The goal is to eliminate cervical cancer as a public health problem. In order to get us on the road to cervical cancer elimination, we set targets for the year 2030. And those three targets are that 90% of girls would be fully vaccinated against the HPV virus by 15 years of age, that 70% of women are screened with a high performance test by 35 and 45 years of age, and that 90% of those women who screen positive and need treatment receive the treatment and care that they need. So we find that HPV vaccine is an incredibly effective way of preventing women from developing cervical cancer. And the countries in green have adopted HPV vaccine into their national immunization programs, but many countries, those in gray, have not yet been able to do so. Some of the lowest income countries qualify for Gavi, which allows them to purchase the HPV vaccine at a lower price. But as countries graduate from Gavi, that can be a problem. However, we're anticipating that there's going to be an increasing supply of HPV vaccine and new manufacturers coming online in the next couple of years, and that the prices of the vaccines should be able to drop so that more countries can adopt the vaccine into their national immunization programs. But for now, as you can see that in the year 2020, only 13% of girls over the age of 15, less than the age of 15, received the vaccine. So that is actually quite a low coverage when you think about the 90% goal that we have. So we have some work to do in this space. On screening for women at the ages of 35 and 45 years old, we also see a huge divergence between the low and the middle income countries with the upper income countries. So the countries that are in sort of a lighter yellow, orange, and red are those that have much lower coverage rates than those in green. And we can see that in India, between 0 and 9% of women have ever been screened for cervical cancer, which is really too low. And if you'll recall again, the target here is 70% of women screened by the year 2030. So we have work to do. Cervical cancer also creates a number of socioeconomic, cultural, and political challenges. There's really high stigma around cervical cancer. In part, it's because we're talking about women's private parts, and that makes people really uncomfortable. Sometimes women have been accused of committing adultery, and that's why they got sick. And of course, we know that's not true. With the HPV vaccine, we also see vaccine hesitancy, and we see fear that the vaccine could impact the young girl's reproductive health. We know that it's not true, but there are these kinds of fears, and that's an opportunity for advocacy, is to educate people that that's not actually the case and that the vaccine is safe and effective. We know that there's lack of access to vaccination, screening, and treatment, and that many, many girls and women don't have access to these services. Gender dynamics are also a problem. The low status of women, and sometimes women are not even able to access screening and treatment if they want it. We also know that for women who do have a precancerous or a cancerous lesion that need treatment for that lesion, they're often not able to find that treatment in their communities. And sometimes they need to travel to another city or town in order to get that treatment. And that can be prohibitively expensive. And I think over all of this is the fear of cancer. It's knowing that you're identified as having this disease is really, and that it's a life-threatening disease is really, really scary for many people. So we need to do more work to educate that cervical cancer is preventable, especially if we find it early. So there are many issues that need advocacy. On the vaccine, we need to do more messaging with, so to and from our community leaders, our religious leaders, women's leaders, and parents. We need parents to understand that this vaccine is an anti-cancer vaccine, that it's safe for their daughters to have, and that this is a good thing for parents to ensure that their daughters receive. Religious leaders can also be really important advocates around the vaccine. When they speak in front of their community and say that this is a good thing to do, it really drives behavior. And of course, women's leaders and community leaders are integral parts of cervical cancer and HPV vaccine advocacy. We need to make sure that all girls get the vaccine. Not only those that can afford it, we need to make sure that there's programs so that all girls can get the vaccine. And we also need to focus on out-of-school girls. We've seen that often girls that are in school have more access to getting the vaccine, but some girls are not able to be in school, and we need to make sure that they have access as well. On screening and treatment for adult women, we need to ensure that women know that they do need routine screening before the ages of 35 and 45. We want to make sure that their husbands and their families, including mothers-in-law and others, support women's need for screening. Quality of care is also important. We've seen the WHO recently recommend that we should move away from visual inspection of the cervix to HPV testing, which is a far more accurate method of screening. Quality of care is also important. In many places, the quality of care is not at the standard it should be. One of the most important things that we've seen in India is actually that many women are receiving too much care, what we call overtreatment. So women with a small lesion that is very easy to ablate using thermal ablation or cryotherapy, sometimes that is actually being treated with a hysterectomy, which, as you know, has severe reproductive health consequences for women, and it's medically unnecessary. So we need to make sure that women are treated with ablation when they qualify for it and only get hysterectomies or other much more significant invasive procedures only when they need it. And finally, we need to make sure that women receive adequate, respectful, quality care for all women, and especially women who have cancer and need treatment. So there are a number of advocacy challenges that I think we need to think about as advocates. Some of these are caused by COVID-19. We know that people are focused on other things. There's a limited amount of money, a limited amount of time, and people are focused on COVID-19 or on other very urgent issues. We know that women are staying away from healthcare services unless they're really sick. So it's very hard to convince people to go to the health center if they're not actually sick because they're worried about getting COVID. We know also that this disease has led to an increase in violence, and it's led to fear for women, and they're facing increasing violence in the home and sometimes outside of the home. And there's also an increase in poverty. So what can we do? We can advocate, we can raise awareness about cervical cancer. We can work to design safe approaches and make sure that women are not exposed or at risk of getting COVID-19. One of the ways that we're doing this is with self-collection for HPV, which is really easy to do. Women can collect their own sample, and they don't even have to go to the health center, and they can still be tested for HPV. We also need to listen to women, help women who have domestic violence, help them respond to that, to poverty, other household issues. And we also need to make sure that cervical cancer programs are affordable. So how do we form partnerships to fight cervical cancer? And I think partnerships are really important. We're much stronger if we work together and if we work across different groups. So we might work with sexual and reproductive health groups, we might work with women's groups, youth groups, public health, HIV, maternal health. Economic development groups have a strong interest in preventing cervical cancer, religious groups and business groups. And I'm sure you can think about in your communities, who are the groups that might care about this and how could we help to bring together a coalition to increase access to services? What can all of these groups do working together? Well, we can encourage women to get screened and treated and to make sure that girls are getting vaccinated. We can help women find the care that they need. Sometimes it's really hard to navigate getting care. We can support families by providing them information and education about cervical cancer, and we can reassure husbands, mothers-in-law, and others about the importance of cervical cancer screening and treatment. We can work to increase access to vaccines, screening, and treatment. And I think all of us have a role we can play in decreasing stigma related to cervical cancer. There's a lot of different advocacy activities, and they'll depend on what the needs are in your community. It might be holding a community meeting. Those can be incredibly effective at dispelling myths and decreasing stigma. Meeting with local, regional, national leaders to push for more cervical cancer prevention activities. Meeting with local health leaders to make sure that women have access to screening and treatment in local health centers and in local hospitals, making sure that care is respectful and that there's quality of care. Different groups might be interested in letter writing campaigns or writing opinion pieces in the newspaper or in the radio, getting out your voice that this is an important issue. We also do a lot of webinars. Webinars are a great way during COVID-19 of getting information out to healthcare providers and to others that are going to see women and making sure that they're providing a high quality of care. Radio and TV interviews are another thing that can be done. Meeting with donors, that could be bilateral donors such as USAID, international donors like the Global Fund. Meeting with companies and corporations to see how to get them involved and to make sure that their employees are also being screened and treated. Meeting with foundations and others. You could do days of action, such as a march in the street. You could hand out flyers and brochures and other information. And I think finally, one of the most important things we can do is we can support women that are affected by cervical cancer. That might mean raising money to make sure she can go to the next town in order to get treatment. It might be supporting her family, helping her to be able to access the care that she needs. So I wanted to give you a couple of examples of cervical cancer partnerships. And one of them is called PPAL, and it's a partnership on building cervical cancer leadership in Tanzania and India. And this program is active in Varanasi in India. And it's very much focused on building leaders. So they have leadership development programs, both online and in person. And they also focus on trying new approaches that are innovative, testing innovative products and projects, and sharing the lessons learned from those projects amongst themselves so that they can all have stronger cervical cancer programs in their communities. Another partnership is Together for Health. Together for Health is a partnership of different nonprofit organizations and private sector companies that work together on global advocacy to increase attention and activities related to cervical cancer prevention. They publish a lot of reports about financing for cervical cancer. They have webinars and they provide a lot of information about how to access funding, how to access programming, and what is quality programming. And I wanted to tell you about a recent campaign that Together for Health has undertaken. The World Health Organization published some recent guidance, and it suggested that countries really need to move away from visual inspection with acetic acid to HPV testing. And that does have some financial implications for the countries and also for donors funding these programs. So Together for Health put together a letter writing campaign where they sent letters to the heads of the large donor organizations such as PEPFAR and the Global Fund in order to advocate for the move from VIA to HPV testing because it's more effective. And they got all of the organizations you can see on the screen to sign on to that letter. And by doing that, it makes it look like this is a really strong effort, that all these groups can work together and that this is an issue that's important to all of these groups. So the letter was just sent last week, and so we don't know what's going to happen. But now we have all of these groups saying that this is an important thing, that HPV testing should be done for women, and that all of these nonprofits support it. So hopefully this will be an effective letter writing campaign, and we will keep you posted on how that works. There's also a lot of information that is available about cervical cancer prevention. You don't have to create new things for the most part because there's a lot available. The World Health Organization, UICC, the American Cancer Society, Together for Health, which I just mentioned, and Cervical Cancer Action for Elimination. They all have toolkits and information. They have webinars. They have guidance and newsletters and other ways that you can gather information. I would recommend starting by going to their websites, which are included here, because they have a lot of the information you need to get started on cervical cancer advocacy. So what can we learn from these partnerships? I think one is that you can be the organizer. It really doesn't take that much. That letter writing campaign that Together for Health started really wasn't that much effort to write the letter and then to send out emails to other organizations and to ask them if they wanted to join. It turns out that these groups are very interested in working together. And if you make it easy for them to be a part of your campaign, you can bring together a lot of groups and show that you have a lot of support for your idea. Also, government leaders and donors, they care about looking good. They want to get good press and they want to be seen as doing the right thing. And so they're actually very interested in hearing from advocates, and they want to hear advocates' ideas. As I said with the Together for Health work, joining groups together can have a really big impact. If you bring together groups from different sectors for cervical cancer, there's really a lot of partners, and there is strength in numbers. And I think finally, we need to support leaders and support women's voices. We need to make sure that we have great leaders, really accomplished, well-spoken people that are speaking out on this issue, and make sure that they have the right messages. And finally, I think my thoughts are that cervical cancer is a cost-effective, life-saving intervention. Cervical cancer programs can be integrated into existing programs for reproductive health. We don't have to create new programs. We can make sure that cervical cancer screening is what's done every day at the health centers and at the hospitals, and it can be integrated in a very cost-effective way. There's a lot of programs that are already underway in India. So understanding what is going to work in your community, who are the other groups in your community, these are great ways of banding together and getting more done, because really we are all going to have to work together to reach those 2030 cervical cancer elimination targets. So I think I will stop here. I'd be happy to be in touch with you if you have any questions or any suggestions or thoughts, or if I can help you get started on your cervical cancer advocacy work. My Twitter handle is right here, and I look forward to hearing from you. Thank you very much.
Thank you, Selina, for a wonderful talk, and you have touched upon really very important topic, cervical cancer, and we as public health practitioners are also surprised that this is one problem that is associated with some infections. Very safe and effective vaccine is available, but still the coverages are so low, and even country has not yet adopted it. And you have so many actually issues surrounded with it that even for screening, testing, and treatment, you need to have good health systems in place. So the one problem is that how those systems can be put in place so that this clinical service of screening, testing, and treatment can be made available. And then the second issue you touched upon is the stigma associated with all this. So all those interventions at the community level to reduce those stigmas, and then to improve the acceptability of the vaccine and the actions to actually take the policy decisions that this vaccine should be introduced. The country level, still I think there is no decision. Some states are doing because health is a state subject. So many issues to be tackled, and you have given very good tips and examples that there are some partnerships who are doing a lot of good job, and then let us build partnership and then put pressure on all the stakeholders to roll out such an important intervention. Thank you very much. Over to Dr. Mahalakshmi for the next deliberation.
Thank you, Selina. She very nicely touched upon various advocacy measures. Now we go to the next speaker, Reena Nagarajan, who is the editor of research in Times of India from New Delhi. We'll be going to her session. I request the tech team to please play the session.
Ma'am, your voice is not clear. Please say again.
Tech team, you can start with the next video. Reema Nagarajan.
Okay, sure.
Hi, everyone. I'm basically going to talk about the infodemic in the times of our pandemic. And I guess COVID being a pandemic must be the first one in the age of social media, which is why we are facing the infodemic that we are facing, which is basically overabundance of information. And how difficult was the job of a journalist in such a time is basically what my talk is going to be about. How we have to swift through an avalanche of information to make things understandable to our readers or to our audience. So WHO thinks that, infodemic is dangerous enough that, they now need to hold workshops, they need to hold, conferences to train people on how to deal with this. Because actually infodemic affects how the public health strategies work on the ground. So this is WHO's definition of an infodemic, which is basically an overabundance of information. And it's basically divided into two, misinformation, and then there is disinformation. The difference between the two, of course, is in the intent, which is that, disinformation is something that is done deliberately, whereas misinformation need not necessarily be the case. Now, let's look at what made COVID prone to an infodemic. One, of course, is the fact that it's a new disease. And second is that it affected almost everybody. But having said that, I must add that it did affect the poor the hardest. But if it affected only the poor, it wouldn't have got the kind of coverage that we saw. It's because it affected people who are well off. And for the first time, they probably realized that neither money nor influence could get them out of the clutches of this infodemic. That, they realized what had hit them. And that made sure that the media also covered the issue with such intensity, because the people who had influence were actually being affected. And the other challenge that we faced was that everything that we knew about the virus kept changing because it was new. I mean, the virus, the disease, everything kept changing, it kept evolving, and it was difficult to make people understand that, what I said, what we might have carried 2 weeks back or a month back, what we said is not true anymore, not because it was fake news and not because we didn't, try to bring them credible information, but because the understanding of the disease has changed. And there were several instances of this, from how the disease spread to what kind of treatments were available. And it didn't help that, we had really poor communication from the government and the scientific establishment, which I will go into, and how, the infodemic actually contributed to that, to how both government as well as the scientific establishment also contributed to the infodemic. So we'll first take a look at misinformation. Misinformation is where WHO cautions that it could cost lives. And actually, we saw that, lives were affected because of misinformation. And one of the things that we saw was, hyping of various kinds of treatment. There was overabundance of, information on different kinds of treatments, lots of studies happening. And one of the earliest hypes, of course, was plasma therapy. But we are not, we had a whole lot of them happening. We had HCQ, we had a BCG. I mean, all kinds of drugs were being talked about. There were studies happening on all kinds of them. But I'm going to specifically look at plasma therapy just as an example to show you what happens when we have that sort of, overabundance of information. So the first thing to look at is the fact that plasma therapy came into this whole scene with just a case series of 5 patients, which was published in JAMA in March 27. And then we had the first case where plasma therapy was used on April 26, 2020. And ICMR, soon after that, ICMR gave permission for the use of plasma therapy in clinical trials by the end of April. Now, this is what the series of information. And what do we have when ICMR gave permission? What does that lead to? it basically leads to, rampant misuse because there was absolutely no sort of oversight, no audit, no regulation of any sort to see whether, plasma therapy was being used in clinical trial mode or not. Now, so let's look at what different people did in terms of plasma therapy. So what did the government do? Here we have the Union Health Minister right from the beginning saying that, this is fantastic, we should encourage everybody to donate blood. And then, we saw that, the hospitals were more than happy to hear this. And we saw a whole lot of them actually climb onto this bandwagon. In September, actually, ICMR study came out, the preprint of the study, and showed that this might not be as effective as it's made out to be. And in spite of that, in October, here we have the Health Minister of Delhi batting for plasma therapy and actually telling ICMR that they should not be shutting it down. So we have these kind of conflicting information coming out. And this was a real challenge, not only for journalists, but also for common people to understand. And it is this confusion that was taken advantage of, and a lot of people were actually given plasma therapy where it was not required. Now, what did the scientific establishment do? How did they contribute to this infodemic? So there is our premier research body, which is ICMR, which let plasma therapy remain in the treatment protocol all the way till May 2021, even though its study showed in September that it doesn't work. So that was one. But at the same time, as you can see, US FDA was not very different from us because they also gave emergency use authorization for the therapy in August 2020 and again reversed it in February 2021. The reason why I'm putting in Mayo Clinic study is because a lot of private sector hospitals, when asked, when journalists or when media gets in touch with them and ask them, why are you using plasma therapy when there isn't enough evidence, they would immediately say the Mayo Clinic study. And the study itself had so many problems. The fact that it was a retrospective analysis, the fact that, they didn't have a placebo arm, all of those things were problematic. In spite of that, they went ahead and published it. They had it on their website saying that, plasma therapy is effective. And what we had was, a whole lot of people being put through plasma therapy till the time we saw the recovery trial coming out, which showed not only is it not effective, it actually might be harmful. So you can imagine all the people, thousands of people who were given plasma therapy at this time. So this is what happens when you have this sort of flood of information coming without anybody to, have any sort of check on the kind of information coming in. And now let's look at what media did. Now, media also, while some of them did try to do responsible reporting, there were a whole lot of them which actually went on to do campaigns around, donate plasma. And another one was actually going to, feature all the people who donated plasma by calling them, heroes and so on and so forth, and a lot of human interest stories. So media actually played into this whole hype, and you cannot blame patients and their families for actually running from pillar to post and spending so much of money trying to get plasma, which is being sold in the black market. So now we'll come to disinformation. So that was an example of misinformation which I was giving you. And, just substitute plasma and put HCQ there, put BCG there. You can put remdesivir there. It was the same scenario. It happened in the same way. We didn't have our regulatory body stepping in at the right time. We had media also adding to the hype. We had the government not acting on time. So it was, you can substitute any of these things. It would be the same. Now coming to disinformation, disinformation is far more dangerous because it is done deliberately. And we have a classic case of state-led disinformation, which is basically the Tablighi Jamaat incident. Where the state, the government itself was actually leading the disinformation. We had, press briefing happening every day where they would give separate information about all the thousands of cases across the country, which were caused because of the Tablighi Jamaat meeting. Now, the point is, how would public health have been served in knowing this? There is no reason for them to have done that except actually to foment trouble. And it's not just the central government, many state governments also, like, for example, in Delhi, we had a separate number being given for the number of infections which were supposedly originating from this meeting. Many states did this, and they actually played into this whole thing. And this is when you have the ministry saying this. This is what the health ministry says in its guideline. So, I mean, guidelines were apart. They went ahead and broke their own guidelines to do what they did. So that's a classic case of disinformation. Now, this is as far as, the two kinds of infodemic is concerned. The third is, the amount of data that we had flowing in. The moment COVID happened, the government started launching digital platforms, dashboards. They were giving us everyday counts of deaths, counts of confirmed cases. So there's an abundance of data. I mean, and once vaccination started, we had, vaccination data coming out every day. The point is, did all these data help us report better? Did it help people understand better this flood of information that was happening? Actually, no, because a lot of the data which was being given was incomplete and also not disaggregated properly, and it's not granular. So let's take a look at an example. For example, the adverse events following immunization. Look at what COVID gives us. This happens every day. Every day they show you the cumulative percentage and the total number of AEFI. It's a completely meaningless information that is being given, because there is nothing about the severity or the seriousness. It is not, you don't get to know which vaccine cost what, which was it first or second dose. So none of this information. This is classic how government has been giving data out in such a way that people cannot use it, that it doesn't have much meaning for people. Now, data and advocacy, the problem is that, if you don't have data, it's very difficult to actually plan your strategy, not only for the government, but also people need data to take informed decision. And what happens is that when you assess, you also have data coming from official sources which are not credible. And if you don't have credible sources of data, the point is people will go and pick it up from places which are not so credible. And loss of credibility for the public authorities is really unfortunate, because people will start wondering what you're hiding and why you're hiding, and actually let their imagination run wild. We don't want them to do that, but that's exactly what would happen. What could have been different in all of this? Could ICMR have coordinated with hospitals to do a better job? Yes, so much could have been done. We have a lot to learn from, how this pandemic was handled. What could we have done differently? So some of the things we could have done is, yes, I mean, ICMR could have been more responsible. The other one is that, Indian scientific community as well as ICMR could have updated the protocols a little more on time, so that we were not at sea with information floating in from all kinds of sources. And the other one, of course, is uniform parameters for reporting. We wish the state government and the central government would sit down and talk about a uniform format for reporting all this data, so that it was easier to make interstate comparisons and also to understand the scenario all over the country. So if nothing else, one good thing that has come out of this is that journalists now know a whole lot of public health experts, have their numbers, have their contacts. They know what an epidemiologist is, and they know a lot of epidemiologists. And hopefully in future too, we will see both public health experts and epidemiologists actually contributing to our health policy, instead of, us having to talk to or listen to cardiologists and corporate hospitals who will hold forth on what our health policy should be. Thank you.
Thank you, Rima. It was a very good presentation on how infodemics was contributing to the COVID during the COVID pandemic, and she also stressed on how public health is important, and how getting briefing from the about the policy from public health people is important. Thank you, Rima. Sir, over to you, sir. Arun, sir, any questions or anything? I think Rima is not there signed in. Any comments?
No, I think this is very important that this COVID-19 and whatever was flowing from it, and all these problems what she has highlighted are really important. And everything, everyone, every stakeholder, maybe this is the government or the experts or people or the media, everyone has to be responsible in communicating what is required. But at the same time, I would say that this pandemic, we call it VUCA, it was such a volatile, full with uncertainty and complexities. Nobody knew that what is right, what is wrong. And everyone was learning as the things were evolving. Protocols were being developed, and that is why a lot of confusion. So only the lesson, should have been that there should be core committees of public health experts, epidemiologists, and the right people who should actually pass on the messages to the community, etc. It is not everyone who should come out and say whatever they want to say when such pandemics they strike the countries and globally. So responsible information should come out, and I think that is the message which I wanted to give. So now, do we have the fourth presentation?
Yes, sir. We'll
over to you.
I'm very happy, in fact, to introduce Dr. Stuti Pramod, who's a junior resident from our own department from JIPMER. So usually when we think of advocacy, we think of big people telling to the policy makers. But definitely the role of youth who are very energetic is there. And Stuti Pramod is a very active, energetic person in our department, who was one person who was behind through all the plenary sessions and other things. And now I hand over the session to Dr. Stuti.
Greetings, everyone. I'm Stuti from JIPMA, and I would like to talk to you about advocacy for and among youth and offer my 2 cents here. So when I hear the term advocacy, I think of someone standing up for a cause. Now, this could either be someone standing up for themselves and making sure that their voices are heard, or someone doing so on behalf of someone who is less privileged and cannot do so for themselves. But what often fails to enter this conversation is, do they really have a leg to stand on? Are they making these decisions, or are they forming their opinions based on facts and information, or are they simply being drawn towards the most sensational piece of information that there is out there? So this is where evidence-based advocacy comes into the picture. And speaking on behalf of the youth fraternity, I would want the stakeholders or the decision makers to make sure that they see to this. So as it was just mentioned, there's a lot of misinformation and disinformation out there. So with this infodemic that is going on, how can I be assured that people who are making these decisions on behalf of me, or making these decisions supposedly in my best interest, know the difference between the two? They know what misinformation is as compared to information. How do I know that they can make an informed decision? How do I know that they're letting the facts speak for themselves? How do I know that they're looking at the numbers and then making sure that they do justice by their decisions? So with that being said, I would like to bring your attention to a few examples where I think youth advocacy is more important than ever. So first of all, this happened a couple of months ago. I was trying to look at the statistics and compare between the first wave and the second wave of the COVID-19 pandemic in India. So the first wave happened in 2020 and the second one in 2021. What I basically wanted to look at was how many people have gotten affected, what their social demographic profile is like, and how it has evolved over the years or the months rather. Is there any change in the pattern? Is there any change in the affliction of people? So when I was trying to do this, the first thing that really caught my attention was that there is no single credible source of information. All the information that we have out there is so fragmented that it does not let you piece everything together to get the full picture. So with that, how am I supposed to get all the information? How am I supposed to know that the information being presented to me is correct? How am I supposed to know that the people who are making the big decisions or calling the shots are not looking at the same information? Do they have credible data? Do they have a sense of what the reality is as compared to what is being presented? And this was something that just hit me and got me thinking about where else we need medical professionals or the youth to actually apply themselves, look at the information, and try to make decisions where their best interests are being discussed. So, going along the same lines of the pandemic, what also happened here was that I started thinking about all the other issues that have affected the youth more than anyone else during this pandemic. So, the first one being job security. Now, a lot of us do not have the privilege of job security, or rather, don't have the luxury, especially those who work in unorganized sectors. Is there anyone speaking up for them? Is there anyone trying to discern what they actually need? Or are they simply considering that they're doing right by them by just doing what is expected? Are they really talking to them? Are they really listening to them to see what they think is important? Yes, that may or may not be right. I mean, the felt need and the perceived need and what the actual need is may be different. But that does not mean that they don't get a chance to voice their opinion. It does not mean that they shouldn't have a say at all, right? And the more I thought about this, my mind went to issues like stress, burnout, fatigue, social isolation, and disconnect that is often talked about in social media. We often talk about this with our peers as well. We talk about staying connected, that these are tough times and we need to have each other's backs. But is saying that enough? Is simply talking about it enough? Or do we need someone to stand up and make sure that these issues are not disregarded as less important? Do we know that there is somebody who is taking all of this into consideration when they call the big shots? And if you look a little further away from home, my mind went to a few more pressing social issues, such as physical and sexual abuse, medical termination of pregnancy, where one's autonomy is in question. And when the issue is as pressing as this, it is not only understandable, but also justified that the people who these decisions are being made for get a say. They need to be able to tell others what they think is the best for them or what they think is the next step. What should be done? Who's speaking up for us? Who is taking our opinion into consideration? Again, this needs to be taken with a pinch of salt because there is always two sides to any kind of opinion or any kind of story. So yes, we do need to make sure that their opinions are also based on the information or the facts and not just, make any kind of irrational decisions in the name of taking everyone's opinion into consideration. But then again, that does not give anybody the right to take away someone's voice. That does not prevent anyone from being able to speak up. So this is what got me thinking about the need for youth advocacy and other issues where the young people need to have their voices heard. The young people should be given a chance to speak up and let the policymakers and the stakeholders know what they think is important, what they think the next step needs to be. And yes, this is how we learn. The opinion may not always be right, but again, it's a learning process and it's a two-way communication. So I believe that if we were to bring youth advocacy into the picture and if we give them a seat at the table, they will definitely have something to offer. They will definitely have something significant to say, if people are ready to listen. And with having said that, I do believe that youth advocacy has always been important. Yes, it is being talked about a little more now than ever before, but that does not mean that it has not existed before. There have been examples from the past where young people have been able to stand up and make a difference. Why can't I be one of them? Why can't you be one of them? Just something to think about. Thank you.
Thank you, Stuti, for that wonderful talk. And really, it was a pleasure to hear about youth advocacy from a youth and their own perspective, and also a perspective from the medical side. We talked about how we need to balance their voice and especially about the missed out people. So thank you, Stuti. It was a wonderful talk.
Thank you, ma'am. Thank you for the opportunity.
So do we have any question answer session? Or we need to summarize and conclude? Dr. Mahalakshmi? You are on mute.
Yes, sir. So in this session, we started with the key speaker, Dr. Cherian Varghese, talking about advocacy and a very crisp presentation of the funnel, the advocacy funnel, which I think all of us need to keep in mind when we talk of advocacy, the key points. It was well taken over, sir. And Selina was talking about, yes, she not only told about the problems, she also told the solutions, and she told about what could be done at all levels, in the ground level and also at the top level of policy making. She highlighted very nicely the partnership, taking an example of cancer cervix. And then infodemics, yes, it was like the other end of advocacy. If the advocacy is not done properly, what happens? So it was clearly told by Rima and Stuti, of course, the voice for the youth. So it came out through Stuti. I think the key message is being that advocacy is one of the key tool, and it should not be underplayed or overplayed. So it should be played in a right way. Over to you, sir.
Thank you very much, Dr. Mahalakshmi. And I think this was a wonderful session that from generic principles of advocacy and then application in some specific context, maybe this is HPV and then related infodemics, etc. And then youth advocacy. This is, I think, and JIPMAR scientific committee has demonstrated by including a youth resident into such an important panel to voice the views, and this itself is a demonstration that youth advocacy is really important. But my message to all the public health practitioners is that, I mean, if you look at theory of change, ultimately all public health practitioners, they want to make a change. Maybe this is at the policy level, program level, community level. They want to make a change. And advocacy at all the levels is an important skill and instrument. And for that advocacy, whatever we learn in public health, maybe this is epidemiology, health management, social sciences, whatever it is, the output of that should go to the advocacy so that you can make a change. And I very strongly feel that our fraternity is very, very weak in this science and art of advocacy. So if we can build partnership among ourselves and we are able to demonstrate our worth to everyone, so that we lead this front of advocacy, only then we will be able to make some change at whatever front we want to make a change. And I would be very happy if this the deliberation by the eminent speakers motivate our associations and fraternity to do something concrete for advocacy, advancing this science and art of advocacy. It would be a great contribution to the nation. Thank you very much.
I would like to take this opportunity to thank the speaker, Dr. Cherian Varghese. I know of his busy schedule, giving us time and addressing the young youth to motivate and talk about advocacy. Thank you, sir. I thank the other speakers, Dr. Selina and Rima, and special thanks to Stuti. It's definitely stressful for a youth to talk to a large gathering, so she has taken that. Thank you, Stuti. And thank you, Arun Kumar sir. Your words of wisdom is really going to inspire all of us. Thank you, sir. We'll be proceeding for the next session. Thank you, sir.
Good evening, everyone. I welcome everyone who have gathered here in person as well as in virtual platform for the valedictory session of Iphacon 2021. I request everyone to kindly stand up for Dhanvantri invocation.
धन्वन्तरी स भगवानमृतत्वदाता यो वैद्यकस्य गुरुरादिरनादिकालात् यो हार्तदेगमन आत्मसुखावहस्य नैरोग्यतस्य निदरां चन्द्रुणां हितस्य तस्यारणास्पदमहर्षिवरस्य शिष्य ये त्रेवयं प्रमुदिताननुभाग्यवन्तः देवप्रतीपितचरं सुचिरात् शुभायुः वेदस्य दीपामिह तत्पुरदोतरामः येन प्रभां वयमिहस्य विदद्य दिक्षु ज्योत्स्नां रुजातिशमनी प्रभवेम दातुम् व्यादिव्यकात हृदयाय मानवाय देयं द्वितम्बुविकलापि च न किलैषः देयं द्वितम्बुविकलापि च न किलैषः देयं द्वितम्बुविकलापि च न किलैषः.
Now I request Dr. Sitanshu Shekarkar, Professor and Head of the Department, Preventive and Social Medicine, JIPMER, and Organizing Secretary of Iphacon 2021 to give his welcome address.
Thank you, Nandini, and good afternoon, everyone. Respected Dr. Sanghamitra Ghosh, the Secretary General of Indian Public Health Association, Dr. Gautam Roy, the Organizing Chairman of Iphacon 2021, Dr. K.C. Premarajan, the Chair of Scientific Committee, and Dr. Subhita, the Joint Organizing Secretary. I welcome you to this valedictory function of 65th Iphacon 2021. It's indeed a pleasure to go through the last 3 months activity that we have done here. It is marvelous. It's wonderful. So as a part of the responsibility that I have to welcome all of you here, the Central Council members, the faculty in the department, the residents, the students, the MPH trainees, PhDs trainees, and the MD residents, and those who have joined us online, all these other dignitaries, the chairs and other things who are all there. Thank you so much for all those effort that you have put in to make this 65th annual Indian Public Health Conference a success. Though it was done in virtual mode, we have learned a lot. We have through this process we have gathered a lot of experience as a team, and that's the learning that we take to the future from this activity. Through this process of last 3 to 4 months, that we have, what I have realized personally, let me tell you that first, then we'll go to the overall success story or whatever that we can call. So there is a term called team that we always describe in our group dynamics and all the sessions that we take. So team means together everyone achieves more. That's the example that is there for in front of you. Together we have achieved more. Together we can do, which is considered to be sometimes when impossible, when there are multiple people coming together for a particular organizational objective, one particular goal that we want to achieve. It cannot be done by an individual person or a small group of people. Always everyone has to contribute, and that's what you people have done. And that's how we have reached this milestone of organizing the first virtual conference of 65th or IPHA. When initially it was told that we should do it offline, because the plan was to do it in January 2021, thinking that COVID will have mercy on us. That didn't happen. Subsequently, we thought that let's put it in September, so that by that time something better news, good news will come to us, which didn't happen. But when we started planning for the virtual one, there was a lot of uncertainty and apprehension in mind. But as a team, whenever there is apprehension in one's mind, the other person was there to tell us that no, it can be done. That's how the power of togetherness, the power of taking the task which appears to be impossible for a person, but as a team we can achieve that. So that is my learning from this whole exercise. The second thing that I would like to tell the group here is there is an African proverb called, if you want to go fast, go alone. But if you want to go far, go together. So as a team, we have learned that. As a department, we have understood that. So great work to everyone. Thank you so much for being there as a part of this journey. And during this process, as a team, what happens is in the family, as we fight sometimes, we may be rude to someone, but that was all in good intention and all in good faith. So please don't take that to your heart. It's ultimately the organizational goal, as I always keep in mind, that should be achieved. And with this experience, I think we can go ahead and we can try to do something which is bigger than this as well. So with that, with those few words, I would like to welcome you once again for this valedictory function. So last 3 months were so hectic. Now I don't know what will happen tomorrow. No? So all these residents sitting till 11 o'clock in the room trying to arrange for Zoom call for recording and other things. But I'm sure there are some loose ends to tie. We'll all do that, and we'll try to complete all our pending activities. That's all from my side. Thank you so much, and thank you for being a part of this 65th annual National Conference of Indian Public Health Association. Thank you so much.
Thank you, sir. Thank you for sharing the insights and for your warm welcome. Now I welcome Dr. K.C. Premarajan, Professor of Department of PSM, and also the Chair of Scientific Committee, IPHACon 2021, to address the gathering.
Once again, a very good afternoon to everyone and the delegates who are attending online. We are now come to the last phase of this IPHA conference. Last 4 days, we have really gone through a scientific journey, which was the outcome of last so many months of preparation and planning. As chairman of scientific committee, it's been a very satisfying feeling for me today stand before you, thanks to the efforts put in by all our faculty, residents, and friends from different parts, both within Pondicherry and outside Pondicherry. And though as Dr. Sudhanshu has said that we organize this function, this program online, but also, online has got a lot of technical challenges. but at the same time, we fully utilize the opportunities offered by the online by having the almost largest number of panel session, plenary sessions with efforts put in by Dr. Siddhansh to get the galaxy of experts from all over the world, the best, I should say, we could get it. And that has given the real scientific feast. So being an online pro, we could not give the real feast, but really all of you agree that this has been a really, very informative, knowledgeable conference in the sense we dealt on topics not of past relevance, current relevance, and futuristic relevance, especially sessions on COVID. And we got a very good response on that, thinking meaning that is the current issue of interest, and those sessions are really, I'm sure, useful to everybody, especially the young, public health professionals who attended this conference, and how we should be prepared for the future pandemic. Now, all of you agree it's not the end of it. So I am sure the deliberations and the discussion we had during this conference definitely will go a long way in the capacity building of the entire public health fraternity in our country and also outside the country. Okay, so it has been a very onerous, difficult task, in fact, to my team to receive, evaluate, and assess the number of abstracts. I think we received almost nearly 1,000 abstracts, both oral as well as poster. And yes, and we could conduct. We want to be quality conscious at the same time. Give a chance to everyone. So we had 300 oral presentation and about 500 poster presentation organized over the 10 halls. Okay, so let me again take this. I will be failing my duty if I don't thank my team, scientific committee team, my faculty, my residents, MPH, MD, PhD, who has been really, I should say, I know words to express that. It's been a really, I know it's a tough job, but all of you did it as a good team. And I'm very thankful to all of you for that. And let me stop here. Again, we'll announce the awards and all a little later. Okay, thank you once again. Thank you, everyone. I hope all of you enjoyed this. I'm sure IPHA 2021 will must have remain amongst all your minds as a knowledge feast, and definitely it will be a capacity boosting for all the public health friends all over the country and abroad. Thank you.
Thank you, sir, for your kind words. Now I request Dr. Gautam Roy, Professor, Department of Preventive and Social Medicine, JIPMER, and also the organizing chairperson of Iphacon 2021 to address the gathering.
Thank you, Dr. Nandini. With the permission of the House, I would like to sit and address you because I've got used to sitting and doing nothing. Good afternoon, ladies and gentlemen, those who are here in person and those who have joined us online. A very good afternoon. In particular, I would like to say welcome our Secretary General Didi, Dr. Sanghumitra Ghosh, and all the other invitees who have come from far away, and of course, all the team members of the Department of PSM JIPMER. This conference was obviously not the first conference which was held online, but something tells me that this is going to be the norm, where you have maybe a little more of in-person participation, but then we can always have, rope in the experts from far away who need not, take all the trouble of coming down here just for half an hour or 1 hour session. I think this is what is going to happen henceforth. And it's my sincere hope that we could not maybe JIPMER, because I don't know, whether they'll be, but we'll be happy to have another conference here in person so that you can really enjoy what Pondicherry has to offer. And the other part is, though everybody's someone is going to propose a vote of thanks, I must thank not only our team, but all those who participated in it, all our knowledge partners, sponsors, and everyone. Thank you so much. So nice to be having you here.
Thank you, sir, for your wonderful words. Now the moment has arrived for which everyone is waiting for, announcement of awards and prizes. For that, I request Dr. K.C. Premarajan to announce the winners.
It's my proud privilege and pleasure to announce the various prizes and awards just grant for this granted during this conference. First, let me present on the proposal, the award of grants. We have received 2 organizations supported us. One is a Joint World NCT Federation Grant Award. We have received 6 proposals, 3 in 2 categories. One is systematic review and meta-analysis in NCT proposal. And under this category, 3 proposals received. And under this category, the winner is, the proposal is comparison of the effectiveness of different non-pharmacological intervention for tobacco cessation, a systematic review and network meta-analysis by Dr. Venmadi, Assistant Professor, Department of Community Medicine, ESI Medical College, Chennai. Congratulations. Now, under the second category, implementation research in NCD proposal, the proposal which is selected is evaluation of implementing National Health Program in prevention, diagnosis and management of diabetes mellitus in rural urban areas of Prakasam district, Andhra Pradesh by Dr. Tirumala Rao, Assistant Professor, Department of Community Medicine, Government Medical College, Ongole, Prakasam district. Once again, congratulations to the winner. Then we have another grant which is constituted, supported by National Level Resource Center for Tobacco Control from PJ Chandigarh. So we have received 20 proposals, out of which 6 were shortlisted, and the selected one is estimation of the presence of the tobacco industry, direct and indirect advertisement of the tobacco in social media in India by Dr. Vinod Kumar Kalidas, MBBS, MPH. He is now is working Department of Community Medicine, AIMS, Mangalgiri. Incidentally, he graduated from JIPMA, MPH. Then come to another very important. We have conducted a IPH quiz. Last there's been another good participation, and under this we have first and second prize. Second prize went to team from JIPMA, Dr. Prem Kumar and Dr. Dhanajayan. Congratulations. The other, okay, congratulations. And the first prize went to team from AFMC Pune, Dr. Suraj Kumar and Dr. Mandir Kumar. Congratulations to all the winners, and thanks for your active participation for all the teams who participate in the quiz program. Then coming to the oral and poster presentation, we want to encourage all the good participation from good number of delegates. So we had constituted about 60 prizes for oral presentation and 36 for poster presentation. Since you agree that number is quite long, so we will be putting the winners' details in our website today itself. Okay, please, I will not be announcing it now. you please look into our website. Once again, congratulations to all these, and the prices will be, little different from usual time. We will be offering, in addition to the certificate, also very useful books related to public health will be sent to all the winners. Then we also want to encourage more participation from MPH students. So we have also constituted special prize. One is on MCH and geriatric, and the winner is, the prize award goes to Nitya C, MPH trainee. And we have another one on COVID health system, and the winner is Raunik Talukdar, both MPH trainees from JIPMA. Okay, once again, congratulations, and that's all. With this, the announcement of prize awards over. So, okay, thank you.
Thank you, sir.
In addition to that, sorry, breaking the protocol. In addition to that, the cash prize for the quiz will also remain the same that was offered last time. So the first prize, the first cash prize of rupees 20,000, and the second prize will be of rupees 11,000. We'll maintain the same cash prize that was given in AIMS, and it was instituted for the first time at AIMS to promote competition and among the residents. So we'll maintain the same level. Thank you so much.
Now I request Dr. Sangamitra Ghosh, Secretary General of IPHA, to address the gathering.
Good afternoon. This is the end of IPHACon 21, and it was really difficult. When we started discussing about this conference, we thought about the normal conference, which we have always. But number of times we changed the date, number of times we had some meeting online. COVID did not have any mercy on us. So we changed the date. Again, we thought in September, we will have a physical conference. In the last month, means like July and August, Dr. Shitangshu told, no, it's not possible. It will be virtual only. So I told him, please let us come. Only few Central Council member and President and Secretary, we will come. That is a personal reason, because I like Pondicherry. I really like Pondicherry. I really like JIPMAR. It has a very soft corner, because when I became Secretary General, I actually revived Pondicherry branch. It was a very good branch, and I, with the help of Dr. Shitangshu, Dr. Shenali, Dr. Prem Rajan, Dr. Gautam Roy, we actually revived this branch. And Dr. Ajit Shahai, I must take his name. Dr. Ajit Shahai was a very young at heart, retired person, but very young at heart, and very passionate about IPHA, very passionate. So that's why I told, within my tenure, if we have Pondicherry conference, I must come. So here I am. It was a marvelous conference. This marvelous conference, in a way, it was an academic feast. We had session of 18 plenary. We never thought about, in a physical conference, we cannot do like this. It is one of the advantage of the virtual conference, because we could gather worldwide the best speaker, best orator. So there was 18 plenary, 800 abstracts were submitted. There were few rejection, but 800 abstracts were accepted, and 300 was taken, Dr. Prem Rajan already said, and others, rest were in the e-poster. And we had pre-conference 11 pre-conference starting from 3rd September to 19th September. This also cannot be happen. So there are some positive side of COVID. There is positive side of virtual conference. Probably in future, we'll have hybrid type of conference, probably, because this is good. We can have so much good orator like Dr. J.P. Mulyal and Sundarajan. So we had our chief guest, Dr. Shoma Saminathan from Geneva, though she was in Chennai that time. So it is very good in that way. And thanks to the organizing committee and thanks to Dr. Shitangshu, Dr. Gautam Rai and Dr. Premarajan for organizing with your beautiful team. The 12 faculties, I have to take the name. And our residents, junior residents and senior residents, they are marvelous. They are working day and night. Our CC members, must thank them. Our CC members, those who actually they are COVID warriors. They are working day and night, and they came with some of my young brigade also. They came here. They had their CC meetings here, AGB also, and we have taken some very important decision in these meetings. So there are a few changes in the journal. There are a few changes, and one advice from CC meeting, it has came to us, that is more academic session and more academic workshop. So I request our institutional branch to take up this matter, take more academic session for IPHA, and it will be pan-India. So I should mention that we have AIMS branch, Delhi AIMS branch, Rishikesh AIMS branch, Bhubaneswar AIMS branch. We already have all this AIMS branch. We have Chipmar branch, this Pondicherry branch, and FMC branch is in pipeline. So that will also have. So we have some big institutional branch, and I think we'll have a very good academic session. Our next is difficulties. I already told date changes and what type of mode of conference. About the quiz, I should mention this quiz we started in 2015 at Tirupati conference. 2014, Dr. Devki Nandan died, and 2015, in memory of Dr. Devki Nandan, our one of the biggest leader, we started this one, and the first time it was by UNICEF and WHO. They gave very good prizes. After that, we continued this, and it was actually IPHA headquarter function. IPHA headquarter, I must mention few names. Those who are for this quiz: Dr. Ribhu Basu, Dr. Anirban Dalui, Dr. Abhishek Dey, who has not come here, Dr. Kaushik Mitro. Other from Dehradun, Dr. Shaili, Mohammad Wasim Ansari, Malatus, and Dr. Sharon. They were regularly in touch. That's a pan-India team, and they were very good. Technically, they were very good, and it was very successful. 46, actually, 46 teams participated in this online quiz, public health quiz, and 4 were selected. Among the 4, 2 are the winner and runners-up. Winner FMC, Dr. Suraj Kapoor and Dr. Mandeep Kaur, and Jipmar, Dr. Janardhan and Dr. Prem Dhananjay. Okay, Dr. Dhananjay. I've just got the name from WhatsApp. So Dr. Dhananjay and Dr. Prem, we have runners-up medal with us. We'll confer this medal and certificate. Everybody will get the certificate, e-certificate. Even the organizer, they will get the certificate. So it was a very good session, very good conference. Obviously, we always, and we enjoyed our stay also. I think on behalf of my CC members, I thank organizer and JIPMA team, marvelous team. I must tell you, marvelous team. So please keep it up and be with IPHA and make the IPHA more stronger and long live IPHA. Jai Hind.
Thank you, ma'am, for sharing your experiences. We are really honored to be part of the team. Now I request Dr. Subida L., Additional Professor, Department of Preventive and Social Medicine, JIPMER, and also the Joint Organizing Secretary of IPHACon 2021 to deliver the words of thanks. Dr. Dhanajan and Dr. Prem, they're the runners-up of the quiz competition.
Forgot to tell you one thing. There is a trophy for the winner. That is a rolling trophy, and which is sponsored by Dr. Pankaja Varkar of Jodhpur AIIMS. Raghav. And that trophy is now in headquarters and will send to FMC with this medal.
Very good evening, one and all. It's my honor and privilege to propose the words of thanks. So we come to the close of the IPHACon 2021. It's been a great experience so far. So I was mentioning it's a team that helped it happen. So not only from our state branch, but also cooperation of the central committee and President sir and madam. So the list is long and endless, but I just try to put in the names as much as possible. So firstly, I would like to thank our President, sir, Dr. Sanjay Rai, and our Secretary General, Madam Dr. Sangamitra Ghosh. So both were very pleasant and approachable. So at any time, endless meetings, Zoom calls. I remember even sometimes it was late in the night. So minutes and hours together also we were discussing many things. So thank you all, ma'am and sir, for making it happen. So next, I would like to thank the Central Council members. So though your presence here actually has made it very, more realistic and lively for us. So, and for me, first time I'm having a feel of the association. So what it means for people of this stature coming together in a place and so trying to live this, the splendor of the organization, trying to uphold it high. So definitely that was also a great experience for us. Thank you for making it happen. Then I should definitely thank our state branch members, Pondicherry branch, with vibrant, and we have frequent meetings and workshops and other ways in which we try to collaborate. So definitely this was a major moment for us where everything happened together. So I should definitely mention the support of Dr. Anil Purti, our co-chair, and Dr. Kavita. Madam was she was the chair of the workshops. So, and other members as well, Dr. Kalai Selvan and others. So any meeting we call for, be it WhatsApp meetings or in-person meetings, they deputed coordinators from their colleges to help us through the proceedings. And frequently they were there to guide us, and whenever we wanted some counsel and some information, so they were always there for us. So definitely we would like to thank and honor them as well. So I'd like to also mention our cooperation and whenever we approach our Department of Health. So we had some program officers here who had attended the program in person as well. So thanks to them. Next, I would like to extend heartfelt gratitude for the pre-conference workshops team, so headed by Dr. Kavita and Dr. Palnivel. So they made it happen. A string of 11 workshops in a span of 2 to 3 weeks is no small task. So the team of residents, MPH scholars and PhD scholars, they made it happen. So, and also the eagerness of participation from the delegates. So it started from there. So many groups formed, and everything it's almost like organizing a mini conference for it. So they made it happen, and it was a wonderful array of scientific topics. So, and we had many good collaborations also that came out of it, in the sense like good networks and partnerships. So next, moving on to the orations. So I need not say more. So we had 3 splendid orations. We were fortunate to have 2 of them in person, and blessings of Dr. Nikesh virtually. So they upheld the moment. So it was really very nice for us. Thank you, sirs. Then coming on to the plenary session. So it was all of you already have mentioned 18 plenaries covering the most of the topics in public health. So it was definitely, we have to take some time to sit back and I mean, of course, technology helps us to sit and listen to all these sessions in person. So all of you saw how it was able to help us. So next, moving on to our knowledge partners. So we have put it up in our website as well. So it's a big list. So each of it, they had their own way in which they helped us, by either through workshops, through sponsorships, through plenary sessions, through advice and counsel. So definitely we'd like to thank our partners. So the World Health Organization, Minerva team from AIMS, the World NCD Federation again from PGI, the RCTC from PGI, ISAS from PGI, then the IDSI, the International Decision Support Initiative, the Health Technology Assessment in India, the branch, World Food Program, PHFI and IIHMR. We also had sponsorship from the Boston University Foundation of India to run a symposium. So we thank our knowledge partners, the Report India Initiative, the Boston Medical Center and the Rutgers. We also had a workshop which was conducted by JUMP organization, so JUMP team as well. So each of it was an experience in itself to collaborate with them and make this huge event happen. So we thank from the bottom of our heart our knowledge partners in this event. We also, you saw the call for proposals, so specifically from the WNCDF and from the RCTC, to encourage the budding researchers to put up, to get the feel of actually how it is to put a proposal and have that moment of elation when they win it, and then try to see with some guidance to complete it and take it to the next level. So we thank them for taking up this opportunity and providing us the same. Moving on to, again, the quiz. Dr. Rivubasu and the team did an excellent job, though they had the limitations of doing it virtually. We saw how good it was, and anyone everywhere could access it. So we saw that on the platform, we saw it on YouTube. You could again watch it any number of times. Thank you, sir. Moving on to the our internal team, I would start from our administration. Our sincere thanks to our Director Jupmar for not only allowing us to happen, but support from his side. So not only from our from the technical sessions where he was a part of 1 or 2, but also he helped us collaborate with Dr. Soumya and get her in for this for our inauguration. So I missed thanking Madam for her presence in the inauguration. Definitely elated the level of the conference. So Director's presence was felt throughout our organization. Thank you, sir. I must also thank our Dean Academic and Dean Research, our Medical Superintendent of the hospital, for extending their warm support. Also our HIS team, the telemedicine team, and our studio team. So our hybrid sessions were successful because of numerous, a type of trials that we had here. So they made it happen, Mr. Ramachandran and team, supported by Dr. Chitoria and Dr. Mahalakshmi. So many thanks for that. So then moving on to the our website. So website again was developed internally by our own one of our well-known person amongst us. So Mr. Praveen. So again, this it is a new thing for us as well from our end. So to host a range of domains in this think it was a great feat. Frequently kept on asking for revisions. So Mr. Praveen, thank you for all your support. And then our major people from VMNC. So this event happened and we were able to complete without any major hitch because of the support from our technical partners, our virtual partners, the VMNC team. Thank you, Mr. Pratik and Mr. Abhishek. I hope you can hear us. And they had for the 10 halls, when we said 10 halls, they said yes. We said one more day extra, they said yes. So they had 10 hall managers lined up for us. And well, it had its own timeline of events, starting from giving us a feel of how the platform is. And it was completely new for us, but they made it happen easily and effortlessly. So many trial sessions were run, and even the ending, every part they were very supportive. So thank you, Mr. Pratik and team. So again, I should mention Dr. Pradeep Agarwal's help in this. So he was helpful in actually guiding us through our interactions with our VMNC team and guiding us in the technical part as well. Thank you, sir. Again, our sincere gratitude goes on to our souvenir design and certificate design, Galaxy Enterprises, Mr. Dilip, food and catering partners, Grand Serena and A1 Caterers. Finally, I come to our internal team, our home ground. Thank you to all the faculty who've been an excellent source of support. Starting from, we had many committees, both with partners, with support from other medical colleges as well. So the heart of it was our scientific committee and the pre-conference workshop committee, our digital committee. So there were many other committees which did small roles, but a very crucial role, something they tried new, some social media committee. So special thanks to the registration and kit committee. So each of it was a very, though we say it is a hybrid or a virtual conference, but it has both an in-person meeting as well as this. So it was almost like running 2 races at the same time. So thank you all faculty. And at the heart of all of this is our strength and support our residents, our trainees and our scholars. So it was an experience, a great experience to, learn along with you. There were many hits, a few misses, but still thank you for all the experiences. Then I should not be forgetting our support staff. So there are many names, Mr. Ramkumar, Mr. Chandru, Mr. Ilai Perumal, our office staff, many others who helped us in this. So forgive me if I've missed any names. So I think I've finished my list. So thank you for bearing with me for this long. It's an emotional moment for us to make it happen through endless meetings. So it's been flash meetings, marathon meetings, Zoom meetings, in-person meetings. So till nights it used to go on. So we are at the end of it. So lots of WhatsApp groups and mail threads and Google Drives. So we've been through it in the last 2 to 3 months. As sir was mentioning, we have to go through a phase of de-addiction. But hopefully at the end of that, we'll be able to sit back and learn more from the experiences here, and the knowledge that we've gained slowly we'll be able to internalize more of it and build with the collaborations that we've started on. We've met a lot of new people, both in person and virtually. So hope we take it forward. So last thing though COVID was very harsh on us, the last 1.5 years, we've been speaking only about COVIDs and vaccines. But the last, I think 2 months, we've spoken more about other things than COVID. So let's go back to, again, fighting COVID. Thank you all for your presence here. Long live IPHA. Thank you, sir.
We have come to the end of Iphacon 2021. It was a wonderful experience working as a team and learn. So now, thank you everyone. Now we'll stand up for national anthem.
शुभ आशीष मागे
Hello. Hello.